عايزين نقعد بقى يا جماعة ونقفل الباب. الحقيقة بداية قوية جدا لمؤتمر اسم القلب. أنا يعني جسمي أشعر من يعني الكواليتي بتاعت الساعتين ثلاثة اللي فاتوا. فأرجو احنا عندنا النهاردة اليوم مش قصير، وعندنا نشاط علمي قوي جدا. ممكن نقفل الباب، نقفل الباب اللي ورا ده، نقفل البيبان. احنا عندنا، انا سعيد ان انا ابقى تشيرنج السيشن دي مع الاخ العزيز الاستاذ دكتور ياسر السيد، استاذ القلب في طب الازهر، والاستاذ دكتور محمد عبد الغني، استاذ ورئيس اسم القلب السابق في طب القاهره، وهو هيتكلم على اسبرين فري استراتيجي، وهو هيبقى ريبليسنج المحاضره بتاع الاستاذ دكتور هشام صلاح، والدكتور هشام صلاح هيتكلم بعد كده على طول. يلا يا دكتوره وفاء اتفضلي. وعايزين نقفل بقى الباب.
بس ما صارش هنا. هي هتصل طبعا حضرتك هتبقى دي نيكست ودي باك. ممكن من كمبيوتر ده الليزر.
يلا يا دكتور هشام تعالى جنبنا هنا. والدكتور محمد معانا استاذ دكتور محمد الرملي ويلا يا دكتور محمد اتفضل. دكتور محمد عبد الغني.
مساء الخير. This is the Sanofi symposium. I'm going to suggest a new strategy for you. Aspirin-free strategy beyond 1 year. All of us using acetyl salicylic acid for primary prevention. What about using alternative agent, B2Y12 inhibitor? Is it possible? Is it beneficial? This is what I'm going to explain in the following few minutes. Antiplatelet treatment, of course, is a cornerstone in patients following PCI. We all know that dual antiplatelet therapy is a standard care among those patients. What about an aspirin-free strategy in chronic maintenance treatment of patients of PCI after 1 year? When you do PCI for a patient, you estimate the hemorrhagic risk in what is called precise DAPT score. And accordingly, if the patient has high hemorrhagic risk or a score of 25 or more, this means that you should give him short dual antiplatelet therapy. After 1 year, you have to stop and risk stratify your patient according to DAPT score to evaluate the thrombotic risk. If it is less than 2, no need for dual antiplatelet, single antiplatelet is enough. So the concept is there. You can stop dual antiplatelet therapy after a certain time, whether short or long, and maintain the single antiplatelet therapy. Dropping aspirin, why? Of course, aspirin plus another agent equals more bleeding. Now we have another antiplatelet agents which we believe that they are more strong. They can do everything. And third, we have evidence-based that those agents may be enough as a single antiplatelet treatment. We have a long list of trials since 1995. But recently, there is a trend towards shortening the duration of the dual antiplatelet therapy and doing de-escalation, whether guided or not guided. And more recently, we have the aspirin-free concept among patients with ischemic heart disease maintenance therapy. And the guidelines are clear. You can stop dual antiplatelet therapy. You can stop aspirin after 3 to 6 months. This is 2A level of evidence A. The standard treatment post-acute coronary syndrome stenting is 1 year dual antiplatelet. However, if your patient has a high risk of bleeding, dual antiplatelets will be enough in the first 3 months, then continue with single antiplatelet. Very high risk of bleeding, now 1 month is enough dual antiplatelet and continue with single antiplatelet. So the concept is here, present in the guidelines and your daily practice all over the time. We have some recent trials evaluating antiplatelet therapy in coronary artery disease. We have global leaders trial, and we have Twilight trial, Smart Choice, STOP-DAP 2, and GLASS. We are convinced that single antiplatelet equals less bleeding, but they surprise that single antiplatelet carried same or maybe better thrombotic risk compared with dual antiplatelet. And this was a surprise. In the global leaders trial, principal investigator was Patrick Souray, and in the subgroup analysis of patients with acute coronary syndrome, yes, expected that we have less bleeding with single antiplatelet therapy. But what was not expected, that the death or myocardial infarction with single antiplatelet therapy was less than dual antiplatelet therapy. This was strange. Rosanna Mahran, during her presentation of the Twilight acute coronary syndrome, in her study, she maintained antiplatelet therapy for 3 months. After that, she compared single versus dual antiplatelet therapy. Of course, bleeding was much less with single. But what was not expected, that the thrombotic events were similar. There was no further protection with the dual antiplatelet therapy. So why giving dual? Why would not be satisfied with single antiplatelet therapy? Twilight acute coronary syndrome. When we put these trials together, you can see that if you consider bleeding, you have 40% less bleeding with single antiplatelet therapy. When you consider major acute cardiovascular events, you may have even better regarding thrombotic events. Capri trial is a very old trial. They consider patients with recent infarction recent stroke, peripheral vascular disease, and they compare head-to-head comparison clopidogrel versus aspirin. See the results, clopidogrel in the red bars. You have lower bleeding expected, but you have lower ischemic events with clopidogrel versus aspirin. This is a relatively new trial, the host exam trial. They took patients with PCI and follow up them till 1 year plus minus 6 months. Then patients were randomized to aspirin versus clopidogrel, head-to-head comparison, chronic maintenance therapy, clopidogrel versus aspirin. And over 2 years, there was the initial follow-up. Look to those patients. Actually, 50% of them had myocardial infarction, 30% had unstable angina, and the procedure was not simple at all. 50% has multivessel disease, 5% left main, bifurcation, 10% CTO. I mean, this is a complex procedure, and these patients were randomized to clopidogrel versus aspirin. Look to the results. The primary endpoint of all-cause deaths, MI, stroke, readmission, acute coronary syndrome, and major bleeding was better on clopidogrel patients. Clopidogrel was superior. There was 27% reduction by clopidogrel over 2 years. Reduction among bleeding is expected, 30%, but also, surprisingly, among thrombotic composite outcome, clopidogrel was more powerful, reduction by 30%. And this superiority was clear whether age patients, young versus old, body mass index, hypertension, diabetes, whether the complex PCI was there or it was simple, high bleeding risk or not, clopidogrel was more superior. What about the extension of this trial over 6 years? Again, the same results was clear. Clopidogrel versus aspirin was more superior, bleeding-wise and thrombotic event reduction-wise. And the recommendation was clear: clopidogrel monotherapy as compared with aspirin significantly reduced the risk of all composite endpoints, death, myocardial infarction, stroke, and bleeding. The beneficial effect of clopidogrel was observed in thrombotic composite endpoints. Panther trial is another trial conducted in South Korea. Large number of patients, open label trial. They compare head-to-head comparison. Aspirin versus B2Y12 inhibitor. The concept of using single antiplatelet agent for secondary prevention was beyond the design of this trial. And actually, this trial was conducted on all patients with ischemic heart disease, whether BCI patients, CABG patients, both BCI and CABG, or even in non-revascularized patients. Patients with a stroke was included, peripheral vascular disease. The primary outcome was clear. cardiovascular death, myocardial infarction, and stroke all was reduced more by the B2Y12 inhibitors compared with aspirin. They are very powerful preventive tools compared with aspirin. The reduction was around 12%. Number needed to treat was 123. And regarding major bleeding, there was no statistically significant difference between aspirin and B2Y12 inhibitor. However, when we go into details, we have less GIT bleeding and less intracranial hemorrhage. This trial actually proved that single B2Y12 inhibitor, whether clopidogrel or ticagrelor, can be used as effective secondary single antiplatelet therapy in secondary prevention of this patient. Thank you.
Thank you Professor محمد عبد الغني. بروفيسور محمد عبد الغني من المحاضرات اللي يعني بنسعد بيها ان حضرتك عندك انثوسيازم في اعطاء المحاضره، فبتخلينا كلنا صاحيين من اول دقيقه لاخر دقيقه. الانتي بليتلت طبعا يعني all antiplatelets in guidelines based on evidence based medicine and the large trial like Twale trial and all trial. What's the position of my question? Why is the position of individualization and يعني when I give aspirin 1 month, 3 months, 6 months, for 1 year with antiplatelet, is it still individualization?
For secondary prevention, still we have aspirin. الفكرة إن إحنا why not to escape aspirin وندي حاجة more potent. إحنا we do know that B2Y12 they are more potent with no bleeding risk in using these patients. Why not to maintain our patients with a more effective, more potent single antiplatelet. لما نقارن السنجل versus الديول definitely less bleeding. وكمان نفس الافيكاسي regarding thrombotic protection. Guidelines لسه ما اتغيرتش، لكن الديول antiplatelet therapy مع الوقت بتاخد shorter duration. escaping aspirin محتاجه ترايلز اكتر. البارتنر ترايل اتعملت في دوله واحده اللي هي ساوث كوريا وكانت اوبن ليبلد، مع وجود عده ترايلز انترناشونال وبرضه ديزايند بطريقه سليمه نقدر نقنع الجايد لاينز ان احنا نمشي على سنجل بوتنت B2Y12 inhibitor as a secondary prevention tool. Till now, guidelines considering aspirin as a secondary prevention agent.
دكتور محمد، I think انه ما فيش دواء في الطب خد البوزيشن بتاع الاسبرين the way that we know it. ما فيش عيان بيخش لك ويقول لك انا باخد اسبرين، ولما تيجي تموديفاي الاسبرين يقول لك يعني انا ما باخدش، مش مصدقين انه البرايمري بريفنشن خلاص الاسبرين ما بقاش له رول فيها. انه التغير ده حصل لانه في بدايه الثمانينات الاسبرين كان هو الوحيد اللي موجود مع حاجات تانية بسيطه جدا. لما ظهرت الايس انهبيتورز والاي ار بيز والستاتنز والاذر دراجز، اي ثينك انه الامور استدعت ان احنا نعيد تقييم الموقف بتاع الاسبرين. والاسبرين is losing a lot of its grounds. و I think انه حتى في السكندري بريفنشن women are not the same as men, young are not the same as older patients. واحنا بنشكر حضرتك وكانت محاضرة مهمة جدا. شكرا.
The second symposium, Survey Symposium, joined the fight by Professor Dr. Sameh Al-Affas.
مساء الخير جميعا. اشكر اساتذتي على التقديم واشكركم جميعا على الحضور. وتاني احنا في بيتنا وفي مكاننا ومؤتمر very dense in the scientific content. النهارده احنا بنتكلم على سيرفي سيمبوزيوم، والسلايد الاولى ممكن نبتدي. نعرض ازاي يا شباب؟ يلا بينا. اشكركم. ده بيقلب. تمام ممتاز. اوكي عظيم. طيب the title of the presentation is Win the fight and save more lives. التايتل ده مهم لأن hypertension as a risk factor and a disease, we have 37 million newly diagnosed hypertensive patients worldwide per year. So it is very prevalent and it is one of the most important risk factors in our daily practice that we need to do. Win the fight يعني ايه وsave more lives يعني ايه؟ السلايد دي مهمة جدا، وبدون الدخول في تفاصيل هي عبارة عن curves بتوري الانسيدنس اوف cardiovascular disease, heart disease, cerebrovascular disease، وفي 4 لاينز. أول لاين there is no hypertension. تاني لاين اللي باللون الأخضر is a treated hypertensive patient and he is controlled or she is controlled. اللاين اللي باللون الرمادي treated uncontrolled، واللاين الأحمر untreated. أظن واضح جدا. 2 lines converge and the other 2 lines converge. الاثنين ماشيين واضح جدا ان في 2 مصاحبين بعض، no hypertension and controlled treated patients، والاثنين التانيين treated but uncontrolled is almost the same like an untreated hypertensive patient. So this is very important. It is not just about prescribing a drug, prescribing treatment, and not looking for the goals and what we are really achieving by decreasing the blood pressure numbers. السلايد دي شهيرة جدا، مش عايز ادخل فيها في تفاصيلها برضو، ولكن هي السلايد بتاعة 2018 European Society of Cardiology Guidelines. هي عبارة ببساطة الانيشال ثيرابي ديوال كومباينيشن، وسبيشال لو كانوا سنجل بيل، وبعد كده تريبل كومباينيشن، ولو في ريزيستنت هايبرتنشن ستيب 3 ان احنا نحط سبايرون ولاكتون اور اذر دراجز. هي دي القصة، بس الوردنج هنا مهم قوي وعجبني قوي. أول حاجة البوكس الأحمر اللي على اليمين واضح فيه in the primary goal of treating hypertensive patients is achieving the blood pressure targets، وده مهم اللي بالارقام نوصل للارقام التارجت بتاعتنا، and reduction in the long term total risk of cardiovascular morbidity and mortality. ودي نقطة مهمة جدا، لأن في الآخر hypertension في حد ذاته is not actually a disease, it's a risk factor for cardiovascular morbidity and mortality. فبالتالي simply reducing the numbers without achieving reduction in this long-term morbidity and mortality is actually we are not reaching what we are trying to do. بما ان احنا اتكلمنا عن and نتكلم عن or. الأور هنا فين؟ ان في الجايد لاينز كاتبين دايما اول ستيب ACE inhibitors or angiotensin receptor blockers. فده بيدي ايحاء ان هم equal، والحقيقه انا اعترض شويه على هذه النقطه، يمكن هنشوفها في البرزنتيشن. فالاجنده بتاعتي النهارده حاجتين، احنا التارجت بتاعنا is lowering blood pressure numbers and achieving reduction in cardiovascular morbidity and mortality. نمرة 2 ACE inhibitors و ARBs are they really or ولا في أفضلية عن فصيلة من هذه الأدوية. نبتدي على أول حاجة achieving blood pressure targets. الجايد لاينز واضحة وصريحة، وإن احنا ناتشيف ذا بلاد بريشر تارجت اللي كل شوية ابتدى ينزل ويوصل لأرقام بقينا نعتبرها الحقيقة كانت صعب الحصول عليها زمان، بس الحقيقة كل ما نوصل ل a lower blood pressure target this is better، زي ما احنا شفنا في السبرنت ترايل. و the faster we reach this target ده أفضل وأفضل، إن احنا بالكتير within 3 months نكون وصلنا ل our blood pressure target. وأخيرا ودي نقطة مهمة جدا the long-term control, the sustainability of the control of the blood pressure numbers. Consistency is important, consistency throughout the day, consistency throughout the treatment journey. Nighttime blood pressure is really important, والvariability again is really important، وهنشوف ده حالا. الكلام ده ابتدينا فيه وعرفناه من فترة طويلة قوي من الاسكو ترايل. الاسكو ترايل كانت هيد تو هيد ترايل بين 2 combinations الاتينولول والثايزايد versus الاملوديبين والبريندوبريل، وزي ما احنا شايفين هنا في السلايد دي the time course والnumbers are almost identical. It is similar reduction in the brachial blood pressure, but the outcomes were totally different. There was definitely significant reduction with the arm of amlodipine perindopril versus the arm with atenolol thiazide على long term. الحقيقه الاستادي دي كانت من الاستاديز اللي خلت الاتينولول، ومش بس الاتينولول، اغلب البيتا بلوكرز تاخد صف تاني في علاج الهايبرتنشن الا في مواقف معينه زي ما احنا عارفين من الجايد لاينز. بس ده جاي منين؟ للارقام اللي احنا هنشوفها دلوقتي. ان البريندوبريل املوديبين combination as compared to atenolol thiazide ادى الى reduction in the central aortic pressure as compared للاتينولول thiazide. نمره 2 the blood pressure variability was much less with perindopril amlodipine, and the night blood pressure again was much more in control with the perindopril amlodipine combination. So basically, what we are seeing here is the reason beyond the outcome benefit of using a combination versus combination. It is not just about the numbers that you get in the office, a good number that is compliant with the target of the guidelines, but again you have to be smart, thinking that what I'm trying to do here is not just numbers. I'm trying to offer my patient better reduction in the cardiovascular morbidity and mortality, so not all the molecules are the same. This is a very important slide. This is a combination of trials, the trough to peak ratio, which basically means how long out of the 24 hours is the drug effective and it's doing its job. زي ما احنا شايفين واضح جدا ان اول 3 molecules almost بيغطوا 100% of the 24 hours are the perindopril, amlodipine and indapamide. Other drugs that are very common in our daily practice هي زي ما احنا شايفين برضو مش واصلين لأطراف peak ratio that is convenient to provide adequate blood pressure control over the 24 hours. And again, this is really important ان احنا لسه شايفين من الاسكو trial in control الsustainability ونقلل الفاريابيليتي in the blood pressure numbers ونقلل النايت تايم blood pressure is really important in affecting the outcome, the morbidity and the morbidity of the patients. يمكن هنا بيحضرني دايما الهيدروكلوروثايزايد 33%، يعني almost تلتين اليوم it is not there, it is not really effective، مع انه اشهر مولكيول كدايوريتك موجود في الانتي هايبرتنسيف كومباينيشنز. طيب نمسك مولكيول البريندوبريل، ان احنا نعمل راس انهبيشن is are all the molecules the same. البريندوبريل الحقيقه بيتميز بحاجات، والحاجات دي in my practice بتهمني جدا، ان احنا increasing the dose does that translate to an equivalent reduction in the blood pressure numbers. ده دايما التاثير اللي بيجي لنا او الفكره اللي عند اغلب العيانين، ان انا لما اقول لمريض انا خدت كذا، او حتى مريض حاسس ان ضغطه مش مظبوط فياخد حبايه زياده، فهل ده معناه ان هو هياخد double the effect؟ This is not really the story. يمكن البريندوبريل متميز في كده in increasing or doubling the dose we can reach up to negative 30 millimeters mercury of reduction in the blood pressure. And again, this is not evident with some of the molecules that you can see here, up to increasing, for example, telmisartan up to 80 milligrams. There is only negative 14 millimeters mercury of blood pressure reduction. So again, perindopril is a very good, as we have seen before in the previous slide, a very good trough to peak ratio that covers almost 100% of the 24 hours. And number two, that increasing the dose can actually lead to much increase in the control of the blood pressure than the initial dose. Amlodipine, ده our favorite kid on the block اللي احنا بنحبهم وبنستخدمهم in the combination, and it's almost موجود في اغلب ال combination of most of the antihypertensive drugs. Combining perindopril and amlodipine، احنا هنا السلايد دي عباره عن كل مجموعه عباره عن 4 بارز. اول 2 بارز بنستخدمين البيز لاين كومباينيشن 5/5 فور اكزامبل مع البريندوبريل املوديبين، والاثنين بارز التانيين استخدام ال 10/10، والاثنين بارز التانيين دول في كل جروبس هم اللي كان ضغطهم من الاول اعلى بكتير، اللي هو فوق ال 180 ملم ميركوري سيستوليك، وده موجود في كل المولكيولز او كل الكومباينيشنز. زي ما انتم شايفين simply that we increased the dose of the perindopril and the amlodipine to 10 over 10 from 5 to 5, we can achieve up to more than 63 millimeters mercury reduction in systolic blood pressure. So this is again very significant. When you increase the dose, you get a very important decrease in the blood pressure number. And again, this quicker and better blood pressure control that is compliant with the target of the guidelines. اخر حاجه بقى في الكومباينيشن التريبل كومباينيشن بتاعنا اللي بنتكلم عليه النهارده الاندابامايد. This is really magical when you add these. السلايد دي باديه من عيانين مرضى هايبرتنشن بياخدوا ادويه كويسه ACE inhibitors amlodipine, ACE inhibitors hydrochlorothiazide, ARB amlodipine وARB hydrochlorothiazide, and they were not reaching the blood pressure target according to the guidelines. Simply shifting these patients, whatever the starting combination, to that triple combination resulted in almost 91% of the patients included in this meta-analysis reaching the blood pressure target as per the European Society of Cardiology. So again, it is not just about combination. You have to think about the molecules in the combination. When you add different molecules, you act on different systems behind the blood pressure increase, so you get much increase in the improvement in the blood pressure number and improvement in the outcome, as we will see now. So the other part is morbidity and mortality. Are all molecules the same in decreasing the morbidity and mortality, ACE or ARBs? دي ميتا اناليسيس لطيفه جدا من 2012 بتقارن بين الايس انهبيتور ترايلز اند ذا ارب ترايلز regarding the all cause mortality, the hazard ratio for all cause mortality. As we see here, ACE inhibitors definitely have an edge in the reduction in all cause mortality as compared to ARB trials. And these are led mainly by the trials that contain perindopril, the ASCOT and the ADVANCE and the HEVNET. So basically, again, it is not just about the numbers. Choosing the molecule can translate to an outcome benefit, as we can see here, the all-cause mortality benefit as compared to using ARBs, for example. Another important endpoint that we are trying to prevent or protect our patients from having, the hypertensive patients, is myocardial infarction. And again, as we can see here, when we compare the trials with the ACE inhibitors and the ARBs, أنا عارف معلش الكلام مش واضح شوية، بس trust me, in these trials, whether بالperindopril or elanapril, led to reduction in the incidence of myocardial infarction in hypertensive patient, and this was not there in the ARBs trial. I'm not saying ان الاربز وحشين، انا مش قصدي كده، ولكن الاربز بالمناسبه ممكن يكون عندهم تفوق في نقط معينه زي الرينال بروتكشن، ولكن تاني احنا استخدام molecules, a molecule that has been there for that long and it is effective and it has a lot of evidence standing behind it in reduction of cardiovascular morbidity and mortality is definitely worth ان احنا نفكر هم ليه مستمرين معاه لغايه النهارده بهذه القوه. اخيرا بقى رينال بروتكشن، الايس انهبيتورز واربز دي من النقط اللي دايما بتخوفنا من استخدام الراس انهبيتورز in general. Actually these molecules provide renal protection as we all know. الادفانس trial for example هنا it was a very big trial, more than 11,000 patients. We can see that the reduction in the blood pressure translate into reduction in microalbuminuria, reduction in the renal events versus control that was statistically significant. And although we can see that with other types of molecules زي ما احنا شايفين في الجدول, but again this did not translate into mortality benefit except with perindopril in the advanced trial. So this again translated into guidelines. Randomized controlled trials are the basis of the guidelines. زي ما احنا شفنا في اول واحده تحت الهايبرتنشن guidelines قالت ACE inhibitors or ARBs or ده او ده head to head. بس الحقيقه لما نفكر in that particular patient, عيان عنده diabetes, عيان عنده chronic coronary syndrome, عيان عنده myocardial infarction, عيان عنده heart failure, لو هنفكر فيهم زي دول زي ما يكونوا secondary prevention in a hypertensive patient that developed already a cardiovascular morbidity, there is no doubt that ACE inhibitors in all these guidelines has the upper hand over ARBs. And ARBs are always mentioned if the patient cannot tolerate the ACE inhibitors. و cannot tolerate دي الحقيقة in our practice دايما بتصب في أغلب الأحيان للقف. I advise you all and advise myself ان احنا نفكر في الكف in an ACE inhibitor prescribed patients very well. لان الحقيقه في ميتا اناليسيس لطيفه للاسف معيش السلايد بتاعتها بس طلعت ان الانسيدنس اوف كف with ACE inhibition is almost 13%. بالنسبه انا خلصت خلاص انا اخر نقطه بس. 13% is a very big number. في ميتا اناليسيس ثانيه كانت بتطلع 3 to 4%. بس لما عملوا بلاسيبو كنترول اكتشفوا ان اغلب اسباب الكف في العيانين واخدين ACE inhibitors كانت اكشولي بسبب اخر زي smoking زي heart failure worsening زي اسباب اخرى. ف when we face cough in an ACE inhibitor treated patient we have to stop and evaluate the whole patient. هل في سبب اخر ممكن يخلي الكحه زايده ولا لا؟ لان again for example in a heart failure patient ACE inhibitors has a very good impact on the outcome. So we'll not lose that a very strong tool in reduction in the morbidity and mortality بسبب a minor incidence زي cough خصوصا ممكن يكون ليها سبب اخر. اشكركم شكرا جزيلا.
شكرا يا سامح. Very elegant and informative talk. معلش no time for discussion عشان احنا we are very late. دكتور وليد عمار سيرفيه سيمبوزيوم برضه هيكلمنا عن الإيفابرادين before discharge in acute heart failure.
بسم الله الرحمن الرحيم. شكرا اساتذتي الكرام وشكرا شركه سيرفيه على دعوتها الكريمه وشرف لي ان اكون معاكم النهارده ونتكلم عن very important topic هو related للهارت فيلير. زي ما الدكتور محمد قال كده هي فكره اللي احنا how to control with the importance of controlling heart rate in patients recently admitted with acute decompensated heart failure. In brief, we all are aware about the burden of heart failure. We are speaking about a worldwide prevalence reaching about 20% of adult population of a heart failure. It's the number one cause of hospital admission in people at the age of 65 and above. And this onset of hospital admission for patients with heart failure is a very critical point in a disease story because 30% of patients who are hospitalized with heart failure are going to be readmitted in the next 3 months. And 30% of these patients will die in the first 1 year. Therefore, every pillar of heart failure treatment should be instituted as early as possible because we have a very critical period early after hospital discharge because all the catastrophic endpoints will occur very rapidly in this critical period. And this figure shows the importance of the marker of poor outcome in the first year after hospital discharge. Patients who are discharged with a heart rate above 85, for example, compared for those with heart rate below 64 are associated with an increased mortality by about 41%. 41% were related to a higher heart rate at hospital discharge. Therefore, it's important to look at heart rate at hospital discharge for your patients with heart failure. This paper related to our Egyptian population dealing with the demographics, clinical characteristics of patients hospitalized with heart failure in Egyptian population. As you can see, the median heart rate at hospital discharge for our patients around 100, sinus rhythm. And the 1-year mortality of our patients about 26%. Therefore, we have a high 1-year mortality and we have high heart rate at hospital discharge. It's an important endpoint that we should tackle in management of heart failure. This is an extremely important slide. This is evolution heart failure. 270,000 patients in best of evidence class countries in Sweden, Japan, and United States to address to what extent guideline directed titration of beta blockers after 1 year. 25% discontinuation rate and less than 10% of our patients in these countries achieved a target heart rate or a target dose of beta blockers, less than 10%, while the majority of patients on beta blockers were still on a starting dose or a small dose or on best hands moderate dose of beta blockade. Therefore, we have a problem in up titration of patients with heart failure to all guideline-directed medicine therapies, especially for beta blockers. Why we have that? Simply because beta blockers in the early phases of heart failure treatment are associated with transient reduction in stroke volume, maybe hypotensive effects, and so on. However, after 3 months, we have tremendous change and improvement in stroke volume and ejection fraction. But the early critical period in the first months of acute heart failure treatment with beta blockade, we have some reduction in stroke volume, and this may prevent up-titration or poor tolerance to beta blockade. And the difference between ivabradine and beta blockers in this critical period. Ivabradine, as a selective current inhibitor for the AC node, just affects the heart rate. We have an improvement in the stroke volume that compensates for a preserved cardiac index and the cardiac output in the first weeks of treatment. And this may give an early superiority from a hemodynamic profile for patients with acute heart failure on beta blockade versus ivabradine. The guidelines for treatment of heart failure, as we all know, we are about, we have 4 pillars we have to start. We have to start these patients as early as we can. ACI or ARNI, beta blockade, MRA, and SGLT2 inhibitors. Most of the trials that made the difference guidelines representing patients on chronic heart failure. However, we have evidence for much of these trials, for these molecules, for early initiation just before or after hospital discharge. For example, for ARNI, we have transition and the pioneer heart failure. For empagliflozin, we have the IMPULSE trial. All these trials are trying to address the early critical period in the management of patients recently hospitalized with heart failure. If these patients were not well controlled in the 4 pillars and they are not candidates for a device therapy, CRT or ICD, and they are in sinus rhythm with a resting heart rate above 70, here it is initiated ivabradine as a class 2A recommendation for these patients with reduced ejection fraction. Ivabradine was implemented in the guidelines based on the famous landmark SHIFT trial. However, the SHIFT trial recruited patients hospitalized within the previous 1 year, and patients who were hospitalized within the previous 1 month were excluded from the trial. The fact number 2 is that about 3/4 of patients hospitalized and discharged with heart failure have a high heart rate above 70. And these 3/4 of patients with higher heart rate are associated with higher readmissions, higher mortality, and higher costs, of course. Therefore, we have a clinical unmet need that is optimization of heart failure in the post-acute phase of heart failure with reduced ejection fraction. This is a crucial issue. We have limited evidence, but now we have more evidence. The evidence that I am going to present is a live study. This study has been presented 1 year ago. It addressed the association between ivabradine and the adverse cardiovascular events in acute decompensated heart failure. It is a retrospective trial trying to address the safety and tolerability and the beneficial effects of ivabradine in such situation. About 900 patients with a discharge heart rate about 86. They received all the standard of care therapy, beta blockade, ACE inhibitors, sacubitril, valsartan, or MRA. Patients were either allocated to ivabradine or standard of care therapy without. At follow-up, we have 1 year follow-up, we have 55% relative risk reduction of cardiovascular mortality in patients who received ivabradine compared to standard of care therapy, and we have 52% relative risk reduction of all-cause deaths in patients who received ivabradine. Very, very important evidence. What about frequency of hospitalization? If we initiated ivabradine early after hospital discharge, we have 27% relative risk reduction in the frequencies of hospital readmissions, either in the 6 months or at 1 year follow-up. And this evidence is not the first time to have. We have a subgroup analysis, which is very important from the SHIFT trial. We know that many patients at SHIFT trial were rehospitalized during the follow-up. And we focused on subgroup analysis, patients who were hospitalized during SHIFT trial and at discharge were allocated either to ivabradine or standard of care therapy, including beta blockers. And we followed these patients over the next 3 months. We have 30% relative risk reduction with ivabradine compared to standard of care therapy for hospital readmission, which starts early, just 1 month after hospital discharge. Very strong evidence in favor of ivabradine early after hospital discharge. Ivabradine was associated with significant reduction in heart rate, significant improvement in NYHA class without effect on systolic blood pressure, as you all know. This is an important fact that I would like to address again. it is beneficial to start ivabradine with beta blocker. Is this helpful for the patients? This is a prospective study addressing this issue. As you can see from this figure, it's beneficial to add ivabradine, and you can achieve earlier and higher titration of beta blockade in the presence of ivabradine. This means that if you start both together, ivabradine plus beta blockade, you can achieve higher doses of beta blocker while on ivabradine compared on beta blockers alone. Very good evidence in such. Actually, ELIO was not the only trial to address these points. There's another evidence from Optimized Heart Failure Care Program. The same concepts, patients who were discharged on a combination of beta blockade plus ivabradine compared to beta blockers again. After 1 year follow-up, we have significantly lower all-cause mortality and heart failure hospitalization, significantly greater improvement in quality of life, and very important as the last, significant achievement of beta blocker target dose in the presence of ivabradine compared to standard of care therapy. However, all these trials are retrospective in nature, despite being very respectable. We have a prospective ongoing trial to address this topic, efficacy of early initiation of ivabradine treatment in patients with an acute heart failure. This is a SHIFT acute heart failure trial. It's recruiting patients. It's ongoing, very well controlled, placebo controlled, multi-center randomized trial. Finally, my dear chairpersons, my take-home message is clear. Ivabradine is helpful in patients recently hospitalized with heart failure. It's vital and important to initiate ivabradine early as much as you can. It's beneficial in systemic. Of course, it's beneficial in chronic setting in ambulant patients with heart failure. It decreases hospitalization, and we have some evidence of combined endpoints reduction, especially in patients while on beta blocker. It has semi-synergistic effect, and thank you very much.
شكرا يا دكتور وليد. محاضرة مهمة جدا. خليني بس قبل ما اقول كومنتس، هو في حد من النواب موجود في الميتنج النهارده من نواب الاسم؟ ولا هم غالبا في الرعايات ولا لا؟ انا بس جاست انا يعني هل كريم البكري موجود؟ انه كان في ما انا عارف كريم كان معايا في حاجة قريبة وقال لي دكتور حسام احنا كنا بنعرف العيان بتاعك لما يخش الاسم من ضبط الهارت ريت. فالحاجه اللي تقدر تظبط بيها الهارت ريت اكيد هي الايفابرادين، لانه لما بتزود البيتا بلوكرز في ليميتس للانكريز للدوز افكت على البلاد بريشر بيبقى يعني واضح. انت لما بتنيم العيان على ترابيزه القسطره وداخل بيه حتى لو كانت قسطره دايجنوستيك وهارت ريت 100 او 110، قصه مختلفه تماما عن ان العيان يبقى نايم على ترابيزه القسطره والهارت ريت 60 70. فالنقط اللي قلتها يا وليد في غايه الاهميه، وان هو يتاخد بري ديسشارج حاجه اي ثينك انها تفرق جدا في البراكتس، وان قبل الاستادي دي امشور عدد كبير مننا كان بيعمل كده. عايز اسمع راي الدكتور هشام صلاح في القصه دي. واخر حاجه انه الكومباينيشن بتاع الكارفيدولول والايفابرادين اي ثينك انه مع الدوزجز اللي يعني محطوطه بيها الكومباينيشن دي فرق جدا في البراكتس، خصوصا انه عندك براند من الكارفيدولول which is not. انا عارف ان في كارفيدولول لوحده موجود في سوق جينيركس، انما ده هنا you have كارفيدولول from a company زي سيرفيه، واحنا عارفين ان هم بيهتموا جدا بالكواليتي بتاعه الموليكيولز مع another very important molecule اللي هي ايفابرادين. بتشوف ايه دكتور؟
سؤال حضرتك على ايه يا دكتور حسام؟
على هاو دو يو فيل في البراكتس الايفابرادين انه يظبط مهم انك تخش القسطره والعيان نايم على الترابيزه هارت ريت مظبوط ولا ما بتفرقش؟
Definitely it's very important سواء في القسطره او بره القسطره. Having the heart rate controlled is one of our very important goals. لان الحقيقه ممكن جدا يجي لك عيان ضغطه 160 على 100 عالي اهو، بس هو اهم حاجه ان هو بيبقى ممكن بيشتكي ان ضربات قلبه سريعه او حاسس انه مش مرتاح. تكنترول البلاد بريشر وتنزل بيه ل 130 80 وتلاقي العيان still not very comfortable. ليه؟ لانك you left one very important point which is heart rate control. وعشان كده هنلاقي ان الجايد لاينز بتتكلم على الهارت ريت وحطها كواحد من البوينتس اللي لازم نتشيك. ده الجايد لاينز بتاعت الهايبرتنشن بتتكلم على تشيكينج الهارت ريت في كل عيان بنشوفه.
احنا عملنا استادي قارنا الناس اللي داخلين القسطره بالهارت ريت في الرينج بتاع 60 بلس ماينس 10 بالناس اللي داخلين هارت ريت ب 90 وكان في فرق في الاوت كم واي ثينك كانت فيري امبورتنت ستادي واتنشرت في انترناشونال جورنالز.
في الاسكيميا ترايل كلمه اوبتمايزد ميديكال تريتمنت معناها انك تحط الهارت ريت من 50 ل 60 في العيانين اللي عندهم كرونيك كوروناري سندروم. How to achieve this goal? We have to use our tools, beta blockers والإيفابرادين. الارت ان احنا نستخدم الإيفابرادين ازاي وامتى ده حاجه مهمه جدا وده جزء من السكيلز بتاع اي كلينيشن بيعالج الاسكيميك هارت ديزيز.
I think ان it's time to move في البروجرام. شكرا دكتور وليد. It gives me a great pleasure to introduce أخوي العزيز الأستاذ دكتور هشام صلاح to be presenting data على الانترستو in heart failure patients across the spectrum. We know very well إنه الأستاذ دكتور هشام صلاح is one of our best speakers. He has a great control on التوبكس اللي هو بيتكلم عليها وعشان كده أنا برضو كنت مهتم إنه أنا عارف إنه ممكن النواب يبقوا مزنوقين في الشغل بتاع الرعايات بس this is the day that we need our younger colleagues to see how can we deal مع المحاضرات. اتفضل دكتور هشام.
Mr. Chairman, thank you very much for your kind introduction. The topic I'm going to discuss is Entresto across the spectrum in heart failure, a story of impact. والحقيقة heart failure ده مشكلة كبيرة جدا. It has different stakeholders perspectives. واحنا كphysicians هنلاقي ببساطة شديدة we know for sure that heart failure has a progressive nature. And that patients can never be perceived as stable at any time. احنا بنتابع عيانينا واحيانا بعض العيانين دول بيكونوا functional class 2 ونبقى احنا مبسوطين والعيان مش متضايق قوي ونلاقيه all of a sudden he arrests and dies. وبالتالي فكرة stable ولا unstable دي ما بقتش نقطة قوي بنتكلم عليها، بنتكلم على compensated heart failure أو decompensated heart failure. وheart failure is definitely a major health problem. لأن quality of life is significantly impaired in these patients. تقريبا 3/4 بيstruggle to perform their daily activities. هنلاقي إن تقريبا تلتينهم report symptoms that are consistent with depression. On the other hand, واحدة من أكبر المشاكل اللي بتواجه هؤلاء هي الهارت failure hospitalization which is very frequently repeated. لدرجة احنا بنقول إن تقريبا 44% of patients are rehospitalized within just 1 year. واحدة من أكبر المشاكل اللي بنشوفها أما العيان بيخرج من المستشفى هنلاقي إن تقريبا ربعهم بيبقى re-admitted again علشان هارت فيلير. طبعا جزء من المشكله بيقبع في ايدينا احنا. عدم تظبيط الدايوريتك دوز على سبيل المثال قبل الخروج بنبقى مدينهم مثلا لارج دوزز اي في دايوريتكس في الرعايه ونيجي مخرجينهم على سمول اورال دوز. فطبعا ده واحده من الاسباب اللي بتخلي العيان يرجع تاني rapidly. واكيد mortality is the thing which we all are afraid of. 50% of patients having heart failure die within 5 years. And this is in spite of the advances in the medications that were present at the time we are talking about. وبالتالي, given these facts, a new treatment modality was needed. ويمكن حاجة من الحاجات اللي عملت يعني فعلا a breakthrough كانت البارادايم study اللي اتنشرت من حوالي 9 سنين والاستادي ديت كانت على angiotensin neprilysin inhibitor versus enalapril في عيانين الهارت فيلير. والريزلتس بتاعت الاستادي كانت very impressive. ليه؟ لأنها كانت on top of the best available medications at that time. اللي حصل إن الجروب اللي خد sacubitril valsartan had an improvement and a reduction of 20% in cardiovascular death or heart failure hospitalization. there was as well 20% reduction in cardiovascular death, 21% reduction in the risk of first heart failure hospitalization, and a 16% reduction in the risk of all-cause death. فأرقام الحقيقة كويسة جدا given the fact that the patients were already taking the best available medications possible. وبالتالي sacubitril valsartan, according to this study, was superior to ACE inhibitors in reducing risks of cardiovascular death and heart failure hospitalization. طب هو بيعمل كده ازاي؟ طبعا بعدها ابتدى يظهر ترايلز، ومن ضمن الترايلز ظهر لنا بوضوح that this medication has the capability of improving the ejection fraction. لدرجة ان 25% of subjects experienced a left ventricular ejection fraction increase of 13 or more points at just 12 months. طبعا رقم احنا مش متعودين عليه خالص، لان احنا مش متعودين ان يحصل a significant improvement in ejection fraction بالطريقة دي. With this, there was also as well a reduction in end-diastolic volume index as well as a reduction in end-systolic volume index. كلهم بيحسنوا outcomes of the patient، وطبعا حصل بالإضافة لكده a reduction in left atrial size, a reduction in electrical instability، ويمكن ده واحدة من الحاجات اللي مخلية في some reduction in sudden cardiac death in such patients. وبعدين ابتدينا نفكر، احنا كنا بنتكلم على chronic heart failure، ابتدينا نفكر كمان في acute decompensated heart failure. فجات لنا ترايل بتشوف هل العيانين after stabilization can we start sacubitril valsartan before discharge or not. فلقينا ان ال outcomes of such patients ان احنا قادرين up titrate the dose ونصل بيها لل 200 مللي جرام في جزء كبير من العيانين، سواء we started the doses in hospital or just after discharge. وبالتالي جنت المفاجأة ان initiation of sacubitril valsartan in a wide range of heart failure reduced ejection fraction patients early after acute decompensated heart failure event in hospital or shortly after discharge was feasible and overall well tolerated. جات لنا البايونير هارت فيلير بعدها وبينت لنا ان الهارت فيلير rehospitalization was reduced by approximately 46%, and this was quite impressive. وقلنا ساعتها according to the results of the trial that sacubitril valsartan titrated to target doses based on systolic blood pressure should be considered first-line therapy for patients with acute heart failure reduced ejection fraction. وبالتالي given all these facts ابتدى يبقى فيه a clear indication of giving this medication والguidelines كلها اتغيرت، وجه في 2021 and for the first time sacubitril valsartan provided a treatment option for a long-standing no treatment disease ألا وهو heart failure preserved ejection fraction. وجه a new FDA indication talking about ARNI is the first heart failure therapy with an FDA-approved indication that includes patients with preserved ejection fraction. طب جت الحكاية دي منين؟ جت من the famous Paragon heart failure trial. والحقيقة إنه there was a 13% reduction in the risk of primary endpoint, which did not achieve a statistical significantly p-value, which was missed by only 7 patients. ولكن given the clear advantages that were seen, they thought that this should be considered as a very good sign. أما جم عملوا subgroup analysis in this study, لقوا إن هم there are 2 subgroups which actually had significant benefit. One of this group were patients with an ejection fraction up to 57%, in which there was 22% relative risk reduction in the composite primary endpoint. The second group that had a significant benefit were females who also had a 27% relative risk reduction in the primary composite endpoint. زي ما احنا شايفين هنا كان واضح انه تحت الخط الاحمر ده line of unity that patients up to almost an ejection fraction approaching 57%, there was still significant improvement in these patients. عشان كده some of the experts in the field of heart failure نزلوا مقالة قالوا فيها that despite narrowly missing statistical significance for its primary endpoint, the Paragon heart failure data were compelling enough to justify expansion of the current indication of sacubitril valsartan to include patients with heart failure whose ejection fractions were less than normal but above the range currently used to define heart failure with reduced ejection fraction. ده from a physician perspective. طب من ناحيه العيان بقى from a patient perspective بتهيألكم العيانين interested in ايه؟ اكيد عايزين يعيشوا كل حاجه، ولكن واحده من البوينتس المهمه هي الكواليتي اوف لايف. واحنا عارفين انه 3/4 بيستراجل to perform the daily activities، تلتينهم تقريبا report symptoms زي ما قلنا related to depression. Almost more than 60% report difficulty with recreational activities with sports or hobbies. وحوالي 40% they struggle to socialize. وبالتالي the quality of life is something extremely important to each and every patient. ويمكن واحدة من الحاجات اللي طلعنا منها من البارادايم هارت فيلير ستدي كانت الكواليتي اوف لايف. لما جينا نشوف الكانساس سيتي كارديوميوباثي كويشنير لقينا انه the overall difference in the score for physical and social limitations in patients treated with sacubitril valsartan was comparable لحاجة غريبة جدا to a difference of approximately 9 سنين. يعني العيانين اللي خدوا ساكوبيتريل فالسرتان تقريبا كأنهم صغروا 9 سنين لما خدوا هذا الدواء in comparison to those who were not taking such a medication and were still maintained on ACE inhibitor. ومش بس كده، واحدة من النقط الهامة جدا ان العيانين دول الاستفادة حصلت quite early لدرجة ان ال p-value became significant just after 14 days. ويمكن بعضكم او اغلبكم حضراتكم اكيد بتستخدموا هذا الدواء هتكتشفوا انه in many of the patients، ويمكن دي حاجه انا استغربتها جدا في العيانين الانبيشنت، الاقي العيان بعد ما ابتدى الدواء بيوم او يومين ابتدى يحس بتحسن واضح، بالرغم ان هو راجل مزمن عنده هارت فيلير بقاله سنين ومتعود على يعني انه ممكن يتحسن شويه او لا، ولكن it is clear that giving such medications in many of the patients there is significant improvement in the quality of life. On the other hand, حتى في الهارت failure preserved ejection fraction patients do improve significantly when given such medication. وبيحصل ان dyspnea on exertion during follow-up of such patient was significantly improved. وحصل improvement in dyspnea on exertion early and was sustained across the taking the medication course. في الباراجون هارت فيلير اللي هم الناس اللي عندها هارت فيلير with preserved ejection fraction حصل برضه significant improvement in the New York Heart Class بتاع العيان، وفي نفس الوقت الكانساس سيتي cardiomyopathy questionnaire was also significantly improved in such patients. نيجي بقى finally to the third stakeholder اللي هم الهيلث كير سيستم. وطبعا في الهيلث كير سيستم هم عايزين العيانين يتحسنوا، بس في نفس الوقت مهتمين بخصوص كميه الفلوس اللي ممكن تدفع. احنا عارفين on the other hand ان مثلا في 2012 the total amount of money spent overall worldwide for the management of heart failure was approximately $108 billion and expected by the year 2030 to increase by more than 100%. 70% of the cost is due to heart failure hospitalization. ودي نقطة في غاية الأهمية. فجم عملوا some cost effective analysis فلقوا الآتي إن whatever the country, if we are talking about بلاد غنية زي الدنمارك أو بلاد low income زي كولومبيا، لقوا إن الاستفادة للعيانين was cost effective in both. On the other hand, giving such a medication في عيانين الأكيوت heart failure برضو كان very cost effective in such patients. With the findings suggested that for patients with heart failure, reduced ejection fraction, initiation of this medication during hospitalization may be associated with reduced hospitalization, increased quality of life, with adjusted life expectancy. وبالتالي لما نيجي نبص بقى للامريكان جايد لاينز بتاعت الهارت فيلير هنلاقي الجمله دي مكتوبه، وهم بيهتموا جدا بقصه الايكونومكس of giving the medication. فكاتبين مثلا in patients with chronic symptomatic heart failure reduced ejection fraction treatment with an ARNI instead of ACE provides high economic value. طب why do they endorse the use of the medication في عيانين الايجكشن fraction more than 40%؟ لان هم جم حسبوها كده لقوا ان هم لو ادوا 1.8 million patient هذا الدواء this will prevent or postpone as many as 180,000 worsening heart failure events، واحنا عارفين ان الايفنت heart failure hospitalization بحد ذاته is quite costly. الحاجة الكويسة ان الميديكيشن is available in Egypt not only on the private sector level ولكن موجود في التأمين الصحي، موجود في الببليك دومين، وموجود كمان مدعم بطرق مختلفة و PSP programs and so forth. وبالتالي I think we can now be offering this medication. My final slides is that the implications of such studies on the guidelines هنلاقي انه خلاص sacubitril valsartan is one of the major pillars in patients with heart failure, reduced ejection fraction. يمكن في اختلافات شويه ما بين اليوروبيان والامريكان جايد لاينز. اليوروبيان جايد لاينز حطاه ACE inhibitors or ARNI, while the American guidelines on the other hand شايفه انه هو يستخدم الارني والايس inhibitors تستخدم فقط لو مش عارفين ندي ARNI. هنا حاطين the two studies have examined
1 minute then.
Two studies have examined the use of ARNI in hospitalized patients ودول برضو استفادوا من giving such medications. و عايزين بس عشان الامريكان جايد لاينز زي ما قلت حاطه الارني ان هو اللي يستخدم، والعيانين اللي عندهم mildly reduced ejection fraction محطوط ككلاس 2B indication، والعيانين البريزيرفد ejection fraction موجودين في الامريكان جايد لاينز as a class 2B indication. Finally, when to use this medication in clinical practice in newly diagnosed heart failure patients. أكيد في عيانين who are symptomatic heart failure you can be switching to such a medication. طبعا taking the precautions of 36 hours stoppage of an ACE inhibitor إذا كنا بننقل من ACE inhibitor، و definitely برضه في العيانين of hospitalized heart failure patients after stabilization. Thank you very much.
Thank you, Professor Hisham Salah, Professor of Cardiology, for these very interesting lectures and illustrative lectures. My question, sacubitril valsartan in two categories of patients most commonly seen in a patient with heart failure. Patient with hypotension and the patient with reduced ejection glomerular filtration rate. Most patients we find the blood pressure is 90/60. How can use sacubitril valsartan in this category of patient in your practice?
Okay. طب ممكن اسالك انا سؤال؟
Yes.
لو دخلت قسطره والعيان ضغطه 80/60.
Yes.
فانت اتخضيت وقلت العيان ده شوك، وبعدين بتتعقم كده ابنه دكتور راح داخل لك وقايل لك على فكره خد بالك بابا ضغطه على طول 70/80 على 50 أو 60.
Yes.
ففي 90/60 and is acceptable for you. طبعا احنا الكات اوف بوينت عشان اعمل ادي الدواء is usually above systolic 90. But having said that, some patients we give them sacubitril valsartan وهم البلاد بريشر بتاعهم borderline, but taking precautions ان نمره واحد اديله smallest possible dose اللي هي ال 50 مللي جرام twice. وتاني حاجه ان انا adjust the dose of diuretics before starting the medication. لان واحده من اهم الاسباب اللي تخلي العيان يدخل في hypotension ان يكون العيان already على diuretic big dose. فusually what I do in such patients I step بعد ما العيان يبقى خلاص ما هواش wet, I step down the dose of diuretic and I step up gradually the dose of sacubitril valsartan. تاني حاجه بعملها في الناس ديت ان انا escalation of dose باخدها على مراحل اطول شويه. يعني انت usually you can escalate the dose وتصل ب خلال 3 ل 4 أسابيع. But you have a slower way of escalating the dose over 6 weeks ويمكن حتى فترات أطول if the patient is having such a borderline blood pressure. بالنسبة للكدني problem, this is quite a problem طبعا في جميع عيانين الهارت فيلير لأن احنا عارفين إن there is usually some problem with the kidney in up to 40% of the patients. في limitations معينة وواحدة من الحاجات اللي بتوقفنا usually is hyperkalemia. يمكن حاليا عندنا some new medications coming in بتساعدنا حتى في وجود hyperkalemia ان احنا نتغلب ونقدر نستep up the dose ولكن طبعا chronic kidney disease وفي limits معينة لو لقيت السيرم كرياتينين jumping significantly أكتر من 30% sometimes I have to stop or reduce the dose.
شكرا دكتور هشام. I think we had a wonderful session وأنا I'm inviting the chairman of the next session please come and take care of it.
عشان for the sake of time we have to move to the next session. وعايز اقول لحضراتكم ان الساعه 7:30 في رجاله دينر ويعني هيبقى في حاجات كويسه قوي تعجبكم يعني سربرايز يعني فمستنيين حضراتكم 7:30 فعايزين نخلص البرنامج اون تايم لو سمحتم. هارت فيلير سيشن.
ابدا يا حبيبي
This is heart failure symposium or lectures. بيسعدني طبعا ويشرفني ان يكون معايا في التشير بيرسون دكتور خالد النادي، دكتور هلا محفوظ، دكتور سيف. واول محاضره ان شاء الله guideline drug medical treatment in patient with heart failure with reduced ejection fraction advanced kidney disease. دكتور محمد حسن from Cairo University. اتفضل دكتور محمد.
بسم الله الرحمن الرحيم. Thanks Mr. Chairman. Good afternoon everyone. In my talk I will highlight how to implement guideline-directed medical treatment in patients with heart failure with reduced ejection fraction and advanced chronic kidney disease. As we know, we have 5 types of cardiorenal syndrome in which both heart and kidneys can affect each other. We have type 1 cardiorenal syndrome in which acute heart failure can result into acute kidney injury. Type 2, which is chronic heart failure, result in chronic kidney disease. Type 3, which is acute renocardiac, so in which acute kidney injury result into acute heart failure. Type 4, which is chronic renocardiac syndrome, in which chronic kidney disease and chronic renal failure can result into chronic heart failure. And finally, type 5, in which there is a systemic disease that can affect both hearts and kidney. If we look at the mechanisms by how the cardiac dysfunction lead to renal injury or renal failure, this damage or injury could be hemodynamically mediated damage just due to low cardiac output, decreased renal perfusion, which at the beginning lead to compensatory vasoconstriction of the efferent arteriole in order to preserve and maintain the glomerular filtration. But however, with humorally mediated damage and more activation of the renin-angiotensin system and sympathetic nervous system, vasoconstriction of the afferent arteriole occur, which lead to more deterioration of renal function and decreased renal blood flow. Also, we have a high systemic venous pressure, and we know with increasing central venous pressure, there is more worsening of the renal function due to increased interstitial pressure and edema within the kidney, which lead to decreased renal blood flow. And we have also immune-mediated damage through inflammation, cytokine release, and endothelial dysfunction, and also some exogenous factors like contrast or introduction of ACE inhibitors or MRAs or diuretics. Importantly, what's the definition of advanced chronic kidney disease? Advanced chronic kidney disease mean GFR less than 30. So it represents stage 4 and 5. 4 with a GFR between 30 and 15, and G5 which is less than 15. And it's well known that renal dysfunction is really common in patients with heart failure. Actually, this is data from around 25 studies that include around 16,000 patients, showed that near 50% of heart failure patients has GFR below 60, and near 10% has GFR less than 10. So it's expected that 10% of the heart failure population has advanced chronic kidney disease. And those patients has poor prognosis. There is a stepwise increase in the cumulative incidence of cardiovascular mortality and heart failure hospitalization with decreasing GFR. And actually patients with advanced chronic kidney disease or represent G4 and G5 has relatively threefold higher cardiovascular mortality and heart failure hospitalization compared to those with GFR more than 60. But importantly, we have many challenges in the management and implementation of guideline-directed medical treatment in those patients with advanced chronic kidney disease. The most important that we don't have evidence. The evidence actually is lacking because most of the landmark heart failure trials for the pillars of treatment of heart failure with reduced ejection fraction excluded patients with G4 and G5 stage. So they were excluded, and there is no dedicated trials for heart failure with chronic or with advanced chronic kidney disease. And importantly, most of the recommendations rely on just subgroup analysis or observational data, and we know the limitations of observational data because in real clinical practice, sick patients, frail patients with significantly elevated creatinine is less likely to receive guideline-directed medical treatment in real clinical practice. So this is the main limitation of observational data in such fields. Also, we have lack of standardized definition. If you look at definition of acute kidney injury, actually it's variable. The degree of acuity, the time frame of rise of creatinine, all this actually sometimes is variable. So there is no standardized universal definition. Actually, most of these studies depend on creatinine, and we know it's an imperfect measure of renal dysfunction, and they did not account for proteinuria, for example, which is really very important as predicting the outcome in heart failure patients in most of the heart failure and chronic kidney disease studies. And finally, there is main concern about the side effects, about hyperkalemia, sometimes serious side effects with like hyperkalemia and worsening of renal function. So if we look at the strengths of evidence for guideline-directed medical treatment in patients with chronic kidney disease, actually the green is a strong evidence. So we have a strong evidence definitely for using guideline-directed medical treatment for patients with GFR between 60 and 30. However, if the GFR is less than 30, actually the light green is just moderate evidence. So we have moderate evidence for the use of beta blockers in those patients, maybe use some dose adjustment with the beta blockers that cleared renally like bisoprolol. And the red, actually, there is no data. There is no data for MRA, and actually it's a contraindication to use MRA with GFR less than 30. And ARNI, also the landmark paradigm heart failure, excluded patients with G4 and G5. And the company recommendations say that we can use ARNI down to GFR of 10 with close monitoring of serum potassium and kidney function. Regarding SGLT2, actually there is strong evidence to use SGLT2 down to GFR of 20, especially with empagliflozin. So we can use empagliflozin down to GFR of 20. And finally, concerning ECI and the ARPs, there is evidence is really weak to use it in patients with GFR less than 30, but actually the evidence may be higher once the patient receives dialysis. And most of the data, as I said, for ECI and the ARPs come from observational trials and subgroup analysis of the consensus and SHARM trial. Actually, definitely there is a benefit. All this say that the patient, these drugs are beneficial in terms of reduction of morbidity and mortality, but this comes at the cost of side effects, as I said, hyperkalemia and worsening renal function. There is recommended dose adjustment for in those patients with advanced chronic kidney disease. Beta blockers, as I said, half dose initially for bisoprolol. MRAs are contraindicated. ARNI, you start with a small dose and 50 milligram twice daily and up titrate. For ARBs, there is no dose adjustment for all ARBs, and for ECI, perindoprel is not recommended, and there is half dose initial adjustment for captoprel, for enalapril, and quarter dose initial just a reduction of dose in ramipril. Actually, we know you start with a very low dose and you follow up the serum potassium and creatinine. And interestingly, if you see the effect of our treatment on the renal stope and on the GFR in patients with HFrEF, you will find that once you initiate ECI, ARP, or SGLT2, there is an expected drop, acute drop in GFR, and then it's maintained. So, but we know that it's accepted to have near 20-30% reduction in GFR with introduction of such drugs, and this is not associated with adverse clinical outcome, or even it did not attenuate the clinical benefit or such drugs. Actually, the guidelines recommend that you can, in patients with chronic kidney disease, not only advanced chronic disease, to start ECI and ARP, and you can accept even up to 50% reduction in GFR as long as the GFR is more than 25. So it's expected to have this acute drop in the beginning. Just monitor your patients, and it's not acceptable if you have hyperkalemia. And if you compare the slope of GFR in patients with ECI, ARP, and ARNI, you will find that those patients taking ARNI and SGLT2, the slope of deterioration of GFR is less than ECI because it has some renoprotective effects and it has beneficial effects on the renal endpoints. So acute drop in GFR with RAS blockade, ARNI, and SGLT2 does not diminish the treatment effect, and the reduction in slope deterioration with ARNI and SGLT2 is associated with due to the reduced hard renal endpoints. And we know that the emergence of the potassium binders may help in initiation or up-titrating these patients with chronic kidney disease. Actually, we know that we have 3 potassium binders. The first one approved is the SPS. However, now there is an FDA warning about increasing the colonic necrosis and bleeding and the ischemic colitis and perforation. So we have the Patiromer and the SZC, the sodium dichronium cyclosilicate. Both actually, we have one in the market, the Lokelma, and it's increase the fecal excretion of potassium, so it can help in initiation or up-titrating your medication, guideline-directed medical treatment in patients with advanced chronic kidney disease. We know that it has some side effects like GIT irritation. There is an increased risk of edema with sodium dichronium cyclosalicylate, and profound sometimes hypokalemia and hypomagnesemia in such patients. The potassium binders actually lead to a significant reduction of potassium, and the rate of discontinuation of the RAS blockade treatment is significantly lower in patients taking this potassium binders, and it's really effective within 48 hours of initiation of potassium binders. You will find the serum potassium is low. I will end my presentation, but this really nice renal-based approach for initiation and titration of guideline-directed medical treatment in patients with chronic kidney disease. This algorithm proposed by the Heart Failure Association of the European Society of Cardiology, to see that if your patient has a GFR more than 60, so definitely it's safe you start from the beginning, initiate your quadruple therapy guided by the patient profile. And if the GFR between 60 and 30, they recommend to start with the triple therapy. So you can start safely beta blocker, you can start SGLT2, but you only start ARNI. Do not start ARNI with MRA, just start ARNI and then follow your patient after 2 to 4 weeks to see the effect on serum potassium and kidney function. And then if the potassium is not high, so you can add MRA. In patients with GFR between 30 and 15, you can initiate also triple therapy, beta blockers, SGLT2 down to, as I said, GFR of 20, and very small dose ACI. They do not recommend ARNI because there is no data on the use of ARNI in GFR below 30. And finally, if the patient has GFR below 15, so just only monotherapy, you have the beta blockers, and you can start very low dose ACI to see the effect on renal function very closely and serum potassium. You may consider the combination of hydralazine and the hydralazine and nitrates in those patients, but there is no strong evidence for them. And then you follow up your patient to see the up titration of your medication based on the potassium and serum creatinine, and you may use, as I said, potassium binders in such patients. So finally, my take-home message that lack of high-quality evidence for guideline-directed medical treatment in patients with HFrEF and advanced chronic kidney disease leave little guidance for the management of this vulnerable population. We have just extrapolation from observational data and subgroup analysis, and I really like the final slide with the renal-based algorithm for managing those patients. The guideline-directed medical therapy in this population can yield definitely some side effects, but the overall poor prognosis of such patients may result in greater absolute therapeutic benefit from this guideline-directed medical treatment. Potassium binders are helpful in those patients, but whether the adding potassium binders and to help up titration of this medication will be translated into clinical benefit is still not evident in clinical trials. Thank you.
Thank you, Dr. Muhammad, for this excellent presentation. To summarize your talk, طبعا احنا عايزين بس نعرف البيشنت السي كي دي هنقسمهم سي كي دي with dialysis وسي كي دي without dialysis، لان طبعا الادويه اللي يبقى dialyzable يبقى لازم تبوت ان مايند الدوزز بتاعتها والتايتريشن والكلام. طب لو احنا قلنا سي كي دي وقدامي بيتا بلوكرز، what is beta blocker you prefer in these cases?
You know, we have 3 beta blockers approved for the use of HFrEF. You can use the 3. Bisoprolol is renally cleared, so if the patient is not on dialysis, so you may start very small dose and up titrate slowly. And if the patient on dialysis, actually metoprolol is not dialyzable, so this actually may affect on the timing and the up titration of the doses. But the 3 beta blockers can be used with...
Also in patient with heart failure with CKD, you can start by ACE or ARBs or by sacubitril/valsartan. What dose?
Regarding the ARNI, definitely you start with 50 milligram twice daily. It's not recommended to use it below 10. This is even by the company. Actually, the guidelines do not recommend it below 30 because there is no data, but you can use it down to 10, 50 milligram twice daily, and then follow up the patient. Actually, if you look at the data from the paradigm heart failure, you will find that the rate of hyperkalemia and worsening renal function is lower with ARNI compared to ECI, so the effect on serum potassium may be better with ARNI compared to ECI. With the other ECI, you can start with a very small dose, especially with ramipril, because it's cleared by the kidney, and then you up titrate. I think you can start with also the 1.25, but you have very close eye on the serum potassium and the serum creatinine.
Okay. As regard to the SGLT2 inhibitors in the CKD patient, you prefer IMBA or DABA, gliflozin?
Both of them can be used down to GFR of 30. But the IMPA has the advantage that we have data that empagliflozin is effective and can be used in patients down with a GFR down to 20. But it's not recommended for both to be used in GFR less than 20.
Thank you very much, Dr. Muhammad, for this elegant presentation. In fact, it is a very complicated issue to talk about advanced kidney disease, but we have to make sure that the advanced kidney disease means stage 4 and 3 and 5. Stage 5, we have no data. Any studies or trials or sub-analysis even, we have no data about the use of the guidelines-directed medical therapy in this situation. So we'll not take talking about it. Stage 1, 2, 3, whether A and P, we can use the 4 pillars in this situation. The issue is in the CKD stage 4. We have to look for the 3 parameters, as you all know, not the serum creatinine only, but the estimated GFR and potassium. The 3 parameters, those 3 issues have to be followed closely in every patient having heart failure. And then readjust the therapy if there is decline below the 3 numbers that I'm going to tell. If the estimated GFR below 20, if the potassium more than 5.5, And if the creatinine more than 3.5, we have to recheck the patient every 2 to 4 weeks and then readjust the therapy, so long the patient in CKD stage 4. Otherwise, this is all patients allowed to have the GDMT with the all guidelines directed therapy. And thank you, Dr. Mohammed Hassan. And we are moving to the next talk. In fact, the second challenging topic, Dr. Karim Saeed will talk about the fasting Ramadan in patients with heart failure. This is also very challenging. I know we will take a very important message from Dr. Karim Saeed.
بسم الله الرحمن الرحيم. Thank you, Mr. Chairman. كل سنة وحضراتكم طيبين بمناسبة المؤتمر السنوي لاسمنا وبمناسبة رمضان. Of course, it is a very common question nowadays from our patients. Am I allowed to fast? And what are the risks? And at the same time, it is a very challenging question for us because it is a very important clinical and religious responsibility to answer this question and to perform our duties. And the guidance in this issue is not available as we are going to see. Our concern in fasting Ramadan is related to the risk of dehydration, hypovolemia, hypotension, and the development of acute kidney injury, the risk of hypoglycemia and its associated arrhythmic risk, and as you know, hypoglycemia is associated with increased sudden death. Electrolyte imbalance, the eating habits and socialization, more calories, more salts, disturbed sleep cycling rhythm, which is a known risk factor for cardiovascular event, and of course, how to tailor the medication in those patients to make them adherent, but we have more question about the safety of these medications in heart failure. On the other hand, fasting is known to be associated with many advantages. Hunger increases the parasympathetic, so there is lowering of the blood pressure, lowering of the heart rate. Subset of patients in Ramadan lose weight and had good insulin resistance. Actually, fasting in Ramadan is a form of intermittent fasting. Lower pro-inflammatory factors, and of course, the spiritual and psychological impacts and lower stress and depression have a good impact. Fasting is a state of ketosis, and this may be good for patients with heart failure. As you know, normal heart utilizes fatty acid as the substrate for metabolism. However, when the heart fails, the substrate is not fatty acid, it is glucose and ketones, because they are good fuel in efficiency. And the more severe the heart failure, the more dependence of the heart on ketones. And ketones are beneficial, not only by being efficient, but they have anti-inflammatory and antioxidant actions, and they reverse the remodeling. During fasting, the liver will produce excess ketones, and this will be taken by the heart. So, hypothetically, the environment of ketosis in Ramadan is beneficial to patients with heart failure, and this may be a rationale why, one of the rationale why SGLT2 inhibitor have a positive effect in patients with heart failure. However, we have uncertainties related to the benefit versus concern. We have very limited studies coming from small numbered research, retrospective, with deficient methodology published in low standard journal, heterogeneous populations with selection bias, different geographical locations. This is important because the hour of fasting, the type of foods differ from geography to other geography. However, all in all, fasting Ramadan is safe for all cardiac patients. And in this systematic review, with 36 studies, fasting Ramadan was not associated with increased risk of acute coronary syndrome or acute decompensated heart failure compared to other months of the year. However, there may be one difference. Events tend to occur at iftar, not at early morning. And in this study from Qatar, the rate of admission for acute decompensated heart failure during Ramadan did not show difference compared to other months. It's the same for mortality. However, acute decompensated heart failure during Ramadan may have different profile. In the Gulf Care Registry that recruited more than 4,000 patients hospitalized for heart failure, 7% were hospitalized in Ramadan. And those hospitalized in Ramadan showed lower rate of symptoms and sign of volume overload, and less atrial arrhythmias, possibly due to the lower sympathetic flow with the same mortality rate. So the message here is fasting is safe during Ramadan. And in this study from Saudi Arabia, commonly cited paper, in chronic heart failure, it is only 8% chance to have deterioration in the NIHA class. So in chronic heart failure, it is safe. For acute heart failure, it is not associated with increased mortality, maybe changing in the volume status. So how to manage our heart failure patient in Ramadan? We have only two guidance. This paper from the British Islamic Medical Association published last year, and another consensus from Turkey, from the Turkish Society of Cardiology. Among heart failure patients, who is the patient to exempt from fasting? This will include patients with acute decompensated heart failure, patients with NIHA 4, those patients receiving large dose of diuretics, especially in summer. And when heart failure is associated with ventricular dysrhythmias, severe pulmonary hypertension, or when heart failure follows an acute coronary syndrome or within 3 months after PCI or CABG. Some experts recommend against fasting in those patients who had hospitalization during the last 6 months, and some advocate for those patients with ejection fraction less than 35. And there is diversity about the recommendations for those patients with AICD or CRT. The British recommend against fasting in those patients with device therapy. However, the Turkish, I think, are more practical in individualizing the recommendations based upon the risk for deterioration of heart failure and arrhythmia. Regarding medications, in those patients taking twice or thrice daily dose, we may consider using single daily dose. For example, ramipril and valsartan is given twice daily dose in heart failure, so they can be replaced by lisinopril or candesartan. Those with borderline blood pressure, we can split the dose. We should not use medications with iftar. Should be given after al-Isha prayer or after suhoor. Also, the pH at iftar is very low, about 1, and this may interfere with the pharmacokinetic of medications. So if the drug is to be taken on empty stomach, this should be taken before suhoor. And if the drug should be taken after food, this be taken 1 hour after iftar, so the pH is normal now. For the use of diuretic, we should reduce the dose and to monitor the serum creatinine and electrolyte, and use it at al-Isha, not early with iftar and not late with suhoor because of the disturbed sleep rhythm. Digoxin can be given any time. For beta blocker and RAS blocker, we should use a long duration molecule and in different timing. So we can give, for example, ACI long-acting at العشاء and metoprolol long-acting at السحور, for example. For SGLT2 inhibitor, we should not use it or initiate it in the months before Ramadan because of the increased risk of ketoacidosis and worsening kidney function. We should start with low dose. However, this is mainly for diabetic patients. Not use it initiate it in elderly patients or those with CKD. We should check the INR frequently before and during Ramadan. For NOAC, we should use a long-acting NOAC, such as rivaroxaban. And if the iftar hour is less than 8 hours, we should not use apixaban. We should replace it before Ramadan by rivaroxaban. Salt, of course, is a major cause for decompensation in heart failure. Our patient should be aware that the majority of salt occurs in the procession of the food itself. It is not added. So our table is filled with modifiable salt source, breads, chickens, and soup are very rich in salt. Licorice overconsumption or consumption is a common tradition among Egyptians. However, overconsumption is associated with this increased risk of hypertension, heart failure, hypokalemia and its sequelae, coronary artery spasm, and the drug interaction with RAS blocker, warfarin, and digoxin. Exercise should be done 2 to 3 hours after iftar, not exercise before iftar, which is a common practice. So, being prepared to Ramadan starts before Ramadan. Before Ramadan, we should assess our patients, take a good history, revise all labs and imaging data, revise the current medications to see if there is a comorbid conditions that may prevent fasting, such as advanced diabetes or CKD, and to ask about the past experience during past Ramadan. If something bad occurred, so we should not allow fasting Ramadan this time. Also, we should revise and change the medication schedule. Patient should be advised to have a voluntary fasting in Sha'ban. This is a very good test for the response during the 30 days of Ramadan. Patients should know the red flags if they have fasted. They should break their fasting, dizziness, hypokalemia, hypoglycemia, or congestion. After Ramadan, patients should be reassessed again. Ideally, they should be in a very good state. They lost weight and they are decongested. However, this may not be the case in many situations, so we should reconsider our medications after Ramadan. This is my last slide, and thank you for your attention.
Thank you very much, Dr. Karim, for this elegant talk. I know it's very challenging, especially almost all Muslims want to fast in Ramadan, and this is the issue. They want to fast, but it's simply to categorize the patient into low risk, high risk, and very high risk. The low risk patient that can fast easily, and you recommend that for mild diseases, for controlled hypertension, mild valvular diseases, patient with chronic renal syndrome, patient with supraventricular or ventricular arrhythmia but controlled, just to make the patient adherent to the medication. But the very high risk patient with decompensated heart failure 3 and 4, and patient with acute coronary syndrome, that you shouldn't fast. I'm going to ask you about the intermediate zone, I mean the patient to moderate risk, how to advise him to fast or not to fast. We can say that should not fast, but not must to not fast.
هو حضرتك بتسمرايز الريكومنديشنز بتاع البريتش اسلاميك ميديكال اسوسيشن. Actually, if we know who should not fast, the other should fast, may fast. زي ما حضرتك قلتي اللي مش هيصوموا هم العيانين اللي عندهم advanced heart failure، العيانين السيفير pulmonary hypertension اللي عندهم acute coronary syndromes، دي كلير مفيش فيها دور ريد. اذر كان فاست. لكن الجروب الانترميديت اللي هو مثلا فانكشن كلاس 3 هارت فيلير، او عيان انجينا لكن عدى 3 شهور من بعد البي سي اي، we may advise the patient not to fast based upon these recommendations. And if the patient insists to fast, okay, this will be approved, but with close monitoring and modifications, with modification for the medications during the 30-day of fasting. بقية البوبوليشن hypertension, الديسلايبيديميا, الستيبل coronary artery disease, المايلد to moderate pulmonary hypertension, الفالفولار heart disease not severe, all of them can fast. How come patient should not fast?
تمام، شكرا جزيلا. وطبعا في حاجه we have to add it قبل الدكتور خالد ما يتكلم، انه هو البيشنت عنده مطلق الحريه انه يفاست one day and if he's not feeling well او في اي change في الكلينيكال ستاتس ممكن يفطر immediately في السكند داي.
صحيح.
Dr. Karim, thank you for your great effort to extract this very scarce data to give advice about to fast or not to fast. However, I do believe in most of our cardiac patients to start with should avoid fasting except in a very mild condition. لأن الissue for the patient for the heart failure, for example, is not hypovolemia per se, it's hyperviscosity as well. The same as a patient with dysrhythmia, like those with atrial fibrillation who is on either vitamin K antagonist or novel oral anticoagulation. I shouldn't allow increased blood viscosity to start with because I'm giving an anticoagulant. This is number one. Number two, to adjust the patients on the new modality of food taking and drug taking, and then to reach the optimal condition. This will take about 5 to 7 days. And to readjust the patient again after ending شهر رمضان, it will take another couple of weeks. So I do believe ان احنا نستخدم الرخص اللي ربنا سبحانه وتعالى اداها لنا من غير تنطع. انا اسف ما اعرفش التنطع يعني ايه بالانجليزي. This is better. We should allow for the just controlled hypertensive patient with heart failure class 1, something like this. Most of the patient with dysrhythmia or most of the patient with the taking an anticoagulation due to whatever cause shouldn't. This is my point, especially if there is a comorbid condition with a cardiac condition like diabetes and like chronic kidney disease. I want to know your point of view.
شكرا دكتور خالد. هو طبعا راي حضرتك هو عباره عن ميرور للكونتروفيرشي اللي موجود في الموضوع ده، لكن هو الموضوع ليه شقين بالنسبه لنا احنا كفيزيشن. وان الكلينيكال ريسبونسبيلتي اللي انا هبقى مسؤول على العيان لو حصل له ايفنت، والحاجه الثانيه ماي ريليجيوس ريسبونسبيلتي اي ويل بي، انا هبقى مسؤول لو انا فطرت عيان وهو ما كانش المفروض يفطر. الجزء الاولاني هو الكلينيكال ريسبونسبيلتي. I have some data and I have guidance. So I have rules I can follow. فلو عيان hypertensive severe with target organ damage, I will not ask him to fast. عيان severe heart failure responding well to medications بقى moderate, he should fast. ونفس الكلام ده في الدايابيتس. الدايابيتس هو ميتابوليك ديس اوردر ومليان كومبليكيشنز. الكاتيجوري اللي هم مش بيصوموا مش كبيره وليها كرايتيريا واضحه. فده الجزء الكلينيكال. الجزء بقى الريليجيوس ده هو سهل نقول للعيان افطر وساعات العيان، لكن I feel responsible اللي انا بعمله ده هيبقى مظبوط ولا مش مظبوط. والاكسبيرينس بتاعتنا شفنا عيانين كتار جدا كانوا المفروض ما يصوموش وصاموا وما حصلش حاجه. لكن الايشو بتاع الفيسكوسيتي ده مهم، وده will taken في العيانين اللي هم acute coronary syndrome او اللي ركبوا ستنتس او اللي عملوا كابج. ففاستنج is not allowed during the first 3 months، وده interestingly متاخد من study من بني سويف cited several times. This may be longer لو العيان عنده other issues kidneys, CKD, diabetes or heart failure. لكن I think we have a frame. وfinally the decision should be individualized. Before fasting عندنا before رمضان عندنا فترة طويلة دي بنبتدي قبلها بشهر من شعبان. وفي رمضان it is a dynamic process، بنشوف العيان وهنشوفه اخباره ايه وافتر رمضان. Okay.
Thank you, Professor Karim. For the sake of time, we will shift to the last presentation on the management of heart failure in patients with low blood pressure by Dr. Mariam Khalid.
presentation مش صح. Good afternoon all. My session today will be about hypotension in patients with heart failure, and this will be the following agenda. First, we will talk about guideline-directed medical therapy in heart failure, and then what is the magnitude of the problem of hypotension in patients with heart failure? Is hypotension in heart failure have clinical significance in the patient as regarding the quality of life and the prognosis of these patients? What is the proposed management approach? And finally, a short note about orthostatic hypotension in patients with heart failure. First, this is according to the ESC guidelines for management of heart failure. We all know that we depend on these 4 pillars for management of patients with heart failure. However, it's not only about using these 4 pillars, it's about using them in the doses studied in the guidelines and reaching to the target doses that will give the maximum benefit as regarding the quality of life, the morbidity, and mortality. However, this is not an easy mission to reach to these target doses. This data from the CHAMP Heart Failure Registry shows that among 3,100 patients with heart failure, they divided the population into 2 groups. Group with systolic blood pressure above 110 and the other group with systolic blood pressure below 110. Among both groups, only 18.7% can reach to the target doses of beta blockers compared with 17.5% in the other arm. 10% can reach to the target doses of ACE inhibitors, and only 2% among both arms can reach to the target doses of ARNI. So majority of patients in both arms could not reach to the target doses. So what are the barriers? Why it's not an easy mission to reach to these target doses? Mainly non-compliance to medical treatment, hypotension, worsening renal function, hyperkalemia, and bradycardia. Now we will focus on hypotension. Hypotension in heart failure has very well established and understood mechanism where the nature of the disease itself by pump failure reduces the cardiac output, volume depletion from the use of diuretics, and hyponatremia from excessive salt restriction. Some more comorbidities that alter the vascular activity of the patient, the use of disease-modifying drugs, and loop diuretics that can result in volume depletion. And that's why we should reduce the dose of diuretics when initiation and titration of the guideline-directed medical therapy. What is the magnitude of the problem of hypotension in patients with heart failure? The exact incidence of hypotension in patients with heart failure is not well established because majority of large clinical trials excluded patients with the hypotension. For example, in Paradigm trial, they excluded patients with blood pressure below 95/100. However, some studies were done in order to try to estimate the prevalence of heart failure in patients with hypotension. This is one of the studies that focused to see the prevalence of hypotension among patients with newly diagnosed hypotension, with newly diagnosed heart failure. Among 18,600 patients newly diagnosed with hypotension, 13.7% developed hypotension. Hypotension here was defined as systolic blood pressure below 90 millimeter Hg. This was more common among males and the age group between 70 to 79%, and the common risk factors was previous attacks of hypotension. So any patient with a previous episode of hypotension has high risk to develop another episode, renal failure, the use of RAS blockering system. And the clinical significance of hypotension in patients with heart failure, this study, this report tries to answer this question. This is a multi-center study in Japan, including 3,500 patients with acute decompensated heart failure. In this study, lower admission systolic blood pressure was associated with poorer prognosis as regarding all-cause mortality, cardiovascular mortality, non-cardiovascular deaths, and very significantly hospitalization for heart failure. Also, in the optimized heart failure, patients with systolic blood pressure below 120 was associated with the higher rate of in-hospital and post-discharge mortality. However, this poor prognosis and the association between worse prognosis and low blood pressure is well established in patients with acute heart failure. However, it's not very well established in ambulatory patients with chronic heart failure, where patients with the chronic ambulatory patient with heart failure, when receiving the guideline-directed medical therapy, asymptomatic drop in the blood pressure may be a sign and a marker of effective treatment. For example, in the SOLVE trial, the blood pressure falls with the enalapril and was associated with higher survival. In the paradigm, ARNI causes more drop in the blood pressure than enalapril. However, the composite endpoint of cardiovascular death and the hospitalization was better among the use of ARNI. Management of hypotension in patients with heart failure recommend understanding the problem of these patients. Some patients have serious problems as regarding symptoms that make them less compliant to medical treatment. However, part of the problem is excessive cautious of the physicians in using guideline-directed medical therapy among patients with blood pressure below 90 or below 80 millimeter Hg. So we should not be guided by the absolute number of the blood pressure. We should be guided by the symptoms. But of course, these patients need more follow-up while initiation and close monitoring during up titration of their medical treatment. This paper from the ESC guidelines tries to find the algorithm for management of these patients. First, we will consider symptoms of these patients. If the patient is only hypotensive or also hypoperfused. If the patient is hypoperfused, this is an indication for urgent hospitalization. And then dividing the patients into three other categories: those with blood pressure above 100 without orthostatic hypotension, and among these patients no further modification is required; those with blood pressure below 90 and the postural hypotension, we should move to step 2, while those with blood pressure between 90 to 100 or systolic blood pressure above 100 but have orthostatic hypotension, or systolic blood pressure below 90 but there is no postural hypotension, among these patients we should re-evaluate the blood pressure and make sure that symptoms is due to heart failure. Then, if we make sure that symptoms is due to hypotension, we should eliminate other non-heart failure guideline-directed medical therapy, for example, calcium channel blockers, for example, alpha blockers. And if blood pressure remains persistently low, we can consider lowering the dose of diuretics in non-congestive patients, and a lot of modalities, including clinical examination, PMP, echocardiography, and lung ultrasound can be used to determine the fluid status of the patient. If all these problems have been solved, we can consider risk profiling of the patient and determine the clinical profile of the patient as regarding renal function, potassium, heart failure, the presence of arrhythmia, and manage this problem. And then if the patient has persistently low blood pressure, we should send him to an expert in heart failure center. Finally, about orthostatic hypotension, it's a common presentation in patients with heart failure. As per SPRINT study, it reveals that orthostatic hypotension was more frequently diagnosed in patients with heart failure, 13.7%, comparing to only 7% in patients without heart failure. And this was more commonly observed in elderly and in those with HFpEF. This is the mechanism by which our body can resist the presence of orthostatic hypotension. While we are in recumbent position, 30% of the blood is pooled in the chest, and when we stand up, almost 8 cc of the blood will be pooled in the lower body vessels. By different reflexes and the mechanism, there is activation of the RAS system, activation of the baroreceptors that result in reflex tachycardia and the increase in the systolic blood pressure, so prevent this hypotension from occurring. If we see that all these steps can be affected by the pathology of patients with heart failure, where venous pooling is more, and due to diuretics, nitrates, calcium channel blockers, the elevation of the RV systolic pressure make it less likely for the decrease in the filling of the ventricle, also blunting of the baroreceptors by some comorbidities, and the use of guideline-directed medical therapy, which can alter these reflexes. So this is the clinical implication of patients with the orthostatic hypotension. We should early screen orthostatic hypotension in patients with heart failure, because this symptom may be the cause why the patient become non-compliant to medical treatment. We should not rush to stop titration of guideline medical therapy unless we make sure and understand that the problem, the exact problem. And this is a proposed algorithm for management of orthostatic hypotension in patients with heart failure. First, we have to estimate the congestive status of the patient, and if the patient is not congested, we can lower the dose of loop diuretics, and then we can manage other comorbidities and other factors, for example, like polyneuropathy, diabetes mellitus, and we have to manage any type of arrhythmia and disturbances in anemia, constrictive pericarditis, and we have to make sure that and remember that orthostatic hypotension is one of the red flags for amyloidosis, so we have to put it in the background while dealing with these patients. Thank you.
شكرا دكتورة ماري. Any questions? Thank you, and we conclude this session, and we end it. Thank you very much, and we invite the chairperson for the next session to be on stage. My pleasure to introduce my friend Professor Dr. Hisham Salah, talking about pulmonary hypertension update.
Mr. Chairman, thank you very much for your kind introduction. الموضوع اللي أنا هتكلم عليه النهاردة التايتل بتاعه Percutaneous Pulmonary Arterial Intervention When, Why and How. يا ريت بس ننقل على هنا بقى كده. How much healthier could you get? دي سيرينا ويليامز، واحدة من أفضل لاعبات التنس في العالم كله. وطبعا she's very healthy. وبالرغم من كده جالها pulmonary embolism. And بقى a very long story including interventions for her problem. والحقيقة what we know is that pulmonary vascular problems are not rare. They may significantly increase morbidity and mortality. للأسف الشديد they are frequently overlooked. Pulmonary interventional strategies are frequently not thought of even when indicated. What is not in our focus for this presentation, وده اللي مش هنتكلم عليه بس لازم أعرضه لأن احنا بنتكلم على pulmonary interventions، هو balloon angioplasty and stenting in pulmonary branch stenosis. والحقيقة لازم نبقى عارفين ان there are guidelines regarding when to do ballooning and when to stent the pulmonary arteries. تاني حاجة pseudo aneurysms سواء حصلوا نتيجة lung cancer وده كتير بيتعمل لهم coiling أو pseudo aneurysms from manipulations of a Swan-Ganz catheter. True pulmonary artery aneurysms, although rare, but they do occur وأحيانا بيحتاجوا some sort of interventional strategy. Pulmonary arteriovenous fistulas, whether single or multiple as a part of hereditary hemorrhagic telangiectasia, are all things which sometimes need some sort of an intervention. أمال إحنا النهارده جايين نتكلم على إيه بقى؟ The topics of today are balloon angioplasty for chronic thromboembolic pulmonary hypertension, interventions for pulmonary embolism ودي مش هتكلم عليها كتير، وموضوع ما اعرفش حضراتكم يعني تعرفوه ولا لا وهو sympathetic denervation for pulmonary hypertension. Moving to balloon angioplasty، يمكن مهم جدا ان احنا نعرف انه زي ما بنتكلم كده على الكرونري ارتري سيجمنتس وبنقسمهم 16 سيجمنت او غيره، لازم نبقى عارفين at the same time that branches of the pulmonary artery are also divided من A1 to A10. A1 apical, A2 posterior, and so forth, going to the lingular, going to basal. فهم they are numbered. ودي نقطة مهمة جدا عشان لما نيجي أولاً لأنه كتير جدا لما بنعمل pulmonary interventions بنعملها staged. أوكي بيبقى فيه فيلم ومتصور وكل حاجة ولكن لازم من حين للآخر أبقى عارف أنا what arteries did I tackle. فبالتالي knowing the terminology is extremely important. تاني حاجة احنا عارفين في الكرونريز احنا بنقسم السيجمنتس بنقسم الليجنز ازاي؟ ABC مش كده؟ نفس الكلام بس بطريقة مختلفة. الpulmonary lesions are classified into A ring-like lesions, B web-like lesions, C subtotal occlusive lesions, D total occlusions, and E tortuous lesions. وبالتالي لازم نبقى فاهمين what site وفي نفس الوقت فاهمين what type of lesion لأن كمان ال outcomes of intervention in such lesions is different. What is known الحقيقة الغريبة بالرغم ان انا متأكد ان معظمنا ما يعرفش معلومات كتيرة عن هذا الموضوع that it started في 1988 و first publication for the use of balloon angioplasty for pulmonary thromboembolic events كان في 2001 ومن ساعتها ابتدوا يكتشفوا ان such intervention will reduce number one the pulmonary artery pressure and number two the symptomatology significantly. وطبعا ناهيكم انه في بعض العيانين احنا عارفين ان هو already متشخص انه pulmonary embolism وعدى عليه 3 شهور فاحنا اما يجي لنا لو still symptomatic I have to proceed and بفكر بقى is this a chronic thromboembolic event disease وكده محتاج intervention ولا لا فبنعمل له VQ lung scan بنعمل له echocardiography ولو في findings نبروسيد ب CT coronary زائد right sided heart catheterization واكوردنج بقى بنصل انه احيانا بيكون there is a class 1 indication to intervene in such patients. يمكن هنا في الجايد لاينز اللي نزلت في 2022 هنلاقي ان balloon pulmonary angioplasty is recommended in patients who are technically inoperable or have residual pulmonary hypertension after بقى تعمل لهم already end arterectomy or having as well distal obstructions amenable to balloon pulmonary angioplasty but not amenable to surgical intervention. يمكن السلايد ده جميل جدا لأنه بيبين the three options that we have, whether we are talking about end arterectomy لو الثرومباي موجودة في البروكسيمال segments أو أحيانا بنلجأ إلى البالون pulmonary angioplasty، وفاينلي إن في role definitely additional to medical treatment. This is the surgical view. هم باصين لإيه؟ باصين لتايب 1 level 1 and level 2 the proximal segments. وما بيعملوا كده بيحصل a significant benefit for those who were operated. والsignificant benefit ده مش مجرد تحسن خفيف. No, there is a survival benefit for those who underwent pulmonary end arterectomy. And this is the interventional view. This is how we look at it. بنبص بنشوف في distal lesions do we need intervention or not. مهم جدا ان احنا نعرف انه whenever we tackle such a problem we go in with attempting تقريبا في حوالي 30 دقيقة ونحاول 1 or 2 sites. Usually such patients they need ما بين 2 sessions to 6 sessions. Sometimes even much more. في ناس اتعمل لها up to 17 sessions. ليه؟ لأن مهم جدا إن تتعمل الحكاية دي مرحلية and not to go for many arteries at the same time. ومهم جدا كمان إن إحنا لما بنعمل كده بنعمل لو هنعمل مثلا 2 arteries نعملهم on the same side على نفس اللنج. ده التكنيك. بندخل ببالونه بعد ما بنعدي الواير وبننفخ usually the results are quite satisfactory. Different studies have been out. طبعا في study مثلا منهم ظريفه جدا على 16 عيان. العيانين دولت زي ما احنا شايفين كان عندهم significant rise في المين pulmonary artery pressure. وما اتعمل لهم angioplasty there was a significant drop in the mean pulmonary artery pressure, a significant improvement in cardiac output, pulmonary vascular resistance was significantly lowered, 6-minute walk test was significantly improved. BMP on the other hand was also significantly down. مهم جدا احنا بنعمل الكلام ده للعيانين دول ليه؟ عايزين كمان الفانكشنال كلاس بتاعهم يتحسن، وده اللي حصل ان العيانين most of them الفانكشنال كلاس بتاعهم significantly improved. But this doesn't come out without a cost. لأن برضه في significant complications ويمكن من أهمهم الريبرفيوجن pulmonary edema. Whenever you open multiple arteries, the possibility of occurrence of a segmental pulmonary edema in the lung that you reperfuse is quite high. وبالتالي this is why sometimes we have to go step by step and not to tackle many arteries at the same time. من سود يونيفرسيتي كمان جت some data برضو ظريفة جدا على عدد 128 عيان followed منهم 83. النتائج كانت quite satisfactory وحصل بعد عمل البالونينج a significant drop in the pulmonary artery pressure وحصل في نفس الوقت ان الكاردياك index was significantly improved as was a reduction significant in pulmonary vascular resistance. 6-minute walk test in the study was significantly improved. The New York Heart class was also significantly up. Finally, ابتدوا يفكروا انه زي ما احنا بنعمل في الكرونريز ballooning, why not use some advanced techniques as well? ومن ضمن الادفانسد techniques انك to guide what you're doing using IVUS or OCT. ومش بس كده، ده ابتدوا يستخدموا كمان ال FFR in trying to dilate, in trying to assess the significance of narrowing in such arteries. هنا ديت 27 سيشن اتعملت وبينت انه a significant improvement برضو of using such technology في الاوتكمز. هنا زي ما انتم شايفين كده هتلاحظوا ان المين pulmonary artery pressure was significantly reduced. The cardiac index was also and cardiac output were significantly up, as was a significant reduction in the pulmonary vascular resistance. And from a clinical perspective, the 6-minute walk test was significantly improved. وسموها refined balloon pulmonary angioplasty لأنها بنعملها بguidance some other tools, including using OCT or using IVUS or using FFR. في البلمونري امبوليزم في الكاثيتر بيست ثرومبوليسيس، في الميكانيكال ثرومبكتوميز، وفي الفارماكوميكانيكال انترفنشنز. طبعا ديفرنت تكنيكس، منهم الايكوسونيك ده ميزته ان هو بيدي الترا ساوند at a high speed leading to separation of the fibers of the thrombus and giving space انه ممكن يساعد ان الثرومبوليتيك ثيرابي يصل اكتر الى السايت اوف ذا thrombus وبالتالي يكسرها اكتر. الانديجو سيستم ده وانا استخدمته في كذا عيان is an excellent system, although one of the disadvantages ان الكاليبر بتاعه is just 8 French. الجديد بتاعه ده نزل بره ونازل مصر قريب is 12 French. ده بيسمح لي ان انا to tackle more and more thrombi، ويمكن نبتدي كمان نشتغل بيه when there is a thrombus in the right atrium او a thrombus in transit. Studies كتيرة كلها going in the same direction that such techniques are usually feasible and give some very good results. Finally, هنحتاج دقيقتين بس عشان ما نسمعش القنبلة اللي انت بتعملها دي. Sympathetic denervation for the pulmonary hypertension is also one of the relatively new techniques، بالرغم ان بقى لها فترة ولكن يعني واخدة some interest. يمكن في data coming من روسيا. الداتا دي بتبين ايه؟ احنا فاهمين كويس جدا from pathology ومن different other studies انه في pulmonary hypertension there are structural changes, and some of the structural changes is an increase in the muscle mass. وفي نفس الوقت the muscle sympathetic nerve activity in such patients is quite high. وفي experimental animals وجدوا ان في specific sites فيها اكتر sympathetic nerve endings، وبالتالي احنا في الحالات اللي زي دي بندخل بسبيشال كاثيتر ونروح to pre-specified sites اللي احنا عارفين ان probably the sympathetic nerve endings فيها عاليه. وده شكل الجهاز، والتكنيك ما هوش صعب خالص، ولكن طبعا محتاج برضو شويه experience. الستادي دي كانت على 12 عيان، نصهم males mean age of 42 quite symptomatic. اما اتعمل لهم هذه type of sympathetic denervation, the complication rate was 0%, and this is quite important. ولكن كمان لقوا انه there was a significant drop in the mean pulmonary artery pressure with systolic pulmonary artery pressure beyond doubt. blood pressure in mean pulmonary artery نزل من 58 ل 33، وال 6-minute walk distance was significantly improved in such patients. وبالتالي I am calling here for an action. It's time to start improving our knowledge about the pulmonary circulation. It's time to understand the magnitude of the problem in our community through registries. وده اللي already ابتديت أعمله. And we need to build pulmonary interventional teams taking steps to improve our experience. Thank you very much.
Thank you very much دكتور محمد. As usual excellent presentation. وتقريبا من قوة المحاضرة حصل فيه زلزال، ما اعرفش حشيته بيه ولا لا. حصل زلزال حوالي.
نسيت اسمي، ما ده زلزال.
دكتور هشام، حضرتك as regard ان pulmonary hypertension كديزيز it's a dilemma in the diagnosis, but lastly in the last guidelines there is definite new diagnosis as regard the pulmonary vascular resistance والpressure. As a new technology in the treatment أو update في intervention as regard either البالون angioplasty or pulmonary denervation. Until now, I think in the pulmonary denervation there is no strong data about the results. Maybe due to the innervation or sympathetic in the pulmonary artery may be different from the renal vessels. I think about the inflammatory process في pulmonary artery may be different in the pulmonary from the renal vessels. Results may be not good. My question, it is future ممكن الدينرفيشن until now يعني overcome the problem في السمبلستي study ان النيو سمبلستي كاستر making more than 3 or 4 bores فتيك a large area denervated في الهايبرتنشن ريزيستنت والريزلت بقت احسن بكتير. ده ممكن كان applied to take more better results في البلمونري والاذر كويشن از ريجارد.
طب خلينا نرد على الاولاني ده. نمبر 1 انه انا وريت لحضراتكم what happened in the pulmonary artery pressure when they used this sympathetic denervation mechanism. The systolic blood pressure, the mean pulmonary pressure went down from 56 to 33 millimeters, and this is quite a strong drop. So that was a very satisfactory result, although on a relatively small number of patients. هل ده يعمم؟ ما تهيأليش. When I think one of the problems is not only the type of catheters that we are using.
Yes.
One of the problems that there is quite a variation between patients. في patients أكيد الsympathetic innervation بتاعتهم رايحة حتة مختلفة عن التانيين. وبالتالي يمكن the future, and this is just an assumption, the future will be إنه هيحددوا الأول يعملوا some sort of a scanning technique to check where the sympathetic points are at the max. وهو ده اللي يروحوا لها ويعملوا لها denervation. results are not bad أو actually they are good. ولكن الحاجة المؤكدة إن إحنا في التايب 4 pulmonary hypertension اللي هم الكرونيك thromboembolism اللي هم عندهم مشكلة كبيرة إن هم they will die. They are suffering. Pulmonary artery pressure عندهم عالي جدا. We are finally having a good opportunity to help such patients. والحقيقة أنا في داتا كتيرة بس أنا I didn't want to put too much data here. منها على الرايسجوات وكomparison مع البالون pulmonary وإزاي إنه البالون pulmonary angioplasty was superior to the medication. إحنا مش معنى كده إن إحنا مش هندي medications. No, we will be giving medication. بس هنا we are providing a mechanical solution for a mechanical problem. السؤال الثاني بقى.
Another question as regard when start pulmonary angioplasty, it is depend on the severity of the pulmonary arterial pressure and at which stage moderate pulmonary hypertension, moderate or severe can apply this technique.
Strangely enough, most of the trials that were done on mild to moderate elevation of pulmonary artery pressure. ليه؟ لأنه الهاير pulmonary pressure مع still a learning curve بيبقى معاه a higher risk of developing complications. فهتلاحظ حضرتك أنا بس حطيت 3 studies بس في غيرهم شوية يعني. بس كلهم very limited numbers. حاجة و20 عيان من فرنسا، حاجة و20 عيان من كذا إلى آخره. what's the issue is that they usually to try to minimize complications they are starting with mild to moderately elevated pulmonary artery pressure.
Dr. Sham, طبعا thank you for the invitation and thanks to Dr. Magda Hamid. And second, nice presentation, an elegant presentation as usual. I would like to ask about 2 questions. In case of coronary angioplasty, we know there is a percentage of recoil after balloon angioplasty. I don't know, it is the same in case of pulmonary artery angioplasty or not, and if there is availability for repeated angioplasty or not. This is the first question.
طيب أرد على السؤال ده. جزء من الريكويل بسببه الستراكشر of the artery. وdefinitely the coronary arteries are medium-sized arteries, while pulmonary arteries, at least the main branches, are larger-sized arteries. في medium-sized arteries نسبة المسل للtotal wall is usually larger وبالتالي the recoil is usually higher. ففي شوية اختلافات ما بين الكرونري وما بين البلمونري except if you're going to the very terminal branches in which the caliber is smaller فممكن ده يكون أكتر. أنا وريت سلايد على الأمريكان indications for ballooning and stenting in pulmonary arteries. Usually stenting أنا بتكلم على branch pulmonary stenosis وليس thromboembolic. في thromboembolic مننا بنوسع حتت كتيرة قوي. Usually the trend is not to put a stent, you are just dilating وبتدخل تاني وبتصور and you can be checking and if there is a site that is re-stenosed أو حصل فيه rethrombosis you can go in and redilate it. this is the issue. السؤال التاني بعد.
Second one, you were one of the first who worked with Indigo. And I would like to ask in case of massive pulmonary embolism, we can use just aspiration, or we can combine thrombolytic with aspiration?
We can يعني هو الانديجو معمول علشان aspiration وليس thrombolysis، بس احنا عارفين انه في فارماكو ميكانيكال، فيعني اليوجوال ان احنا we go in الانديجو الكام حاله اللي انا عملتهم we went in just for mechanical. في تكنيكس ثانيه بتحقن ثرومبوليتيك بقسطره معينه جوه البلمونريز، مش بس سيستميك ثرومبوليسيس، بس الانديجو از ا ميكانيكال ثرومبكتومي ديفايس. في عيب الانديجو والحاجات اللي بتعمل اسبيريشن جامد ان هي sometimes لو انت مش واخد بالك وبتعمل اسبيريشن ان كوركتد، يعني اللي هيحصل ان ممكن العيان يدخل منك في سيفير انيميا، لانك انت الجار كبير كده وقاعد بيسحب دم. ففي تكنيكس احنا بنعملها عشان نقلل فقدان الدم في هذه الحالات. فخلاصة الكلام ان الانديجو سيستم is a mechanical system, it's not designed for ان احنا ندي معاه thrombolytic therapy، بس يعني احيانا we can give this and that according to the patient.
برضه حضرتك احنا بالنسبه ده از ريجارد البلمونري هايبرتنشن من الموضوعات اللي هي صعبه في التعامل معاها بصراحه في مصر، واحنا ما بنعرفهاش اهتمام كبير.
ما ده اللي انا قلته.
فاحنا
This is the ignored part of the circulation. احنا دايما بنتكلم على السيستميك circulation وبننسى البلمونري circulation. عشان كده I was the one to choose such a topic عشان نتكلم عليه، لان this is step one. We are willing to start a program بقوة في هذا الموضوع ان شاء الله.
بالظبط. ما اعرفش.
شكرا جزيلا.
الدكتور عادل موجود ولا لا؟ موجود؟ موجود؟ دكتور عادل الاتريبي موجود؟
الدكتور عادل الاتريبي يا دكتور مجدي موجود ولا خلاص في السيشن؟ اوكي شكرا.
اتفضل يا دكتورة نهى. بسم الله الرحمن الرحيم. احنا متأخرين كتير، بس هنبدأ السيشن بالدكتور اسلام شوقي. السيشن ده على نيو دراج. نسمع دكتور اسلام يعلمنا ايه الجديد فيه ان شاء الله.
بسم الله الرحمن الرحيم. انا بشكر الاستاذ الدكتور مجدي عبد الحميد رئيس قسم القلب في طب القصر العيني وكل الاساتذه 23 على الدعوه الكريمه. وبشكر مناريني على الدعوة ان انا talking on behalf of Menarini today about ranolazine. And the title is Innovation in Ischemia Management. الحقيقة احنا عارفين كلنا قصة prevalence of coronary artery disease والمورتاليتي اللي worldwide around 30% of mortality worldwide is from due to coronary artery disease, and up to 45% of mortality is due to cardiovascular disease. And this is one of the most expensive diseases. It affects the community with billions of money, either in US, Europe, and even in Middle East and in Egypt. في مصر الناس اللي بيموتوا according to the World Heart Organization سنة 2018 قالوا ان around 30% of population of deaths in Egypt is due to coronary artery disease. السنتوري اللي فات، القرن اللي فات، كان الابيديمكس ده في الاربعينات والخمسينات كان في الويسترن كانتريز. الآية انعكست عندنا وكلكم اوير بالداتا اللي من الستنت سيف لايف انه الكوروناري ارتري ديزيز از ان ابيديميك في مصر وفي الدول اللي حوالينا، والكوروناري ارتري ديزيز affects younger people. And those died from coronary artery disease and having myocardial infarction are 10 to 15 years younger than the population in Europe. The presentation of ischemic heart disease, either acute coronary syndrome, unstable angina, ST elevation or non-ST elevation myocardial infarction، أو عيانين عندهم stable coronary artery disease سواء كانوا having obstructive or non-obstructive coronary artery disease. المشكلة انه الناس اللي عندهم stable coronary artery disease دول around 75 to 80% acute coronary syndrome affects only 20% of patients with coronary artery disease. احنا عارفين البيلرز اللي بيتبني عليها الميديكال تريتمنت، والميديكال تريتمنت الحقيقه بيبقى بريفيرد المانجمنت اوف كوروناري ارتري ديزيز على 3 بيلرز. لما الموضوع يبقى فينا احنا غالبا بنلجا الى السيفست ريجيمن سواء كان ميديكال تريتمنت او لايف ستايل موديفيكيشن. انما لو القصه متعلقه بالانكم احيانا القرارات بتختلف، وهي دي المشكله. Either lifestyle, cessation of smoking, management of hypertension, diabetes, dyslipidemia, etc. أو medical treatment للstable coronary artery disease وكلنا عارفينها، والrevascularization, and those who deserve revascularization is patients with severe ischemia. The diagnostic pathway for patients with chronic coronary syndrome, it relies on the pre-test likelihood of the test. If the patient had low moderate probability of coronary artery disease, you can evaluate those patients with non-invasive imaging, either CT for naive people, and if you want to know the burden of coronary artery disease, أو myocardial perfusion imaging أو cardiac assessment with stress imaging لو كان الريسك a little bit higher أو the question of viability is there. إنما still you can send some patients right away for coronary angio and possible revascularization if the patient had very high pre-test probability for coronary artery disease. المشكلة إنه رغم الميديكال تريتمنت رغم الريفاسكularization still a remarkable amount of patients, around 30% of patients after revascularization with 1 year, they're still having recurrent angina and recurrent chest pain. وده رقم كبير. أحيانا بيبقى أكتر من تلت العيانين بيجي لهم chest pain immediately. احنا طبعا في اللاند اوف اسكيميا ترايل دكتور مجدي and group from القصر العيني was part of the ischemia trial which is a landmark trial. أعتقد إنها غيرت شكل الريفاسكولاريزيشن والميديكال تريتمنت in the last years, واللي كان stated clearly that patients on medical treatment versus those having revascularization having the same outcome almost. There is no statistical significant difference regarding myocardial death, myocardial infarction. على الرغم ان البيشنتس دول كان عندهم moderate to severe ischemia. الoptimal medical treatment do the same exactly like revascularization in patients with moderate to severe ischemia, provided that those patients is on optimal medical treatment. الجايدلاينز كانت stated على انه الحقيقه coronary syndrome patient they should have risk factors modification, وان العيان اللي عندهم chronic stable angina they may accelerate to acute coronary syndrome. Therefore, we need to watch those patients closely. How optimal treatment can be defined as the treatment that satisfactorily controls symptoms and prevent cardiac events. However, there is no universal definition of optimal medical treatment. وأنا دايما بحب أقول إنه في individualization للمانجمنت. You cannot give all patients the same treatment. Each patient need different management, وده التاسك بتاعنا. The presentation of chronic coronary syndrome to our clinics, 6 type of patients we are all aware. ودي medical treatment according to the European Society of Cardiology guidelines published in 2019. It is stated that the first line treatment indicated is the beta blocker or calcium channel blocker to control patient symptoms. And if the angina symptoms are not satisfactorily controlled, beta blocker or calcium channel CCP can be combined for those patients, and this is a class 2A. طيب لو العيان still symptomatic رغم البيتا بلوكر أو الكالسيوم channel blocker يبقى هنا الرانولازين among secondary line medications can be used, and the class of recommendation is 2A level of evidence B. أنا عايز هنا بس هايلايت إنه لو كان في كونترا انديكيشن للكلاس 1 سواء كان البيتا بلوكر أو الكالسيوم شانل بلوكر برادي كارديك أو هايبوتنسيف بيشنتس على طول السكند لاين ميديكيشن هيبقى فيرست لاين ميديكيشن. In subjects with baseline low heart rate and low blood pressure, ranolazine and others may be considered as first line drug, and this class 2B level of evidence C. الجايدلاينز كمان قالوا انه البيتا بلوكر والكالسيوم channel blockers are recommended as the first choice, although no randomized controlled trial to date have compared this strategy to an alternative strategy using initial prescription of the other anti-ischemic drugs اللي احنا بنقول عليهم دلوقتي second line. وعشان كده خلينا نختصر ان القصة هي individualization. You may use those second line as the first line. The same meta-analysis suggested that several second line added on anti-ischemic drugs, long-acting nitrates, ranolazine, and others may prove beneficial in combination with beta blocker or calcium channel blocker as the first line therapy. وده اللي بتقوله الجايد لاينز. The strategy must be adapted to each patient, individualization of the treatment, each patient characteristics and preference, and doesn't necessarily follow the steps indicated in the figure. طيب وده واحد من الالجوريثمز اللي بتقول لو العيان زي ما قلنا هايبوتنسيف او العيان براديكارديك اذا السكند لاين ميديكيشن زي الرانولازين it can be used as a first line medication for such patients. So nice guidelines stated the same, that for people beta blocker or calcium monotherapy whose symptoms are not controlled, we can use second line medications for control of symptoms in those patients like ranolazine. ودي ال FDA prescribing information regarding ranolazine, which stated that Ranixa is indicated for the treatment of chronic angina. Ranixa may be used with beta blockers, nitrates, CCP, antiplatelets, lipid-lowering medication, ACE inhibitors, or angiotensin converting as the optimal medical treatment for patients with stable coronary artery disease. ACC stated the same and conducting the same message. Ranolazine in combination with beta blockers can be useful when prescribed for relief of symptoms when initial treatment with beta blocker is not successful. أنا أعتقد دي أهم حاجة في التوك هو المود of action of the ranolazine. We are all about that the intracellular sodium and calcium overload associated with enhancement of the late sodium current results in both electrical and mechanical dysfunction. The electrical instability includes beat to beat variability and after depolarization, which leads to arrhythmia, while the mechanical dysfunction to include reduced contractility, slow relaxation, and increased diastolic tension and pressure. الحاجات دي كلها by selectively inhibiting a late sodium channel, you improve all those bad effects. By selectively inhibiting the late sodium current, ranolazine prevents the sodium overload into the cell and preventing reverse mode of sodium calcium exchange and consequently accumulation of the intracellular calcium, and this improved diastolic tone, coronary blood flow, and also had an anti-arrhythmic effect, improved of the arrhythmias. There are some clinical trials conducted to ranolazine. Some of them are a big number of patients, more than 800 patients included, and they prove the efficacy of ranolazine in controlling symptoms in patients with chronic stable angina. هنبتدي مثلا بالماريزا trial. الماريزا trial دي كانت to assess the use of ranolazine as monotherapy in patients with chronic stable angina. It's a multinational trial, randomized, double-blind, placebo-controlled study, and it was designed to determine the dose-response relationship of the three doses of ranolazine 500 وال750 وال1000 and their effect on symptoms, on symptom-limited exercise duration and all exercise parameters. Total duration of exercise, time to chest pain, time to ECG changes. And the study proven that use of ranolazine improve the exercise time, extend the duration, and more time for first chest pain, first ECG changes. And the higher the dose, the better the results. الترايل الثانيه هي الكاريزا ترايل. الكاريزا ترايل دي اللي هي الكومباينيشن assessment of ranolazine in stable angina study aiming to compare the effect of ranolazine versus placebo على العيانين اللي اوريدي على الاوبتيمال ميديكال تريتمنت كالسيوم شانل بلوكر والبيتا بلوكر. ودي السكندري اند بوينتس فيها كانت انكلود اكسرسايز دوريشن زي ما اتفقنا وكل الاكسرسايز بارامترز. وكمان كانوا بيبصوا على التوليرابيلتي اوف ذا دراج وعلى السايد افكتس السيفتي بتاعته. الكاريزا ترايل الحقيقه ورت it was a randomized double blind parallel group placebo control trial وكان عدد العيانين فيها اكثر من 800 عيان with chronic angina واتعملت في 15 بلد وكان فيها 118 انفستيجيتورز. البرايمري اند بوينتس في الاكسرسايز ديوريشن زي ما حضراتكم شايفين الرانولازين was significantly increased الاكسرسايز ديوريشن وكمان الاكسرسايز التايم تو انجينا والتايم تو ST depression was significantly lower مع الرانولازين. وكمان it proved the safety and the tolerance of ranolazine versus placebo. الاريكا ترايل دي برايمري اوبجيكتيف فيها كان الافيكاسي اوف ranolazine in chronic angina patients. The primary objective was to determine whether ranolazine could reduce angina frequency and nitroglycerin consumption when it's added to الكالسيوم channel blocker amlodipine versus placebo. والريزلتس بتاعتها كانت very positive. Patients on ranolazine plus amlodipine have significantly lower anginal attacks and nitroglycerin consumptions compared to patients on amlodipine and placebo. التريزا ترايل دي كانت اول ترايل اتعملت على تايب 2 diabetic patients وبرضه ورت ان البيشنتس اللي عندهم تايب 2 diabetes and chronic stable angina on ranolazine plus amlodipine have significant lower anginal attacks and nitroglycerin consumption compared to patients with amlodipine and placebo. الحقيقه دي ميتا اناليسيز كان بيوري البرايمري افيكاسي اند بوينتس والسيستماتيك ريفيو لكل اليوز اوف رانولازين رانكسا فيرسس البلاسيبو في العيانين دول. ودي ورت الاوبجيكتيف منها كان systematic review was to quantify the clinical benefits of ranolazine when it's added to beta blocker calcium channel blocker. والريزلتس كانت الكومباينيشن of ranolazine added to calcium channel and beta blocker showed positive outcome across all outcomes assessed. Other combinations of beta blocker, calcium channel, long acting nitrates and others showed significant benefit for most but not all the outcome as ranolazine. So the conclusion in chronic coronary syndrome, conventional therapy with beta blocker, calcium channel blocker, and long-acting nitrates remains the cornerstone of anti-anginal therapy. Given the ranolazine, Ranexa doesn't affect the heart rate, blood pressure, or bronchial activity, it may be well-preferred agent in coronary artery disease patients with bradycardia, hypotension, or AV block, or chronic obstructive pulmonary disease, while calcium channel blocker should remain the preferred second agent after beta blocker in patients with hypertension. My final conclusion that ranolazine is well tolerated with a proven safety profile and its minimal QT interval prolongation, less arrhythmias, is without clinical sequelae and without any side effects. Thank you very much for your attention.
شكرا دكتور اسلام. يعني احنا نفهم من كده ان احنا عندنا نيو تولز في المانجمنت في الاسكيميك هارت سيز للعيانين اللي هم ريزيستنت للميديكال ثيرابي يعني. والعيانين اللي هم خدوا الرانكسا دول يعني اللي فهمته من حضرتك ان احنا ما عندناش سايد افكتس ويل نون مع الرانكسا.
Very safe.
Very safe و very effective في العيانين resistant.
أنا أعتقد لأنه خلينا نقول بس كل السكند لاين دول they are not approved in the US for example except ranolazine. يعني حتى الحاجات الكومبيتيتورز يمكن في يوروب they approved إنما in US the only approved second line anti-anginal medication بعد الكالسيوم channel blocker والنايتريتس والبيتا بلوكرز هو الرانولازين. That's because it's effective, safe and have evidence.
شكرا دكتور اسلام. مع الدكتور كريم محمود. دكتور كريم محمود, ranolazine in real life.
بسم الله الرحمن الرحيم. يعني في البداية طبعا أنا بشكر تواجدكم معانا في مؤتمر السنوي لاسم القلب، وبشكر طبعا أستاذنا دكتور إسلام شوقي على المحاضرة الجميلة اللي هي يعني هتخلي المهمة سهلة جدا بالنسبة لي. I'm going to address ranolazine in real life practice. طبعا دي اللاند مارك سلايد اللي احنا بنشوفها for different profiles of patient with coronary artery disease. احنا عندنا الهيموديناميك profiles of our patient ده بيحدد which treatment strategy we will adopt for managing symptoms in patient with coronary artery disease. ففي عندنا ال patient with high heart rate and the patient with low heart rate, LV dysfunction or heart failure, low blood pressure, in addition to the standard treatment of chronic coronary syndrome. So for the next slide, we will address some of these scenarios that show يعني ممكن فيها ranolazine ممكن يبقى a helpful drug in managing those patients. And the first scenario for a patient is which is a 42-year-old. She has uncontrolled diabetes mellitus and known to have a coronary artery disease with multiple PCI with long stents in the LAD, diffuse coronary artery disease involving the diagonal and circumflex. Presented with angina that not responding to usual medical treatment. She was treated with drug-coated balloon. However, after the procedure, she continued to have a chest pain. Her heart rate was 90 beats per minute, blood pressure on 120/80, and her ejection fraction was 55%. So the medical strategy for this patient includes dual antiplatelet in addition to statin ezetimibe to control the lipid profile. In addition, this was her medication. As you can appreciate, we reach a maximal dose of many drugs. Nebivolol 10 milligram, ivabradine 7.5 milligram twice, nitrates. So we think about the metabolic drug, which is ranolazine, and we titrated the dose up to 750 milligram twice. That helped this patient in controlling her symptoms. Still having chest pain, but with the frequency much lower with titration of this medication. And we should remember that this drug is also useful in the diabetic patient, which this patient had. And this was according to the TERESA trial that showed that ranolazine was associated with reduction of the weekly angina frequency, weekly use of nitroglycerin, and this was across all hemoglobin A1C profiles. The second patient for a 50-year-old female, she is hypertensive and obese, and she had frequent anginal episodes over the last years. ECG showed STT wave changes, however the echo was normal with no residual motion abnormality. She had coronary angiography that was normal and continued to have angina diagnosed as a microvascular angina. Her treatment includes aspirin, statin, beta blocker, ivabradine, and antihypertensive medication. After that, her heart rate was 55 beats per minute and her blood pressure 120/70. However, she continued to have chest pain. So our next choice here was addition of ranolazine. And if we look to effect of this drug in the patient with microvascular angina, the drug was associated with a reduction of the frequency of angina in association with improvement quality of life. And this was also proved objectively by improvement of coronary flow reserve. As we all know, coronary flow reserve will be reduced in patients with microvascular angina. So the drug here was beneficial for this patient with microvascular angina in addition to a low heart rate. The third case of a patient with 75-year-old, he had CABG 10 years ago. His risk factor were diabetes mellitus, hypertension, and smoking. He had angina and shortness of breath on minimal effort. Coronary angiography was done for these patients that revealed patent lima, patent saphenous vein graft to the right coronary artery with diffuse disease LCX, and the decision was a medical treatment for this patient. His ejection fraction is 35%, and he had coronary kidney disease, anemia of a chronic disease. This was the treatment strategy: heart failure medication, including ARNI, dapagliflozin, carvedilol, aspirin, statin, and ranolazine was added to this patient who is elderly patient with low ejection fraction. Based on the safety that was mentioned by Professor Dr. Islam, this drug can help this patient to control his angina symptoms. And if we look to the effect of the drug as regarding the age, the drug was associated with a reduction of, the increase in the exercise duration and increase the time of onset of angina as compared to placebo, whether this patient is young or elderly. And the fourth case is for a 54-year-old female. She is known to be diabetic and hypercholesterolemic. Her coronary angiography revealed a significant lesion in the mid-LAD, and she had a BCI to mid-LAD, and however, she continued to have chest pain after BCI, which is a usual problem that can happen for many of our patients due to the association of microvascular angina and the vasospastic angina in majority of the patients we are treating. Her heart rate was 70 beats per minute, and blood pressure was on the low side, 100/70. She was intolerant to escalating dose of beta blocker and nitrates, so addition of ranolazine 500 milligram twice helped this patient to control her angina. And if we look to the side effect from ranolazine, the drug has no significant effect on heart rate. The drug has no significant effect on the blood pressure, so this drug is hemodynamically neutral and can be given for this patient. The fifth case is a 60-year-old female. She is known to be diabetic, hypertensive, and had a severe chronic kidney disease of a GFR of 20 milliliter per minute. She presented with non-ST acute coronary syndrome and with recurrent severe angina. Her ECG showed left ventricular hypertrophy and ST segment depression. The echo showed ejection fraction of 50% and regional motion abnormality involving the inferior wall. Initially, the patient refused the coronary angio due to the risk of worsening renal function. Some fellows suggested to add ranolazine to control the patient's symptom. However, this is not appropriate in this patient, as this drug is contraindicated in the patient with severe renal impairment. And after convincing this patient, the appropriate decision was to go for coronary angiography, and BCI to right coronary artery was done. This is a text case for inquiry by the patient, the coronary artery disease patient who is stable on medical treatment, and he reads the pamphlet attached and asking about the arrhythmia that could happen with ranolazine. If we see the safety profile of these drugs, the symptomatic documented arrhythmia was not different from the placebo, and the clinically significant arrhythmia was shown to be less than placebo. So the advice for these patients that can, for the fear of QT prolongation effect of ranolazine, is to do a baseline ECG to exclude QT abnormality and to check for electrolytes before starting these drugs and avoid QT prolonging drugs, and if given any of these drugs, the QT interval should be monitored. Last but not least, this is a 72-year-old male. His risk factor were diabetes mellitus and hypertension, and he is known to be chronic coronary syndrome with patent stent in proximal LAD and some diagonal disease that was left for medical treatment. He is known to have a paroxysmal atrial fibrillation, and his treatment includes beta blocker, rivaroxaban, amiodarone, statin, nitrates. He presented with angina Canadian class 2. So is it suitable to give this patient ranolazine? If we look to the contraindication for the drugs, it is contraindicated with anti-arrhythmic drugs class 1A and class 3 antiarrhythmic, except for amiodarone. Because amiodarone have a minor effect on the QT prolongation, however, it is contraindicated with other antiarrhythmic such as sotalol. So, and if we look to the Merlin-TIMI trial, actually ranolazine was associated with a reduction of AF burden, and the attacks was less in the patient receiving ranolazine. So in the patient with a paroxysmal atrial fibrillation taking amiodarone, it is safe to prescribe these drugs, and this drug was shown to decrease the AF attacks. So to conclude, we have a drug that is a safe and tolerable anti-anginal medication, and gives us the potential to help our patient for symptomatic relief. It is suitable for different hemodynamic profiles such as low heart rate, high heart rate, low blood pressure, and low ejection fraction. It shows symptomatic benefit in special patient population such as diabetic patient, microvascular angina, and elderly patient. Some precaution should kept in mind, such as severe kidney disease, QT prolongation, and the use with antiarrhythmic medication. Thank you.
شكرا دكتور كريم. انا عندي عيان ماشي عليه مثلا بقاله سنه بوست كابج، وكان بيجيله ستيبل انجينا، ورفض يعمل حتى سي تي، ورفض يعمل انجو، وماشي كومبليتلي اسيمتوماتيك لغايه دلوقتي. طب بس هسألك، هو ايه الفرق بينه وبين الترايميثازدين؟ الاثنين ميتابوليك او ميتابوليك دراجز.
هو الاثنين both are metabolic drugs. ده بيشتغل بطريقه، وده هنا بيشتغل بطريقه. ده بيشتغل على طريقه عن شيفت في ميتابوليزم فروم الفري فاتي اسيد تو جلوكوز، وده بيشتغل على كليت صوديوم بلوكر. هيد تو هيد كومباريزون ما عندناش، ما عندناش هيد تو هيد كومباريزون. however يعني باي ترايل، يعني عندنا دلوقتي الرانولازين لما شفناه ريسنتلي عندنا مالتيبل، يعني في عيانين استفادوا منه فور سيمتوماتيك امبروفمنت، وزي ما كانت قال فعلا ان احنا ما كانش عندنا سايد افكتس ريماركابل with the use of these drugs.
طب امتى اعمل شيفت من اللو دوز للهاي دوز بتاعته؟
هو usually it's recommended ان احنا يعني to escalate الدوز، ممكن مثلا at 2 weeks intervals نبدا بالدوز اللي هي 375 ملغ twice، بعد كده ممكن up titrated to 500 ملغ. For me يعني my opinion ان احنا بن escalate الدوز according to the patient response. If we still have symptoms we can escalate the dose. However في patients ممكن بيستفيدوا من اللو دوزز up to 375 ملغ، بس يعني it's advisable ان احنا نوصل مثلا للمودريت دوز اللي هي 500 ملغ twice.
هو العيان اللي بحكي لك عليه ده بقيله على 375 ده for تقريبا يير وكومبليتلي اسيمتوماتيك.
Yes.
Any other question؟
هو شكرا دكتور كريم. هو الحقيقه انا جربته فعلا في عيان اكتاتيك كوروناريس، كان دايما بينكمبلين من ريكارنت تشيست بين. يعني الحقيقه مع 375 جاب نتيجه كويسه جدا جدا الحقيقه يعني. فهو ليه انديكيشن معينه في المايكرو انجيوباثي في الاكتاتيك كوروناريز، في العيان البوست كابج وعاملين مالتيبل ستنتنج ونوت ريسبوندنج لليوجوال ميديكيشن، يعني فليه رول طبعا.
يس هو طبعا يعني زي ما احنا اتفقنا هو از دراج فور سيمتوماتيك ريليف، زيه زي بقيه لما بنتكلم على كل الانتي انجينال دراجز، بس هو كسيمتوماتيك ريليفنج دراج اي ثينك اتس وركينج. الميكانيزم بتاعته احنا عارفينها، والسايد افكت زي ما قلنا ار فيري مينيمال.
شكرا دكتور كريم. Now we're closing the session.
Now we will move to another session, which is related to intervention cardiology, covering two important topics, spontaneous coronary artery dissection and other topic related to drug-coated balloon. I have the pleasure to co-chair the session with Professor Khalid Al-Nadi, Professor Abdullah Al-Agha, Professor Haitham Suleiman, Dr. Amir Mustafa. And it's my pleasure to invite Professor Walid Ammar and Dr. Muhammad Hosni. They are covering the topic of spontaneous coronary artery dissection, to fix it or to leave it. We will see which is should be treated conservative or not conservative intervention.
Thank you very much, my dear Professor Dr. Magdi. Thank you all chairpersons. Actually, it's a very hot topic, Fallon. A lot of controversies. Usually, patients who present with a spontaneous coronary artery dissection are high-risk patients. We usually see them in young females. To fix or to leave it, this question I will try to answer through two very complicated cases. Initially, we'll go through initial theoretical background of the spontaneous coronary artery dissection is defined as an epicardial coronary dissection that's not associated with atherosclerosis and not caused by trauma and not iatrogenic. That definition بتاعه. We have three main types of spontaneous coronary dissection. Either multiple lumens, arterial wall contrast staining, زي ما احنا شايفين أول نوع. Most common هو second type. We have just diffuse stenosis more than 20 millimeters with no evidence of staining of radiolucent flaps. And the least common is type 3, which is a localized narrowing, in which is very difficult to differentiate from usual atherosclerotic coronary artery disease. The true prevalence is not well known. It is usually underdiagnosed because we don't have this diagnosis in mind. It usually occurs in middle or low-aged females in which you do not suspect extensive coronary artery disease. Our imaging modalities, especially coronary angiography, is not sensitive enough to delineate the case in most of the cases. However, the reported cases, up to 4% of patients with ACS may have underlying spontaneous coronary artery dissection. What is the pathophysiology?
Regarding the pathophysiology of SCAD, most of the experts suggested two theories, either inside out or outside in. The more likely of the two theories is the outside in, which states that the spontaneous hemorrhages happen firstly inside the lumen due to rupture of the vasa vasorum and move forward and backward inside the wall. And this goes with the types that the most common type is type 2, which is diffuse narrowing of the vessel. The other theory is the inside out that is formed from usually like the coronary, the aortic dissection, that there was an intimal tear in which the blood goes from the lumen into the wall and forms the false lumen.
What are the risk factors to have a spontaneous coronary artery dissection? Usually we have certain cause to explain. We have a fibromuscular dysplasia or other forms of arteriopathies. We have a connective tissue disorders. We have susceptibility genes, hypertension, pregnancies. However, we have also precipitating factors in addition to these risk factors like emotional stress, intensive exercise, sex hormones, contraceptive pills, Valsalva maneuver, and something like this. The clinical presentation, usually an acute coronary syndrome. The majority of patients will have an evidence of markers elevation, whether STEMI or non-STEMI, and the minority will be presenting with a cardiogenic shock or a spontaneous coronary dissection. As you see from this slide, there is no patients with SCAD who present with chronic stable angina. You usually present with an acute coronary syndrome or sudden cardiac death or even cardiogenic shock.
Regarding the management of SCAD, unfortunately, we have no randomized controlled trials, and most of the data are derived from case series. So we have a scarcity of data. Next, please. In the most of the literature states that most of the SCAD lesions may heal, and the healing may reach up to 97% of the cases, and 5 to 10% of the conservatively managed patient may experience extension of the dissection within the first 7 days. So the patient must be kept in hospital at least 7 days, but most of the experts agreed upon that the cornerstone of the management is the conservative management, and do nothing if the patient is stable.
Because this topic is very important, we have 2 recent position papers from the American Society, from the American Heart Association, to summarize the treatment algorithm of such patients. Simply, if the patient is clinically stable and no high-risk anatomy, meaning that no left main or proximal LED to vessel disease, conservative treatment is a cornerstone with regular follow-up. If the patient is clinically stable with high-risk anatomy, left main or two vessel disease, you may consider revascularization, especially with CABG rather than PCI. Still, conservative treatment is an option. Patients on ongoing ischemia or active hemodynamic instability, these patients need urgent revascularization, CABG or PCI. We will go through rapidly through 2 very hot and complicated cases of such scenario. تفضل يا محمد.
The first case is a 40-year-old female patient. 2 months after her last delivery, she had a past history of migraine, which is a precipitating factor for SCAD. Presented with non-STEMI, her echo was normal, and her ECG showed diffuse T-wave inversion in precordial leads and inferior leads. We went for coronary angiography as a part of management of non-STEMI. We found that the RCA was normal, but the LED in the previous we can see here a staining in the left main, and so we can suspect a dissection in the left main, and in the previous picture we can see a diffuse narrowing from the LED to the distal segment of the LED. So we went through femoral approach, EBU guiding, 6 French, and we went with a BMW wire very cautiously inside the LED, and we went with an IVUS for to be sure of the diagnosis. We can see here in the IVUS, that we have a crescentic shaped hypoechoic structure encroaching on the lumen and changing its position across the clock. We can see from the start that was from 3 to 9 o'clock, and it changes along the vessel until it reached the left main. After getting the diagnosis, I stepped back and start to think what to do. And we must appreciate that any trial of PCI to a SCAD case may have a lot of complication. Iatrogenic extension of the section, propagating the hematoma upward or downward. We may put a long stents with a poor long-term outcome, and the intramural hematoma may absorb, as we said before, and we may face later on mal-stent apposition. This patient was kept inside hospital for 5 days, discharged, and 1 day after discharge, she experienced chest pain again. And this was the picture. Chest pain, her ECG showed diffuse ST segment depression, and unfortunately there was an extensive dissection of the left main in going to the LED. So this patient went for CABG immediately. 3 venous grafts were done. The surgeon told us that the operation was difficult as they found a spiral dissection inside the 3 vessels.
As you can see in Muhammad case, we kept on conservative approach. However, the cases deteriorated markedly just 1 day after discharge, and she presented again with ischemia and cardiogenic shock, and they went through a high-risk CABG surgery. This is another case of 56-year-old lady. She's hypertensive, postmenopausal, who presented with non-ischemia with normal echo, and her angio, as you can see, evidence of spiral dissection in the proximal LED involving a big diagonal branch with TME2 distal to this LED. One of our colleagues saw the case and go ahead for initial revascularization because the patient has evidence of ongoing ischemia. However, because of this multiple radiolucents and flaps, as you can see on the left side hand, once he entered with a guide wire, we have complete disappearance of the LED, extension of the hematoma and the flaps, and the patient deteriorated, and he could not achieve any further achievement, and the procedure was terminated. The patient left to the ICU with another enzyme elevation, and she was advised for CABG. However, she refused the CABG and kept on medical treatment for 1 year. During this year, she has recurrence of chest pain every now and then, and she asked for another trial of revascularization. This is another trial after 1 year. Can you let us through a femoral approach? And we tried to go through the LED again. Once we went through a guide wire, we have again complete disappearance of the LED. However, we were able to go through a diagonal branch through a true lumen. Finally, after many trials, and for the sake of the time, we achieved good true lumen recrossing through the LED, the diagonal branch, and circumflex, because the extension of the flap reached the left main and encroached even in the ostium of the LCX. After pre-dilatation of the diagonal branch, the flap moves and occludes the LED, and the reverse occurred. Once we dilated the LED, the diagonal disappeared, and so on. So we have moving flaps from the LED to the diagonal, and we have a large LED and large diagonal. We want like to fix both at the same time. Therefore, we need a two-stent technique. And the only technique that allows direct intervention without the need of recrossing and going through a false lumen is a Dickey crush. Therefore, we performed a Dickey crush in such patients as a case report for Dickey crush in the setting of spontaneous coronary dissection. We bought a diagonal stent, we fixed it, we crushed it with the LED balloon reaching the ostium of the LED, and after that, we fixed the LED with another stent, we recrossed, and we did kissing, and we did final pot, and this was the final outcome after Dickey crush from the ostium of the LED down to the mid LED, and with good protrusion into LED and diagonal branch. Our take-home message from these cases and this introduction is SCAD is a peculiar cause of acute coronary syndromes with critical consequences. They usually present with acute coronary syndromes, cardiac shock, or sudden cardiac death. The diagnosis is challenging, where coronary imaging is helpful, like IVAS in Muhammad case, however, it is not available all the time. We have a considerable uncertainty about the optimal management, whether conservative management as recommended by the guidelines, or CABG as Muhammad case, or BCI as my case, is still a matter of debate that deserves discussion. Thank you very much.
Dr. Walid, thank you, Dr. Muhammad, thank you. Yani marvelous two cases actually, and you both were brave enough to deal with that two cases. Many questions actually. The first, what's the predisposing factor that allow me to suspect presence of the spontaneous coronary artery dissection, especially which necessitates usage of intravascular imaging? What's the predisposing factor? Especially in second and third type, it's difficult to be judged angiographically. فايه العيانين اللي انا احب استخدم فيهم intravascular imaging suspecting spontaneous dissection, the second type and the third type? This is تفضل.
Thank you, Dr. Khaled. This is very important question because the first thing to reach a proper diagnosis is to suspect the diagnosis in these types of patients. In short, the precipitating factors for SCAD are females, young, in the peripartum period, usually in the third trimester after pregnancy, third trimester of pregnancy, or just postpartum. Patients who are depressed, have migraine, even if also if they are using oral contraceptive pills. All these patients are predisposing factor for having SCAD. Also, we can add connective tissue disease, or patient if it is diagnosed as fibromuscular dysplasia. These patients are very prone to have a SCAD. So if a young female like that with this predisposing factor come to us in the emergency department by chest pain, we should respect her symptom and follow up her for at least 24 hours. And if there is any suspicion in the ECG and or troponin, we should go for invasive coronary angiography, not multi-slice CT coronary.
هو actually السؤال ده أهميته برضو إن أنا suspect patient ليه؟ لأن most of the patient of the spontaneous coronary dissection presents with the acute presentation. And usage of the intravascular imaging in the acute setting is not so much recommended. We are using tools sometimes to be sure of the SCAD, sometimes to be harmful if there is a thrombus or something like this. فالانتسيبيشن ده is extremely important. أنا بس يمكن في المانجمنت أختلف مع حضراتكم شوية. يعني أنتوا قلتوا إن what looks abnormal anatomy or dangerous anatomy we have to go rapidly. Yes, high risk anatomy. الفيرست كيس في الحقيقه الديسكشن هو طبعا اول صوره اتعرضت كان فيها ريتين داي، دي معناها انها كانت محقونه قبل كده، فده ممكن يكون اتروجينيك او سبونتينيوس ديسكشن. This is not the issue. بس leaving في الحقيقه dissection in the left main even if it is spontaneous, I won't be comfortable to leave the patient to go outside the cath lab with left main. مش عارف اساتذتنا رايهم ايه في القصه دي. بس
طب انا بس هقول لحضرتك على حاجه قبل ما الاساتذه يجاوبوا. طب البيشنت at the time of the coronary angiography was off chest pain and يعني few months before I faced a patient like that and I went for BCI and it ended up with a very catastrophic يعني result. I had to use cutting balloon to decompress the hematoma and the outcome was very poor. I take the decision to go for conservative management, which is going with the expert opinion, as the patient was off chest pain and she was hemodynamically stable. And we went for heart team discussion, and the decision of the heart team discussion was to go for conservative management, follow up the patient after 1 month, and leave it to heal, as healing is expected to happen in about at least 70% of the cases. I can
هو يمكن بس الحته دايما اللي هي بيبقى فيها بايفوركيشن الشيرنج فورس بتبقى فيها عاليه جدا. يعني if the spontaneous dissection in the middle of the lead it's okay. انما at the ostium of the left main at the bifurcation of the left main of the lead with the diagonal the second case sometimes the healing بيبقى so much delayed عشان بيبقى فيه الريزيستنس بتبقى عاليه وبيبقى فيه شيرنج فورس عالي. فيمكن دي برضو the second case is very ugly and very frightening case to follow the patient يا دكتور وليد. هو طبعا احنا we have many techniques to decompress the hematoma. Sometimes starts from the distal if the hematoma is very proximal, at the inlet I mean of the dissection is very proximal. Sometimes go with the stenting from the distal to evacuate the hematoma and not to push the hematoma to occlude the artery distal. Sometimes we do this. بس برضو it was a very ugly dissection actually. يعني it's a frightening case. مش عارف رايك.
شكرا دكتور خالد.
طيب دكتور مجدي بيقول شورت كويستشن. السؤال بقى why PCI يا دكتور وليد is not يعني the first choice في حالات السكات؟ وضح لنا، هل عشان مش عارف ادخل في الترول ليومن ولا الفولس ليومن ولا عشان الهيماتوما؟ مين فيهم اللي انا بخاف منه؟
فيها lot of concerns يا عبد الله. very practical question. اول حاجه فعلا فرصه expansion of the dissection plans انك تدخل فولس ليومن عاليه جدا جدا تقريبا almost in all the cases at the time during the procedure. تاني حاجه ان الهيماتوما بعد فتره من البي سي اي بيحصل لها ريزوربشن وبيحصل اندر اكسبانشن ومال اوبوزيشن للستنت والريسك اوف ستنت ثرومبوزس هاي. النسبه كبيره من الحالات دي with conservative treatment they improve, they heal and the hematoma disappear. فالناتشرال هيستوري بتاعهم in many cases are very benign. However, you cannot predict which case will go. Muhammad case appears to be benign and she died eventually. لكن a lot of concerns regarding even الكابج برضه. الجرافس may occlude بسبب competitive flow بعد resolution of the hematoma. وبالتالي if you can closely monitor the patient with conservative management is the standard of care for the time being, except an ongoing ischemia or cardiac shock or something like that.
Thank you, Dr. Walid. Thank you, Dr. Husni. Now we will move to the next speaker. أنا بحب أقدم صديقي وأخي العزيز دكتور كريم محمود هيكلمنا على موضوع مهم كلنا بنتساءل فيه. هل ممكن نبدل الدعامة بالبالونة الذكية ولا لا؟ بالدراج كوتد بالون ولا لا؟ ودكتور كريم هيجاوبنا على السؤال المهم ده، وأرجو الإجابة تبقى يس.
شكرا يا اخويا العزيز دكتور عبد الله. يعني اجابه على سؤالك، هو كل حاجه ممكن تعملها، يعني انت ممكن تعمل اي حاجه يا دكتور عبد الله. طيب التوبيك دلوقتي هو برضو زي التوبيك اللي فات، توبيك خفيف. كان وي ريبليس ستنت ويز دي سي بي، وده برضو يعني ان احنا لما بنيجي قدام حاجه يعني او ليجن بيبقى ممكن نستخدم فيه ستنت او نستخدم فيه دراج كوتد بالون، كلنا يعني بنقف شويه كده ونستنى شويه ودماغنا بتقعد يعني نقول هل ده ينفع ولا ده هيبقى احسن بالنسبه لاور بيشنت. فاحنا we are going to address some thoughts about the DCB use that in the interventional cardiology. As we all know, DCB is a balloon, بس البالون is coated with drugs. وفي حاجه اسمها الاكسيبيانت. الاكسيبيانت ده بيبقى زي الكارير او الحاجه اللي بيلزق عليها دراج علشان نقدر ندليفر الدراج into the coronary lesion. وهو التايب اوف اكسيبيانت والكواليتي اوف اكسيبيانت ده it's very important for the quality of balloon والquality of long term outcome بتاع البيشنت بتاعنا. الدراجز اللي currently used هما الباكليتاكسيل والسيروليماس. الباكليتاكسيل lipophilic والattachment to the balloon is better. السيروليماس now through multiple technology such as nanotechnology can be used. وفي عندنا دلوقتي manufacturer of sirolimus eluting أو sirolimus coated balloon. الادفانتج اوف دراج كوتد بالون اتس نو بيرمننت بروسيسز. دلوقتي انت بنعمل البالون وبنخرجها، ما بنسيبش ميتال جوه العيان. it allows for adaptive remodeling. we can use البالون multiple time، بمعنى ان البيشنت if happen ان هو عنده a lesion in the future we can use the balloon again and again and it preserves the original anatomy of the vessel. والليميتيشن هي الليميتيشن of use of any balloon such as الامبولايزيشن والالاستيك ريكويل والريموديلنج النيجاتيف ريموديلنج، وان انت during transfer او of the balloon into the patient the drug can be lost into the circulation. So as to compare the DCB with a drug eluting stent, if we are going to use the DCB you should have some points in your mind, such as optimal lesion preparation. A DCB, it's not a balloon for dilatation. You should optimize your lesion before using a DCB. Well, pre-dilatation that can be done with the usual methods such as the balloon, and if more advanced techniques such as scoring balloon, cutting balloon, and even حتى atherectomy, you should did that before using a drug-coated balloon. acceptable angiographic results ان احنا يكون عندنا ما فيش عندنا dissection والريزيدوال stenosis يكون اقل من 30%. This is acceptable angiographic result. Some technical consideration for the use of drug-coated balloon: avoid touching the balloon during introducing the balloon into the patient. You should do adequate lesion preparation as mentioned. The balloon should be inflated once at the lesion for 30 seconds and do not go beyond the rated burst pressure لأن ده ممكن يؤدي إلى loss of the drugs. We should wait for 10 minutes after the البالون عشان for the incidence of recoil اللي ممكن يحصل, and you should have in mind the bail-out situation for stenting such as the flow limiting dissection أو residual stenosis more than 30%. If we look to the use of drug-coated balloon in the current practice, the main indication and the class 1 indication for the use of drug-coated balloon is for the treatment of an stental stenosis, whether it's bare metal stent or drug-eluting stent. Here in this case, this patient was going into the vascular surgery and have a significant in-stent restenosis, treated first with balloon dilatation using a 3.5 non-compliant balloon. Then this is the result. After the non-compliant balloon, we can appreciate that we did a good preparation for the lesion, and this is followed by a 3.5 drug-coated balloon at the site of the in-stent restenosis. ده another معرفش هي مشيت بسرعة شوية. ده another patient. This is a 42-year-old patient, diabetic with multiple BCI. زي ما احنا شايفين عندنا a long stents in the proximal, mid, and distal LED that showed a significant in-stent restenosis in multiple areas. I think the use of drug-coated balloon and avoid putting more metal in this patient is should be the strategy, and this is what we did, starting with a pre-dilatation, starting with a distal lesion, followed by 3040 drug-coated balloon at the distal lesion, and we use IVUS also for treating the lesion before the diagonal branch. As you can appreciate, we have also a lesion before the diagonal branch that is confirmed with IVUS and treated with pre-dilatation and drug-coated balloon. So, as we mentioned, drug-coated balloon is a class 1 indication for in-stent restenosis. How about the native vessels and the strategy of leaving nothing behind? Can the drug-coated balloon used for native vessels? If we look to the trials that assess the drug-coated balloon in the native vessels, the main trials investigated this in the small vessel. This is the basket small 2 trial that was the largest trial for the use of drug-coated balloon as compared with the drug-eluting stent in the vessel less than 3 millimeter, and the drug-coated balloon was non-inferior to drug-eluting stent. And doing a subgroup analysis in this trial revealed that the drug-coated balloon may be better in the diabetic patients rather than deploying a drug-eluting stent in diabetic patients. However, in the large vessels, it seems to be safe and effective. However, randomized controlled trials are still lacking. Many European interventional cardiologists are using the drug-coated balloon instead of a stent right now. However, we still wait for the randomized controlled trial. If we look to, this is an example for using a drug-coated balloon in a large vessel. This is a vessel 3O or more at the distal RCA, and they have the follow-up after 2 years that seem that the drug-coated balloon did the job and the lesion was adequately dilated and the late lumen loss was minimal in these patients. And this is a trial for the long-term efficacy of the drug-coated balloon as compared with new generation drug-eluting stent for the treatment of de novo coronary artery lesions. And it showed that the treatment with drug-coated balloon is associated with a similar risk of target lesion revascularization and lower risk of target lesion thrombosis. So for all comers, drug-coated balloon, it might be a solution. What about the bifurcation lesion? Can we use a drug-coated balloon bifurcation lesion? There is 2 strategies for that. The using of the drug-eluting stent in the main branch and using the drug-coated balloon for the side branch as a bailout, or using the provisional stenting with a drug-coated balloon and doing a kissing balloon inflation with 2 drug-coated balloons. All of this planned to use a less metal at the bifurcation. This is also a systematic review and meta-analysis assessed the use of drug-coated balloon in the bifurcation lesion. For the side branch, it was superior to the balloon dilatation at the side branch, and there was 4 trials that assessed the drug-coated balloon in the main branch that showed to be non-inferior and safe. The patient with diabetes will benefit from the drug-coated balloon. It showed numerically lower incidence of the event such as restenosis, target lesion revascularization, and the major adverse cardiac event as compared with drug-eluting stent. So the drug-coated balloon can be used also in the diabetic patient. What about the high bleeding risk? These are another patient population that can benefit from drug-coated balloon. We can use short depth in this patient we can use a single antiplatelet if we have recent bleeding or the patient would go to emergency surgery, and it's of course suitable for the patient on oral anticoagulant. Last but not least, can we use a drug-coated balloon in the acute coronary syndrome? This is a trial which called the BIBCAT non-STEMI trial that tested the drug-coated balloon in the patient with non-STEMI, and the conclusion of this trial that treatment of de novo lesion with drug-coated balloon was non-inferior to stent treatment, and this, BIBCAT non-STEMI supports drug-coated balloon only in coronary de novo lesion, especially in patients with acute coronary syndrome. However, we need also a more trial to confirm this result. And another trial that tested the drug-coated balloon in the STEMI patient was called Revelation trial. The primary endpoint was the FFR at 9 months. That was non-significant. There is no significant difference between the two arms, whether drug-coated balloon or drug-eluting stent. So to conclude, if we look to the major adverse cardiac events between the drug-coated balloon and drug-eluting stent, there was no statistically significant difference. If we look also to the target lesion revascularization, multiple trials showed no statistically significant difference. So we should put in mind some consideration for the use of drug-coated balloon in a special situation, such as a small vessel disease, meaning a vessel less than 3 millimeter, mid to distal lesions for the diabetic patients. And when doing the procedure, we should put in mind the technical points regarding the drug-coated balloon, such as adequate lesion preparation, avoid going to the rated burst pressure, and to know when to stent the lesion if we have a dissection, a flow-limiting dissection, of course, or if we have a residual stenosis more than 30%. And we should evaluate and wait for the elastic recoil that can happen as for any balloon. The patient should have a close follow-up, and the primary endpoint in this category of patient would be the target lesion failure. And thank you.
Thank you دكتور كريم. الإجابة كانت يس. Thank you. السؤال بس البرايس.
Yes.
ثمن البالونة دعامتين أو 3 دعامات صح في مصر؟ ثمن البالونة 8 دعامتين أو 3 دعامات صح؟
تمام بس
تقريبا يعني.
بالضبط.
دكتور هيثم
Thank you Karim. It was dazzling as usual. الكورنر ستون اللي انت بتقول لنا عليه هو lesion preparation.
Yes.
اعتقد هيفضل سؤال challenging اللي ممكن نعمله في heavy calcified lesion even لو هو متحقق فيه كل اللي احنا عايزينه، ان احنا عايزين نبريزيرف الاكتيف ريكويل او الفازو اكتيفيتي اوف ذا ليجن، لكن هل ده برضه فيزبل ان heavy calcified lesion؟ انا عارف ان الاجابه ملهاش دعوه بالترايلز دي، هتفرق صح. في الخبره اكتر، لكن هل ده ممكن برضه يبقى فيزبل ان heavily calcified lesion ولا لا؟
هو طبعا ده سؤال مهم، وهو القاعده طبعا انت بتعمل الليجن بريباريشن وات ايفر ات تيكس. انت محتاج نون كومبلاينت بالون هتستخدم نون كومبلاينت بالون، محتاج اثريكتومي او سكورنج هتستخدم على حسب اللي هيوصل بيك ان انت تعمل adequate lesion preparation. ده الفيرست بوينت. Regarding the use of a drug-coated balloon in this situation, we still less confident. However, يعني احنا شفنا حاجات في يوروب دلوقتي، ويمكن كان في حالة كنت شفتها لأنطونيو كولومبو patient in acute coronary syndrome واستخدم atherectomy، كان mid RCA وكان كبير، وعمل drug-coated balloon وكان ending with a non-flow limiting dissection. وعمل follow up للبيشنت ده بعد 2 months، وكان الريزلت كان دايسكشن هيلد والفلو كان ممتاز. هل نقدر نجنرالايز الانفورميشن دي؟ لا طبعا. We need a randomized control trial. However تاني انت لو هنستخدم برضو يعني المهم ان احنا نعمل good lesion preparation. After lesion preparation if you decided to use a drug-coated balloon you can do it.
Okay. Thank you dear كريم. دكتور هشام.
هو بس يعني I can understand ان احنا نعمل drug eluting balloon inside the stent for restant restenosis. بس احنا قاعدين بنعلم الناس وبنتكلم كتير قوي بقالنا سنين على الريكويل وعلى الدايسكشن that happens with ballooning، وكان الانسيدنس اوف restenosis زمان up to 50% ما حلهالناش غير وجود stents. فاذا كنا بنتكلم اوتسايد الستنتس على السمول سايز ارتريز اللي هم 2.5 او اقل، لان احنا عارفين انه الاوتكمز في الستنتنج ار يوجوالي باد. خلاص ممكن برضو نحط ده، بس in general the idea of drug eluting balloon خاصة إن سعرها at least double the stents is not very appealing to me. يمكن أنا بحب أستخدمهم في very few situations أما يكون instant restenosis وواخد bifurcation وأنا I don't want to compromise وأدخل في technical issues إن أنا أحط more metal في حتة already stenosed والارتري مش كبير قوي. But this is my feedback regarding this point. بس طبعا انا عارف ان حاليا في يعني بقوه شديده اتجاه انه كل الناس عايزين يحطوا دراج ايلوتنج بالونز، وده بتستخدم بره اكتر كمان وفي مصر ابتدينا، بس انا مش مقتنع.
هو ده ياكد طبعا العنوان بتاع السيشن اتس uncertainty interventional cardiologist. لما حضرتك طبعا يعني اتس a brilliant interventional cardiologist adopt ان احنا still not confident about the use of drug coated balloon. Still we are يعني لسه احنا عندنا we need more data. ما نقدرش نجنرالايز ونخلي دي القاعده and for the use of for all coronary lesion. However it should be kept in mind for some subset of lesions زي ما احنا ذكرنا.
دكتور هشام هقول لحضرتك حاجه. احنا we are always interested بالريكويل او بالنيجاتيف ريموديلنج او whatever after stenting. بس we have to consider the vasoactive mechanism which is disturbed tremendously لما بحط دعامه. And even this absence vasoactive response بيبقى beyond الليميتس بتاعت الدعامه. فيمكن الايشو بتاعت الدراج ايلوتنج بالون ان it allows the vasoreactivity of the vessel which is important in the coronary. يعني sometimes this is the issue of the sums who adopts even using drug eluting balloons in the larger vessels to maintain the vasoactive response.
هو النقطة برضو ان هو احد الحاجات اللي بنقولها في الدراج كوتد بالون ان احنا we can accept a residual lesion 30%، وفي بعض الريبورتس قالت انها ممكن to accept up to 50%. فيعني ده على حساب طبعا ان انا I'm not going to leave metal inside the patient. ف we still have يعني مجال في الايه في الايشو ده.
Thank you so much دكتور كريم for this wonderful presentation. So we will close this session and we have to move to the next session, which is company symposium for Sanofi. I'm inviting Dr. Hisham, Dr. Hussam Hassan, Dr. Hisham Baha.
Okay, we will be moving to our next speaker. أنا بس عايز أطمنكم، طبعا إحنا مستمتعين كلنا بالإيفنت، بس أنا عايز أطمنكم إن السيشن الأخيرة هتتأجل، مش هنعملها النهاردة عشان بس إيه يعني النفوس تهدى وكده وتقدروا تستحملوا اللي فاضل. إحنا يعني طبعا هو في جالا دينر اللي طبعا يحب يجي. السيشن الجايه بروفيسور وليد عمار will be giving us new frontiers for high cardiovascular disease risk patients with role of PCSK9 inhibitors and the possible clinical benefits out of it.
شكرا استاذ دكتور هشام صلاح for kind introduction. شكرا شركة سانوفي على الدعوة الكريمة، وإن شاء الله كده in the coming 10 minutes we'll go briefly through the evidence for high risk patients, how to manage their dyslipidemia, which is a very important topic as we all know. طيب لغاية ما يظهروا كده دكتور مجدي، احنا جوعنا قوي. طب قول
رأي
حاجه
الناس
ناكل
تاكل دلوقتي عشان ايه يهدوا.
طيب بسم الله الرحمن الرحيم. طيب cardiovascular disease is a leading cause of death worldwide and also in Egypt is a worldwide and the Egyptian first cause of death. It represents 37% of total deaths. 37% من all deaths are related to cardiovascular disease. مش بس كده, the incidence of cardiovascular disease will increase or have been increased by 30% من 2020 ل 2023. Dyslipidemia in Egyptian population presented with ACS from an Egyptian study 50%. About 50% of our patients with ACS had evidence of dyslipidemia. وطبعا coronary artery disease هو the first cause of death in Egypt. Among all the risk factors for coronary artery disease, high LDL is still the first cause as a causal and a modifiable cause. دي ما ميزة ال LDL ان هو major risk factor لكن هو at the same time modifiable risk factor. You can modify LDL relationship to coronary artery disease. We have evidence through huge trials, more than 200 studies, recruiting more than 2 million of participants, أكثر من 150,000 cardiovascular events. Through these trials, you're using different treatment modalities with statins, combinations, or BCSE targeted therapy. We have a dose-dependent log linear relationship between absolute magnitude of exposure to LDL and the extent of coronary artery disease. المعلومة المهمة بقى إن with each 1 millimole reduction of LDL يعني 38 milligram of LDL reduction, you can achieve a significant reduction of mortality by 15% and the major adverse cardiac events by 20%. In our daily practice, and this is an Egyptian population from the Dyslipidemia International Study recruiting patients from Egypt, زي ما احنا شايفين هتلاقي ان عندنا about 95% of patients on moderate or high dose statin. وبالرغم من كده achievement of the target was only achieved in 28%. يعني 72% of our patients failed to achieve their target despite using a high dose of statin. Less than 1% of this study of Egyptian population was using more advanced therapies like BCSK9 inhibitors in such a trial. طيب. ليه الstatins did not achieve the target? What about the adherence and compliance to statins? After 1 year, we have a relatively good adherence to statins, reaching about 80% for either statin, ezetimibe. لكن after 1 year and up to 5 years, we have a marked reduction of adherence, going down up to 60%. Our patients after 5 years, only 60% are still on statins, and the same for ezetimibe. Right. Da Vinci study is a well-known trial trying to address how many patients on statins will achieve a target LDL in overall population and in patients with established coronary artery disease. والارقام زي ما حضراتكم شايفين just 1/3 of patients on high dose statin achieved a target LDL. والpatients اللي عندهم established coronary artery disease in which you would like to achieve an LDL of 55 milligram, just 18%. Very low figures. Why is this? Because initially lack of health care providers for familiarity with the guidelines, cost limitations, patient reluctance, nocebo effects regarding side effects. In overall, in real practice and in well-conducted trials, achievement of target LDL was minimal, 18% in patients with established coronary artery disease. Even in interventional trials, when patients used atorvastatin in the active arm compared to standard therapy, yes, atorvastatin achieved a 17% relative risk reduction of major adverse cardiac events. However, still we have a 30% residual risk. In best practice, when you are prescribing a good dose of atorvastatin, still your patients over 6 years have a 30% residual risk of cardiovascular events. And how can we improve? We would like to reach our targets
And the target now, as you all know, we have to achieve the two limbs, 50% at least reduction of baseline LDL and going down below 55 milligram of LDL. These patients, not only those with established coronary artery disease, but we have other patients who are considered very high risk, like patients with familial hypercholesterolemia with another risk factor, patients with severe coronary kidney disease, patients with diabetes and organ damage. These patients need these high levels of achievement of LDL below 50%. And the guidelines are clear. It's class 1 recommendation to start high intensity statin for all patients with ECS. And if not achieved a target, you add initially ezetimibe. And if not achieving our target with a combination, here it is clear you have to start a PCSK9 inhibitor like alirocumab. Does it have a role in primary prevention? Yes. Alirocumab can be used in primary prevention in two settings. Patients intolerant to statin, yes, you can start from the beginning. Patients at high risk is class 2B, you can start. But patients with familial hypercholesterolemia, heterozygous, and other risk factors, this class 1 recommendation. Yes, and even in primary prevention, it's indicated in very high risk patients. The early period after ECS is very risky period. These patients have initially 10% mortality, and after 5 months another 7% mortality, and in the following year another 12% mortality. Therefore, this first year after acute coronary syndrome represents a very crucial period in patient history with high cardiovascular events, in which you have to achieve a target as early as possible to decrease these effects. Patients who are hospitalized with an ECS while they are on high dose of statin, and you find an LDL target that are out of our targets. In this patient, you are justified to start PCSK9 alirocumab very early, even in hospital during hospital stay. You can start it very early with class 2 recommendation if the patient was on statin at hospital admission. In other patients in which you started with statin ezetimibe, you follow this patient after 4 weeks to 6 weeks. If the target was not achieved, it is justified class 1 recommendation to add PCSK9 inhibitor like alirocumab. And this is a position paper and treatment algorithm according to the baseline risk of patients presenting with ECS. Look at the left side. If the patient is extremely high risk from the beginning, you are justified to start from day 0 PCSK9 in addition to statin and ezetimibe. Who are these patients who are considered extremely high risk? Patients with ECS and previous coronary events, patients with ECS and other vascular events or multivessel disease. These patients represent a high risk group in which you can start with a triple therapy. And if you think these patients need a reduction of 80% of LDL, you cannot achieve this with the combination therapy, when in best hands you achieve 65%. And if you need more than 65% reduction, you are justified to start in such high risk patients a triple therapy from the beginning. Alirocumab was studied initially in the Odyssey clinical program, 5 landmark trials in phase 3 multi-center trials, in which 3 trials used up titration from 75 to 150. The standard dose of alirocumab at the beginning is 75 milligrams every 2 weeks, and the patient is not at target after 2 months, you upgrade to 150 every 2 weeks. The other 2 trials started from the beginning with the high dose of 150 milligrams every 2 weeks. This represents the patient population in the phase 3 trials. As you can see, 55% of patients had established coronary artery disease, 36% of patients have familial hypercholesterolemia heterozygous, and 31% of patients have diabetes mellitus, very high risk group. And this patient population outcome opens the door for the Odyssey outcome trials, the largest trial for PCSK targeted therapy with cardiovascular outcomes as an endpoint. 100% all the patients in the Odyssey outcome trials have evidence of previous MI or unstable angina. 90% were on high dose statins, either atorvastatin 40 to 80 or rosuvastatin 20 to 40 milligram per day. And patients were allocated randomly to either alirocumab or placebo plus standard of care, and all the patients were in maximally tolerated statin dose. The primary endpoints were a combination of death, non-fatal MI, fatal and non-fatal stroke, or unstable angina requiring hospitalization. What happened? If the patient started the therapy, our target is to go down with an LDL from 25 to 50. This is our target. All patients as a baseline above 70. If the patients at follow-up have an LDL below 15, this is considered risk situation in which you hold the treatment. If the patient's LDL from 15 to 25, this is an acceptable range. However, the target range in the study was 25 to 50 milligrams. At follow-up, we have 54% reduction in the mean LDL. And after 3 years in patients with regular follow-up for sustainability of the lowering of the LDL, we have 62% reduction of the LDL with alirocumab compared to standard of care. And the MACE, after 4 years of follow-up, we have 15% relative risk reduction of major adverse cardiac events. The number needed to treat is 49. But subgroup analysis of the ODYSSEY classified our patients according to the baseline LDL, below, above 70, 70 to 100, and above 100. The most cost effectiveness was achieved if the baseline was above 100, as you can see here. The major adverse cardiac events reduction was 24%, with an absolute risk reduction of 60%, and the number needed to treat dropped from 49 to 60 to 16 patients. Now, in these subgroups of patients with a baseline LDL above 100, despite good dose of statin, it's very cost effective to start PCSK9 alirocumab in such patients. Alirocumab in this ODYSSEY outcome trials achieved the reduction in all-cause mortality from first year in the overall population, and after 3 years it reached 22%, and in patients with a baseline LDL more than 100, very cost effective, 29% reduction of all-cause mortality. What about the adverse events? Just for local injection site reaction, no other adverse events was statistically significant between alirocumab and the placebo. There is no increase in the new onset of diabetes, no increase in the hemorrhagic stroke, no increase in the diabetic complications, and no increase in the risk of neurocognitive dysfunction. It was very safe medication. What about achievement of the LDL targets in the patients? We have two targets, either 55 milligram or 40 in patients at high risk or subsequent events. Compared with standard of care with high dose statin, those allocated to alirocumab, 94% achieved LDL reduction with alirocumab, and 84% achieved a target of less than 40 milligram with alirocumab. The number with standard therapy with statin was much lower than alirocumab. Finally, to conclude, in the modern concept of lipid lowering strategies, the lower the better. The lower the better. Why? Because we decrease the cardiovascular events. The earlier the better. We have to start early in high-risk patients. We can prevent lesion formation from the beginning, and the longer the better for sustainability of LDL elimination of the blood. Overall, we can decrease hard endpoints like mortality and myocardial infarction. And thank you very much.
شكرا جزيلا يا وليد على المحاضرة القيمة دي. في حد عنده أي أسئلة؟ طيب, just for the sake of time, we will be moving to our second speaker.
Now the second speaker for this session is Professor Sameh Al-Affas. He will speak about evidence-based management of antithrombotic therapy, Bayer Symposium.
Slides up, please.
مساء الخير جميعا. اشكركم تاني على استضافتي واشكرك دكتور هشام على التقديم. دكتور هشام نورتونا تاني. طيب يعني البرزنتيشن النهارده ما فيهاش كلام كتير جديد، بس هنتكلم فيه عن اهم ريشيو في الطب. ايه اهم ريشيو في الطب بالمناسبه؟ ريسك بنفيت ريشيو، او بكلام النواكس السيفتي افيكاسي ريشيو. لان الحقيقه اظن ان اغلب وقتنا في العياده ان اور براكتس بيقضى فيه ان احنا بنحاول نقرر الريسك بنفيت ريشيو اوف اني انترفنشن وي دو، سواء ده كان من اول طبعا ادويه لانترفنشن في القسطره، ايفن حتى لايف ستايل موديفيكيشن، لما انصح مريض يعمل رياضه، لما انصح حتى ده في ريسك بنفيت ريشيو. فموضوع الريسك بنفيت ريشيو دايما كان بيشغلني، وكان دايما ويمكن في الفتره الاخيره قبل ما نتكلم عن واكس وده الموضوع الاساسي هنتكلم على الاسبرين، اسبرين بروتكت. من منا ما زال يستخدم الاسبرين بروتكت ان برايمري بريفنشن؟ تمام، بقوا اقليه. اوكي طيب انا هطرح سريعا كده 2 كيس سيناريوز ونشوفهم، يمكن ده يوضح الموضوع بسهوله. A female patient 70 years old, chronic kidney disease stage 3, diabetic, hypertensive, family history of ischemic heart disease، وهي بتتابع حكت ان هي جالها episode of hematemesis بعد gastroenteritis. الريسك بروفايل زي ما احنا شايفين في العينه دي، الريسك of cardiovascular disease is actually very high من الايدج، من presence of المالتيبل او multiple risk factors in this patient. She is at high risk for developing cardiovascular events. وفي نفس الوقت جالها اتاك اوف هيماتيمسيس. وضغطها ما كانش مظبوط، الكرياتين بتاعها كان عالي، البليتلتس واطيه. وانترستنجلي on history taking she has been on low dose aspirin for the past 12 months under recommendation of a relative physician. انت سن كبير ولازم تاخدي الاسبرين علشان الوقايه. ما رايكم؟ اسف. Was the decision of low dose aspirin administration wrong كلمة تقيلة؟ Was it not really appropriate for this patient? And should we stop aspirin? أظن yes. She developed hematemesis، عندها risk factor، مع إن أنا لسه بقول إن ال cardiovascular risk profile of this patient is very high. She's at very high risk of developing cardiovascular events. But again, the other arm of that balance, of that ratio, which is the safety is not there, because ببساطة شديدة her risk of bleeding is too high. وده actually اللي حصل، وده احنا شفناه بنفسنا. فاسبرين طبعا ستوب، وبرايمري بريفنشن هنا باستخدام الاسبرين is not really there. ونفس السؤال بطريقة تانية، هل الديسيجن ده احنا خدناه بسبب ان she developed an attack of GI bleeding؟ يعني لو ما كانش حصل الابيسود ده كنا ممكن نقول لا خليها على الاسبرين ده يحميها من الجلطات. اظن برضو الاجابه از بي. حتى لو فكرنا ان القصه لا، طب ما ممكن نديها بروتون بامب انهبيتور فبالتالي نقلل فرص حدوث الجي اي بليدنج، برضو لا، الريسك اوف بليدنج از ذير. حتى يمكن يعني طبعا هو از نوت cannot be applied in this particular patient. استخدام البليدنج ريسك سكورز ان جنرال زي بريسايز ده هتطلع a very high risk patient. فالريسك اوف بليدنج طالما ان هو يفوق البريفنشن بنفيت يبقى ديفينتلي ات از نوت. وده كان البيز ورا ليه الاسبرين ابتدى ينسحب من البرايمري بريفنشن سي. اون ذا اذر سايد زي ما احنا شايفين الجايد لاينز دلوقتي، this is the American College of Cardiology of 2019 محطوطه بوضوح شديد not at increased bleeding risk. ممكن نستخدم الاسبرين for primary prevention، this is class 2B، والشرط not at increased bleeding risk. نحاول اغير من ده. والايج زي ما انتم شايفين 40 to 70 years of age. ده برضو مقرر في American Diabetic Association. تاني aspirin can be considered as primary prevention in diabetes, but again increased cardiovascular risk. بس لازم البنفيت versus the comparable increased risk of bleeding has to be discussed with the patient. اليوروبيان برضو ماشيه في نفس الاتجاه. Patients with diabetes with high or very high risk, again aspirin class 2B may be considered in primary prevention in absence of clear contraindications. My second case مختلفة. 54-year-old male patient, heavy smoker, overweight, high cholesterol level, كرياتين كويس، وهو كان داخل المستشفى لسبب تاني chest infection. هذا الشخص عنده family history of coronary artery disease that was positive prematurely. وما احنا بنتكلم معاه ان his lifestyle هو كمان his diet is high in fat، وهو بيشتغل شغل مكتبي is a bank employee، ما بيعملش physical activity، وبالتالي الدكتور اللي بيتابعه طلب له ستريس اس جي that came out negative. الجمله الاخيره دي عندي انا كالسيوم سكور، وده واحد من الوسائل المهمه الحقيقه في ريسك ستراتيفيكيشن. دورنا في هذا الشخص مش عايز اسميه مريض for estimation of his cardiovascular risk profile or cardiovascular risk in the next 10 years السكور او الفرامنجهام ريسك سكور او البولد كوهورت كرايتيريا عباره عن وسيله كلينيكال نقدر نستيميت الريسك، وبالتالي نقدر نحطه هل هو محتاج اجريسيف برايمري بريفنشن ولا مش محتاج. وجود كالسيوم سكور في رايي انا وراي الحقيقه اغلب الليترشر بيحطنا في منطقه جراي زون ما بين البرايمري والسكندري بريفنشن. لان دايما لما بنتكلم عن سكندري بريفنشن في عرفنا وفي الجايد لاينز بنتكلم عن سكندري بريفنشن افتر ا كلينيكال ايفنت، يعني a patient who developed already coronary artery disease او عارفين كده. ولكن الكورونري كالسيوم سكور هو بيشاور لوجود الديزيز الكورونري اثيروسكليروزز ولكن without events، فبيخلينا دايما في جراي زون. والحقيقه in my current practice ده ابتدى يغير شويه قرارات. المريض او الشخص ده سالنا هل should I receive aspirin as prophylaxis؟ هل نحط ستاتنز ونقول له بطل تدخين، ولا لو دوز اسبرين مع الستاتين لايف ستايل موديفيكيشن ان جنرال؟
طب ناخد فوتنج كده.
مين ايه؟ اللي يختار ايه؟
مين يختار ان ندي ستاتنز بس؟
اوكي.
طب مين يحب يدي لو دوز اسبرين ستاتنز اند لايف ستايل؟
ده في ناس مش هتشوف المريض اصلا.
طيب
اوكي.
هو بس السؤال يا سامح، هو هنا are we justified as per guidelines ان احنا ندي low dose aspirin ولا لا؟ ليه؟ The patient is not diabetic.
Yes.
خلاص؟ عنده risk factors انت قلتهم مهمين جدا اللي هم family history وكالسيوم سكور عالي مش كده؟
كالسيوم سكور عالي is actually
والكوليسترول عالي
شويه بالظبط.
والكالسيوم سكور العالي ده بيحطنا ازاي؟ It's a risk modifier.
بالظبط.
It's not a risk factor, it is a risk modifier. لما ابقى في الجراي زون الفاميلي هيستوري is a risk modifier.
بالظبط.
الكالسيوم سكور is a risk modifier. فانت هنا تدي اسبرين ولا لا؟ اكيد.
انا ادي اسبرين. انا بدي اسبرين. ليه؟ لان تاني نقطه وجود الكالسيوم سكور، انا طبعا بايظ بشغلي في السي تي، ولكن الحقيقه وجود الكالسيوم in the coronary is actually the disease itself.
Are we protected by guidelines؟ يعني لو انت اديته حبايه اسبرين دلوقتي وجالك بينزف من مناخيره ومن
النقطه دي هي اكشلي جايد لاينز بتقول ايه تاني؟ هي نفس الجايد لاين. It is class 2B. This patient is not at increased risk of bleeding، ولكن هنحسب له السكور، والسكور لو طلع اكتر من 10% in the next 10 years of developing cardiovascular disease then we should give as much as we can. Definitely lifestyle modification, definitely statins, and I would give aspirin لان تاني الجايد لاينز حطينا في كلاس 2B. نفس القصه جايد لاينز مش عايز اعيد for the sake of time. واظن خلصنا الموضوع الكونتروفيرشال والموضوع السهل. مستر امين عنده 80 سنه، نون فالفر اي اف دايابيتيك اند هايبرتنشن. مشاكلنا مع مستر امين الحقيقه في سباف والستروك بريفنشن اتريال فابريليشن is his age and the presence of comorbidities. والايدج الحقيقه عندنا ستيجما كبيره، لان المرضى اللي سنهم كبير فوق سن ال 75 الحقيقه على قد ما هم at increased risk of bleeding they are at a much high risk of developing of thromboembolic events. زي ما احنا شايفين هنا دي ستادي من يعني ريل وورد براكتس السفير اي سي بروسبكتيف ستادي قرب ال 2000 مريض. التشانس باسك سكور بتاعها كان 5 المين، والمين ايج 86 years. Again the presence of major bleeding intracerebral bleeding كان اقل فيفرز ريفاروكسابان فيرسز الوارفرين او الفي كي اي، مع ان الاسكيميك ستروك والمورتاليتي كانوا مش سيجنيفيكانت، بيميلوا طبعا ناحيه الريفاروكسابان. النقطه الاساسيه هنا ان السن should not be الفاكتور الوحيد اللي انا بقيم عليه المريض هيستفيد ولا لا او في خطوره ولا لا من البليدنج مع ريفاروكسابان بالفول دوز. لو كان الرينال فانكشنز جي اف ار كويس we should give the 20 milligrams and this is a very important point. نفس القصه البريفير اف والبريفير اف prolongation reduction of the major bleeding والاسكيميك cardiovascular events دي كانت composite end points الاثنين مع بعض. ديفنتلي زي ما انتم شايفين في وسط النواكس كلهم الريفاروكسابان كان هو اللي عنده الافضليه ان فيفرنج ان ذات كومبوزيت اند بوينت كانت افضل مع ريفاروكسابان فيرسز البي كي اي، ودي لم تتحقق مع الدابيجاتران والابيكسابان. The other challenges are the comorbidities. The presence of diabetes with AF رقم كبير around 1 third of the patient زي ما احنا شايفين في الجارفيلد اي اف اوربت around 20 to 40%، 20 to 30% في الجارفيلد، و around تلت العيانين في الالكترونيك هيلث ريكوردز. طبعا الدايابيتس بيعمل مايكرو فاسكولار كومبليكيشنز وماكرو فاسكولار كومبليكيشنز، واللي بيهمنا في الاي اف طبعا الماكرو فاسكولار والستروك. That risk is too high. في الروكت السب جروب اوف اي اف patients with diabetes زي ما انتم شايفين استفادوا مش بس في البريفنشن اوف ستروك والسيستميك امبولايزيشن in reduction of cardiovascular death بالريفاروكسابان فيرسز الدي كي. والاذر كوموربيديتيز وجودها تاني لازم نحطها in any evaluation of an AF patient لان ده جزء من the whole evaluation of the patient. وبالمناسبه هنا الجمله الطويله اللي موجوده في البوكس الاخضر ان البليدنج ريسك ريدكشن with NOACS was similar في كل الدايابيتكس والنون دايابيتكس، والحقيقه ده لم يتحقق في الابيكسابان. الجمله هنا نفي اثبات. lower reduction in hemorrhagic was reported، يعني الاقلال من المضاعفات النسفيه في المرضى الدايابيتكس ما كانش اقل من النون دايابيتكس في العيانين اللي كانوا على ابيكسابان. طيب الحقيقه وجهه نظر اخرى، وجهه نظر المريض من الكوموربيديتيز اللي بتخوفه جدا as a diabetic patients are the adverse limb events. الامبيوتيشن، اي diabetic patient بيبقى خايف دايما من مشاكل القدم السكري والامبيوتيشن. وتاني ريفاروكسابان احنا عارفين من وجوده ان هو بيدي بنفيت في الميجر ادفيرس ليم ايفنتس، وحتى في الدوز بتاعه الاتريال فايبريشن في السباف هو بيدي فيري جود بروتكشن. These are the patients with diabetes والميجر ادفيرس ليم ايفنتس زي ما احنا شايفين very significantly in favor of rivaroxaban versus warfarin. فهو الحقيقه بيدينا بروتكشن مش بس في الستروك بريفنشن، لا كمان في الميجر ادفيرس ليم ايفنتس. وتاني نفس القصه there was significant reduction of MACE and MALE compared with warfarin in this study في patients with non-valvular AF and type 2 diabetes mellitus. Our last case is Miss Hudan. She is 65 years old, non-valvular AF and creatinine 1.4. ايه رايكم في الكرياتين؟ Does that qualify her ان هي يكون عندها some sort of chronic kidney disease؟ bearing in mind السن احنا دايما لازم نفكر في الحقيقه مش بس كرياتين، لازم نحسب كرياتين انكريز جي اف ار. هو ده الحقيقه الكلمه المهمه في deciding the dose and reduction of the dose if needed in a patient with non-valvular AF. renal impairment طبعا this is a challenge، واحنا عارفين ببساطه شديده ان الايفكت اوف النواكس وسبيشال ريفاروكسابان on the renal outcome in patients with non-valvular AF is actually marvelous. حصل ريدكشن محترم in development of acute kidney injuries and stage 5 chronic kidney disease or need for dialysis favoring rivaroxaban versus الوارفرين. وتاني زي ما احنا شايفين الريلودد مثلا برضو قالت نفس الكلام، الريفاروكسابان والناحيه الثانيه الابيكسابان حصل عندنا ريدكشن طبعا في الاند ستيج رينال ديزيز والدياليسيس في الرينال سب ار. خلي بالكم ان الرينال سب جروب ده اللي هو تاني رو ده ببساطه ده العيانين ان هم اوريدي نون عندهم كرونيك كيدني ديزيز، فالنيد فور dialysis this patient was much better with rivaroxaban. واخيرا الياو طبعا الستادي الكبيره المالتي، يعني ببساطه احنا لازم نفهم ان استخدام النواكس in patients with non-valvular AF مش بس يؤدي الى ريدكشن في السباف، السيفتي وان احنا ناخد اوتكم كويس على الميل على الليمبز على الكدنز is there. It is not just prevention of stroke. Over time in NOACS, particularly especially dabigatran with rivaroxaban associated with lower risk of adverse renal outcomes than warfarin in patients with AF. أشكركم شكرا جزيلا.
Thank you, Dr. Sameh. Yani, I think it's thoroughly has been discussed all the points, and I don't think anyone has any questions. So I think we can conclude this session. Thank you so much, and we move on for the next session, which is going to be the interesting cases for intervention cardiology.
احنا ده ان شاء الله اخر سيشن، وبعد كده في اللانش هيبقى اوبن بوفيه هنا، وبعد كده هيبقى في الجالا دينر 7:30 ان شاء الله، وهنكمل مع بعض لغايه الساعه 10 يعني ما تقلقوش، يعني قربنا فاضل 4 ساعات بس ال4 ساعات هيبقوا بقى ما فيهمش اي حاجه ساينتفك، هيبقى كلها بقى اكل وفرقه وحاجات كده بعيد عن عن العلم يعني. فكل واحد يعني قاعدين مع بعض شويه. مش انت we can start this session, okay? Good.
We came to the last session and this very elegant meeting. It's my pleasure to introduce the first speaker, who is one of my close friends, my brother, Professor Dr. Ibrahim Yassin, one of the pioneers in the field of interventional cardiology. Usually presents surprises. We are all waiting for your new surprise, Dr. Ibrahim. اتفضل.
السلام عليكم. بنشكر طبعا اسم القلب العريق بالقصر العيني على الدعوة الكريمة، وبنهنيهم على المؤتمر السنوي بتاعهم، وطبعا الشكر الموصول لاخويا وصاحبي دكتور وليد ودكتور كريم محمود على الدعوة الظريفة. Could we start? Our cases is a disaster complications in intervention. Let us to start. Take care during passage of a stent through a previously deployed stent. You have to be cautious. Proper dilatation of the stent with NC if recently deployed, and with NC followed by DCB if previously deployed more than 1 month, if under deployment is suspected. Otherwise, you will face such horrible situation. In a setting of TAB stenting to distal left main through a radial axis 6 French, positioning of left main stent to LED with guidance of floating wire in the aortic root. Inflation of the stent, distal optimization, both rewiring of the LCX across the left main LED stent, and the opening of the strut with 2.5 by 15 balloon. Unfortunately, the LCX wire was lost during pulling back the balloon of LCX. After rewiring again of the LCX, the operator couldn't pass the LCX stent. It stopped at the ostium of the left main. He suspected a substrut position. While retrieving the stent is sticked by the proximal strut of the left main to LED stent. Forceful pulling lead to slippage of stent from its balloon and the loss of the LCX wire. شايفين الستنت؟ في الجايدنج وفي الستنت ليفت مين ال دي، وفي ستنت في الدايره دي سلابد ستنت من الواير والبالونه بتوع السي اكس. What to do? Any suggestion?
ترابد بالليفت مين ستاند، يعني هي واقفه في البوزيشن ده ازاي؟ ماسكه في ايه؟
ممسوكه في يعني هو الواير بتاع السي اكس خرج فرجعه وبعدين بيخش بستنت السي اكس. فمش راضيه تخش، فعارف ان هو سبسترات فبيسحب، قامت مشبوكه هوجد في الستنت بتاع الليفت مين ال دي. فهو دلوقتي كل الموضوع فبدا يسحب شويه، فلما سحب الواير والبالونه زي ما احنا شايفين بتوع السي اكس خلاص لوست.
تمام.
نعمل ايه؟ جراحه؟
لا لا لا
سنير. اوكي.
But I would recommend a good post dilatation pot for the left main stent before pulling this one.
Yes.
Not to avoid the left main stent.
في اللحظة دي I was called for help. After putting stent of left main, rewiring of the CX is mandatory here. So I used the pullback wire technique to wire the LCX. Passage of free balloon LCX to be sure ان انت من الستنت بتاع ال دي ليفت مين ال دي مش من تحتها. هنا بقى لازم يبقى فيه في البوزيشن ده، يبقى لازم يبقى عندي تيم وورك. التيم وورك هيشتغل بايه بقى؟ هشتغل ببينج بونج تكنيك. انا هسيب الاوبريتور الاولاني هقول له انت خد الجايدنج بتاعتك بتاع الكورونري وحط لي وايرين فيهم، وانا هخش بجايدنج ثانيه من الفيمورال اكسس وهبدا اعمل سنيرنج للستنت الاولانيه. طيب انا هعمل كده ليه؟ علشان امنتين البيتنسي وانا بشد انا ما اعرفش هيحصل ايه، فهو يبقى اوريدي عنده اكسس للكورونري بواير موجود. ده هوم ميد ستنت فيلد، فانا شفتد لاي ان سنير وبدات اسحب جنتل بريشر، لا دي ماسكه جامد. فبدات ده الاسامبشن اللي انا كنت متخيله ان الاستنتين شابكين في بعض بالمنظر ده، فانا بدات احاول اعمل unlocking بان اند اوت فاين موفمنت وذ فاين روتيشن فيلد. فبدات اسحب مور فورسفul برضه مفيش. وات تو دو هير؟ السيتويشن دلوقتي اللي انا ترابت فيه ان الستنت بتاعتي انا بشد هي ماسكه جامد، وانا عندي ريسنت بوزيشن ستنت في ال اي دي، فانا لو شديت جامد هعمل افالجن للستنت ويز اتس كاتاستروفيك كونسيكونسز، هتبقى المشكله هتبقى اصعب واصعب على العيان. هعمل ايه؟ فانا ده بقى التكنيك اللي احنا بنتكلم عليه دلوقتي اللي هو فيكس اند بول تكنيك. انا هبدا اثبت الدعامه القديمه واسحب الدعامه الجديده. فده المنظر. طيب اثبت على ال اي دي ولا اثبت على السي اكس؟ لو ثبت على ال دي يبقى انا هسحب في نفس الاكسس بتاع الستنت، فمن السهل ان انا اعمل افالجن للستنت. انما لو ثبت على الليفت من سي اكس يبقى انا غيرت الاكسس بتاع البولينج بتاعي، يبقى انا بشد الستنت دي وانا مثبت في اكسس تاني، هتبقى صعبه جدا ان انا اعمل لها افالجن. وده اللي احنا عملناه. فده الفيكس اند بول تكنيك. هبدا اسحب مش راضيه تيجي، واحنا بنسحب جامد جدا فمش راضيه تيجي، فدفليت البالون شويه، leave الهارت to take a press and again finally it was gotten out. What to do immediately after that? It is a two operator working technique. الاوبريتور الاولاني والرابيدلي ديفليت البالون، خلاص لازم انزل بالبالونه بسرعه. الاوبريتور الثاني هيبدا يسحب الستنت يدخلها جوه الجايدنج، ولازم يعمل الكلام ده في الديسندنج اورتا. لو عملته في الاسندنج اورتا والستنت دي مايجريتد منك يبقى العيان دخل في ستروك. طيب لما انا عملت فيكسيشن للبروكسيمال بارت بتاع الستنت بالبالونه للسي اكس هيحصل ديستراكشن وديفورميتي، هيحصل ديفورميتي في البروكسيمال بارت اللي هي في الليفت مين. I can fix it again in a clot technique from the ostium of the left main to the CX، وما اعملش ديستراكشن للجزء من الستنت اللي موجود فين؟ في الاوستيوم بتاع الليفت مين. ده المنظر بعدها immediately stenting in a clot technique, kissing, final bot, and this is final result. The second disaster, previously deployed stent with apparent under deployment with significant ISR, BTCA from the distal to the proximal, under deployed. Result after the BTCA, the operator decided to stent distal segment to the second metal layer. He failed to pass stent distaling, trying to retrieve the stent ended بالمنظر اللي حضراتكم شايفينه. ده الديستال نوب بتاع البالونه بتاع الستنت بادئه من هنا ستيل مشبوكه في البروكسيمال والستنت على البالونه، وبعدين الجزء ده مفروض كله لحد ما شابك في البروكسيمال بارت اوف ذا ستنت. زي ما حضراتكم شايفين كده ده البالونه الستنت بدايتها اهي وماشيه كل ده، بعدين بدا يسحب بعنف اكتر اندد بالمنظر ده. بقت الستنت طالعه من ال دي ليفت مين اسندنج اورت. نفس التكنيك، رجع انت وايراتك امبريلا هاندل كيرف زي ما حضراتكم شايفين. التيب بتاع الكيرف ده بوليمر جاكيت واير بامبريلا هاندل كيرف. رجع لي، وطبعا ما اخشش بواير بكيرف عادي عشان ما اخيطش الستنت. امبريلا هاندل كيرف بقيت في الديستال ال دي، انا جاي ببينج بونج من الاذر فيمورال سايد with الان سنير كابشرنج الستنت، وبعدين بدات اجهز نفسي، فانا حاطط البالونه بتاعت اللي هديها عشان هنفخ على الديستال ال دي الدعامه اللي انا همسكها، والسوفت ترايل الستند جت معايا. بعد كده كملنا البروسيدور بتاعنا زي ما حضراتكم شايفين، وده الفاينل ريزلت. طيب لو انا ما استخدمتش البينج بونج تكنيك هيحصل ايه؟ هوري حضراتكم ده نفس السيتويشن. لا الفيلم ده مقلوب. اوريه لحضراتكم كده.
The message is clear يا دكتور ابراهيم. حضرتك بتقول لو ما عملناش البينج بونج تكنيك وممكن يحصل افالجن،
يحصل سيفير ديستراكشن للستنت دي، واضحه جدا في الحاله دي. اديته قرر ان هو يعمل بس الصوره مش معدوله، مش عارف ليه الصوره دي مقلوبه، انا مش حاططها كده.
هو دكتور ابراهيم thank you for يعني these cases and the handling of these cases. You've made your point, and if you're not working as a team, the catastrophes will happen, and avulsion of the major vessels, especially the left main, will happen eventually. So I think the message here is clear that first, never to let your fellow operator to operate again any thing involving the metal of the left main, and the second that a teamwork is essential with two operators in these situations.
بالظبط كده يا فندم. الكي مسج بتاعتنا هو كان بس انا هوري حضراتكم الميكانيزم الارتر بيقفل ازاي، بس نو تايم. Take home message: full deployment of new and old stent before passage through it is mandatory. Avoid single guide snaring in case of stent caught stent complication. Teamwork is the key for success in such complication management. لما الستنت تتمسك في ستنت تانية، اخر حاجه تفكر فيها ان انت تشد جامد قوي عشان ما تخسرش السيستم. You can snare it, you can deploy it, you can crush it, free it by balloon زي ما احنا بنعمل في الواير بتاع الروتا. ممكن تقطع البروكسيمال هاب بتاعها وتخش عليه بالجايد اكستنشن لحد ما تعمل لها فريز، انما ما تسيبهاش تبقى فري كده في الكورونري. And thank you.
Thank you so much. It's my pleasure to present Professor Mohammed Zahran, Professor of Ain Shams University, and he will talk to us about a very interesting topic. As usual, I think Dr. Zahran will also show us a very interesting case. Thank you, Dr. Zahran, for coming. Coronary intervention case scenario, decision making. Fadal.
Thanks a lot, dear chairpersons. I would like to congratulate and thank Professor Magdi Abhamid and the whole cardiology department at Cairo University for this really high-grade conference and their kind invitation. It's always a pleasure for me to be with my brothers here, Walid and Karim and Samih Al-Affas and all of them. So this was a 58 years old gentleman. He's hypertensive, and Hisham Baha and Haitham Suleiman. 58 years old gentleman, hypertensive smoker, with a past history of primary PCI for an inferior STEMI 1 month before the culprit procedure, during which the coronary angiography showed a distal left main trifurcation involving the ostium and the proximal LED and LCX, and for heart team discussion. So this is the primary PCI. It was a right radial approach for an inferior STEMI, and you can see there is a thrombotic occlusion at the bifurcation of the distal RCA beyond the PL branch, and this was the left system showing a distal left main and a proximal LAD and LCX with a high OM like a ramus branch. At the primary PCI procedure, the patient had an inferior STEMI, so we passed a wire, we passed a balloon, and after that we inflated a 2.75 by 22 millimeter stent, and this was the final outcome upon the primary PCI. So then the patient was referred for a heart team discussion, for which we did the syntax score for this patient. This is the online syntax score. We have a left main, a proximal LAD, a proximal LCX. We do not have a CTO. We have a trifurcation with involving the LAD and the LCX. And as you see, the rest of the points. And this is the calculated syntax score of this patient to be 25. In the intermediate tertile, actually, the MACE by syntax score is 36% for PCI by Texas and 26% for Cabbage, with a p-value of 0.08, which is non-significant, which indicates that both maneuvers in this patient, if you put a Texas stent and you're not putting a Texas stent nowadays, would be nearly of no difference statistically. So after the informed discussion with the family, the decision after 1 month was to perform the PCI procedure. So the toolbox preparation included a 7 French EBU guiding catheter. We need 3 wires to wire this trifurcation properly. We will perform an IVUS and take care that you will perform an IVUS with 3 wires inside the guiding catheter. So you need a little bit slender IVUS. You have the IVUS from Boston and you have the IVUS from Volcano Philips. The IVUS from Boston is a 0.5 French, slimmer than that from Volcano. So we use the one from Boston so the 7 French catheter can accommodate the 3 wires as well as the IVUS catheter. So we checked the stent that we put 1 month earlier. The stent was patent and the bifurcation distally was free. And this is the 7 French EBU. As you can see here, the distal left main and the ostial LAD, LCX, and OM. We passed the 3 run-through floppy wires. And this is the Boston IVUS run to the LAD and the IVUS run to the LCX. And this is the IVUS. So the value of the IVUS in this case is for proper sizing of the vessel. You need to see the atheroma and the plaque burden, and you need to see the extent. For me, the most important was the sizing and the extent. As the IVUS moves proximally, this is an automated IVUS. So as the IVUS moves proximally, you see that the plaque burden is more and more until you reach near the ostium of the LAD and the left main. You will see how big is the plaque burden, and this is the other wire appearing here, and this is the guiding catheter. So this is the measurements. This is the mid segment of the LAD. The size of the vessel is nearly 3.2 millimeter, and the plaque burden is up to 74%. And this is the left main. You have a 5 millimeter left main, so you need to know that you will perform a pot by a 5 millimeter. And this is the proximal LAD and the left main. So this is the IVUS of the LCX, the second run for the LCX. And as you can see that the size of the LCX is 3.5 millimeters. So you need to put a 3.5 millimeter stent for the LCX, maybe a 4 millimeter stent for the LAD, expanded to 5 for the left main. So this is the data that you need to get from the IVUS. So the technique we used was the nano decay crush technique. We passed the stent to the circumflex, and then we inflated the stent. We crushed the stent with the balloon in the LAD. So this is the stent in the circ, the balloon in the LAD, inflating the stent in the circ, and then crushing with the balloon in the LAD, and then withdrawing all the system out of the circumflex before you make your crush. So this is the crush. And then you rewire because you need to make the first kiss. And here you make the first kiss. with 3.5 millimeter balloons for the LED and the LCX. And then I'm checking the high OM. The high OM is patent, so I can take out the third wire and I will perform a bifurcation between the LED and the LCX. So I'm taking out the wire. This is a 4 millimeter by 48 Zion stent for the left main LED to cover the whole atheroma. And then you will do the pot by the 5 millimeter stent, adjusting the balloon exactly at the carina, the distal point. And this is after the pot. Now you need to rewire to the circumflex, and you withdraw the jailed wire, and then you perform the kissing. This is the second kiss. And then you will perform the final pot with the same 5 millimeter balloon. So this is all the steps of the DK crush, and this is the outcome. You have the IVUS probe, so you will make the final IVUS run for the LED and for the LCX to confirm that everything is going on okay and all the stents are opposed. This is the two IVUSes running together. On the right side is the circ, and on the left side is the LED. And then you will see when the second wire appears in the both images that you are inside the left main, and you can see that the left main will be very properly expanded and very properly opposed. In this LCX view now the left main is apparent, and in the LED after a few frames this is the distal left main, this is the wire of the circumflex, and this is the left main. Take out your wires, take your final angio in a caudal view and in a cranial view, and thank you. It was not so complex, I was just step by step for education
Very
with an
illustrative.
intracoronary imaging and so on.
Extremely illustrative, yani. I think all the steps you went through, all the steps smoothly as you always do, and very good outcome. Thank you so much.
Thanks a lot.
I think we move on for our next speaker, Dr. Samih. تفضل. Okay, so
The pleasure is always mine علشان أقدم صديقي العزيز دكتور باسم عبد الحميد رفيق السلاح والكفاح. نتزاملنا الفترة لا بأس بها في مصنع الرجال مستشفى كوبري القبة العسكري. و knowing the level of intervention اللي بيتم هناك متوقع إن شاء الله أكيد حالة متميزة جدا. سيادة اللواء اتفضل دكتور باسم.
بسم الله الرحمن الرحيم. بسم الله الرحمن الرحيم. It's my great pleasure to attend the قصر العيني conference, which I really enjoy to return back to my home القصر العيني واسم القلب طبعا. بسم الله الرحمن الرحيم. دي case presentation. A male patient 60 years old, hypertensive, not diabetic, with no history of previous cardiac troubles, presented to our CCU with chest pain related to mild effort. His ECG was normal, enzymes were negative, good systolic function with anterior wall hypokinesia, and the coronary angiography was decided. And we can see that there is a total LED, a big diagonal branch with ostial lesion, normal mild atherosclerotic circ, and this is the cranial view, a faint distal LED filling antegradely. And the right was normal, giving retrograde to the LED. So, what is the decision? Of course, we do the CTO for the LED. The main problem is there is some sort of difficulty here because there is a lesion at the ostial diagonal, which is a big branch at the site of the total occlusion. So we used the guiding XP 3.567 French, and we cannot see the knob of the LED, so we tried to negotiate first antegradely. If failed, we will shift to the retrograde. We used the Caraval and use a run-through floppy wire in order to reach the site, but it reached to the site of occlusion and stopped. Escalation of the wire, we first change it to the Fielder XT in order to see the micro channel. Sometimes there is a channel we cannot see, but it failed, and we shifted to the Gaia second. And the Gaia second succeeded to cross the CTO and reach. There is a faint antigrade. We didn't inject. We were ready to give the retrograde injection, but it was faint. So we exchanged the wire with the floppy wire. This is a balloon. BTCA for the LED, 1.5 balloon by 15. And this is the end result. The LED looks small. We gave nitrates, stop or continue to predilate. We decided this is the LED. It's thin, atherosclerotic. Just to do the PCI for the big diagonal or continue to the LED, we decided to continue. We're using a bigger balloon, 2015. And this is the control and geography, it's better. Dilatation to BTCA for the distal LED, and this is the end result. What about the technique here? Just one stent technique or the two stent technique. We have an atherosclerotic LED. We have an ostial big diagonal. So what can do? It's two stent technique. I decided to use two stent technique. Regarding the clot technique, there is a complete difference between the main vessel and the side branch. The angle didn't allow us to use T-stenting, so the mini crush was my option. The same, it's steps like my dear friend Zahran, the same steps. Just PCO of the diagonal ostium, and this is the control and geography. We use IVAS in order to reach the size of the LED. I want to use to crush the stent. I want to use 1-to-1 balloon. So we used the IVAS, and it was the LED was 3.0 at this site. So we used 3.0 balloon in the NC in the LED and 3.0 24 balloon in the diagonal branch. This is the cranial view. And this is deployment of the diagonal stent. Removal all the wire and in the diagonal, leaving the balloon and the LED. And now we are crushing the stent of the diagonal. And this is the control and geography. I didn't do a DK crush. This is a mini crush, just a mini crush. This is the LED stent, 3033. From the ostial LED. And this is the control and geography. Now we should recross to the diagonal, do the final kissing. First, do pot for the proximal part of the LED stent by 3.25 part 12. Crossing using a pilot 50 wire to the diagonal branch. And using 1.5 balloon for the struts of the diagonal. Kissing. And finally pot for the proximal part of the LED. And this is the final result. take-home message. Starting with C2A intervention may be suitable for most of the patients with multiple lesions. Recent advances in instruments of intervention can solve many difficulties with complex lesions. Thank you.
Thank you so much, Dr. Basim. Great as usual. We have some questions here. First question is why we didn't do a contralateral injection from the start if there is an ambiguous cap in the LAD and the LAD is supplied by a big collateral from the right coronary. It would be easy. And the second, let me say the group of questions because they are related to each other. If we have an IVUS on board, which is the second option, is to put a wire inside the big diagonal and decide where to poke the cap of the LAD guided by IVUS. So, and third, what was the IVUS image of the left main? The left main angiographically seems not healthy. So, was it a significant plaque in the left main or not by the IVUS?
Okay. First of all, we did retrograde injection at the first, but the flow was not encouraging us because, as we see in the diagnostic, the LAD was diseased, so the retrograde didn't reach to the site of the occlusion. So after trials, it didn't give us data in order to push the wire. Regarding the retrograde, we can see in the diagnostic, it reaches, because the LAD was diseased and there was a lesion distally, it was not reaching to the site of the total occlusion. First of all. Second, regarding the using of the IVUS to enter the CTO cap, it's an escalation. I tried first the wire and it passed. If I failed, I was going to shift to the IVUS, but as a teaching lesson, I don't like to complicate, not to use we have an IVUS. I tried the wire first and the wire passed. So I use the IVUS just here to see the size of the LAD because it looks diseased all over.
Regarding the left main?
Left main, it was non-significant.
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 This is very important. Imaging is extremely important, as you said. Thank you so much for presenting such a marvelous case. And I think now it's time for our last presenter, Dr. Ahmed Kamel. So may I present Dr. Ahmed Kamel, Vice Dean of National Heart Institute, Professor of Cardiology, and will be presenting a very interesting case as well. One of the things that is very important in bifurcation techniques, please do not remove your gear from your side branch until you make sure that everything is fine. You have to do a check injection for your side branch before crushing, because if you have a distal dissection, you should deal with it before withdrawing your gear. So please check your side branch. Professor.
مساء الخير. الاول طبعا بشكر الدكتور مجدي عبد الحميد واسم القلب في القصر العيني على الدعوه الكريمه، بقول لهم مبروك نجاح المؤتمر. الحقيقه قالوا لي خلص بسرعه، احنا ما عملناش وقت. فانا الاول طبعا انا مبسوط ان انا هنا النهارده معاكم مؤتمر القصر العيني. انا مش غريب على القصر العيني، انا خريج القصر العيني من شويه، مش كتير قوي يعني، يمكن سامح القفاص يعرف من كام سنه، مش من زمان قوي. So this is my case, PCI when you have no choice. لما تجبر انك تعمل PCI. This is my patient, 65 years old lady. She's a pharmacist, insulin-dependent diabetic, hypertensive, dyslipidemic, with previous stroke twice. أول مرة 2019، تاني مرة 2021. هي فبراير اللي فات presented to my clinic complaining of generalized edema and shortness of breathing. Her lab tests في نوفمبر 22 كانت unremarkable. رسم القلب بتاعها كانت جاية بيه من بره في short R waves في الشيست ليدز، والايكو كان مورينا ejection fraction of 35% وسيفير هايبوكاينيزيس في الميد والابيكال سيبتم والابيكس ومايلد مايترال انكومبتنس. الحقيقه قلت لها حضرتك محتاجه تعملي قسطره بس مش دلوقتي، احنا لسه مورمين وجسمنا يعني فيه ميه كتير. طيب نعمل شويه تحاليل كده وننزل الميه، ننزل الورم ونعمل كده قسطره. الحقيقه يعني ما فيش بعد 4-5 ايام جالها acute renal failure UTI، دخلت المستشفى. كانت اديمتس وديسنك، و دخلت عملت حوالي سيشنز 2 سيشنز اوف دايليسيس والحمد لله امبروفد ورينال فانكشنز اتحسنت وبدا اليورين اوتبوت يتحسن. قلت لها الحقيقه بصي بقى احنا مش هنعمل قسطره خلاص، الموضوع بتاعك ده بقى خطر واحنا يعني رينال امبيرمنت او رينال فيلير اكيوت رينال فيلير، لا احنا كده بقى عندنا ريسك فهنمشي ميديكال تريتمنت until we see what happens. الحقيقه اهلها تقبلوا الموضوع وقالوا خلاص اوكي هنمشي ميديكال تريتمنت ونشوف ايه الوضع، خايفين طبعا من السي ار اف والبيرمنت دياليسيس. روحت بيتها ما فيش اسبوع اسبوعين رجعت تاني المستشفى برضه سيفير شورتس اوف بريذنج واديما، ودخلت مستشفى خدت اي في دايريتكس. الحقيقه دكتور الكلى بتاعها في الاول كان قال لها لا مش هتاخدي خالص اي دايريتكس خالص ولا اي في ولا اورال، ده اللي خلاها تورم تاني وترجع المستشفى تاني. الحقيقه ساعتها كانت جايه وكان الكلاب بتاعها كويس لكن مورمه، خدنا اي في دايريتكس وبعد كده اولادها قالوا خلاص لازم نعمل قسطره احنا كده يعني بنضيع وقت. عملنا قسطره. الحقيقه انا طبعا كنت خايف، انا بعمل قسطره واحده لسه غاسله كده من اسبوعين، فده كان الانجيو بتاعها. الحقيقه يعني اعذروني على الباد كواليتي اوف ذا بيكتشرز. زي ما احنا شايفين هنا كده في ال اي دي مقفول بعد ماده دايجونال كبير، السي اكس كده في او ام كبير طالع، في ليجن يعني ممكن نختلف او نتفق عليها، يمكن الصور اللي بعد كده تبقى افضل شويه. هنا باين الاو ام يمكن الليجن بتاعته باينه، وباين ال اي دي اوكلودد، والاوستيوم بتاعه يعني شكله مش لطيف قوي. هنبص تاني في فيو اكتر افضل شويه، باين هنا شويه ال اي دي اوستيوم از سيفير ديزيزد، وبعد كده ادى سيبتال، وبعد كده ال اي دي توتال اكلودد، وفي ليجن في الاو ام فوكال ليجن. هنا الاوستيوم بتاع الليفت مين والديستال بارت اوف ذا ليفت مين والال اي دي توتال اكلودد. طيب كده كفايه ولا نشوف الرايت؟ طيب هنا باين قوي برضو ال اي دي اوستيوم، ده الرايت نوري بتاعها، في تو ليجنز في البروكسيمال والميد سيجمنت، في سيبتال كولاترالز كويسه قوي، ولكن يمكن ال اي دي ريتروجريدلي مش ظاهر كويس، هل في فلو ولا لا؟ قد نختلف او نتفق، لكن في سيبتال كولاترالز كويسه جدا. طيب at this point يعني مش عارف حضراتكم شايفين ايه. واحده مالتي فيسل ليفت مين توتال ال اي دي فانكشن 35%. is it a case for PCI or CABG؟ ممكن ناخد مين مع PCI ومين مع مين مع PCI؟ PCI.
بي سي اي يرفع ايده. بي سي اي
وكابج.
كابج يا جماعه.
طب فايابيليتي؟
انا بس عايز اكد على معلومه، يعني انه الكابج اما بيتعمل في عيان عنده رينال ديسفانكشن مش معناها انه مش هيحصل له على البامب انه رينال فيلير، بالعكس برضه ممكن يدخل في رينال ديسفانكشن. اوكي؟
يعني في معانا some factors يعني with PCI and others with CABG. طبعا هي left main multi vessel function اقل من 35 او 35 تقريبا، diabetic. اللي مع البي سي اي طبعا انها الفايبيليتي مش عارفينها، فانكشن 35% توتال ال اي دي، مش عارفين امتى حصل الاتاك، ال اي قفل امتى. بور فيلنج لل اي دي ريتروجريدلي، ممكن الجراح ممكن يرفض. مالتيبل كوموربيديتيز ست طبعا، اوبيز، توايس ستروك. الفاميلي والبيشنت الاثنين يعني وذ بي سي اي خايفين طبعا من الجراحه. طيب عملنا ايه؟ بعتها احمد عصفور مش موجود، بعتها له نعمل سي ام ار فور فايبيليتي. الحقيقه قال لي البيزل سيبتم كويس شغال ماشي حاله، لكن الميد والابيكال والابيكس مش لا سكار تيشو. في اللحظه دي قلنا خلاص يمكن الكابج هيبقى ريسكي جدا جدا، لكن البي سي اي يمكن تبقى افضل شويه. طبعا it will carry the risk of CIN، لكن let's go and do PCI. مين مع انه يتراي انه يفتح ال اي دي ويتراي ال اي دي، رغم ان السي ام ار قال ان هو الابيكال بارت بتاعته مش فايبل. يعني انا طبعا ايه حاولت او قلت لا، يعني خفت او كنت خايف قوي، كان صعب عليا ان انا اسيب ال اي دي والليفت مين واقول لا خلاص كده هشتغل ليفت مين تو سي اكس. حاولت الحقيقه افتح ال اي دي ويعني وذ ورك هورس واير، الحقيقه الواير عدى وكان يعني عدى في الترو اليومن، ويتشيكد ان هو في ال اي دي بروبر. وبعد كده عملنا بري دايلاتيشن للميد سيجمنت ال اي دي والاوستيوم عند ليجنال كانتايت في الاول، وبعدين ده كان شكل ال اي دي. يمكن ديستالي سيفيري ديزيزد، ولكن قلنا لا وي نوت ليف ات لايك ذس، وي ويل ستنت ذا ميد سيجمنت الحته اللي عند توتال اوكلوجن. Then we will treat the OM, then we may do left main bifurcation. دي ستنت في ال اي دي كانت اعتقد كانت 3 by 38، فتحنا التوتال اوكلوجن في ال اي دي، وبعد كده وي باست انذر واير عشان نعالج الاو ام. عملنا بيدراتيشن ببالونه، وبعد كده وي ستنتد ذا او ام with a 2.75 by 28 millimeters بالون stent sorry. وبعد كده we went through the left main bifurcation. الحقيقه يعني طبعا الديكي كراش عليه ايفيدنس كتير جدا وجايد لاينز وكده، ولكن في هذه الحاله الديكي كراش يعني ستيب وايز هيبقى طويل شويه. it will carry the risk of يعني more contrast volume use. فقلنا خلاص احنا we will يعني do it in a simple way، نعمل تاب افضل. طبعا بعد ما عملنا ستنت الاو ام we went through the left main. طبعا احنا عايزين نغطي البلاك اللي في الاوستيوم بتاع الليفت مين ونخش على ال اي دي ونعمل جود اوفرلاب. خدنا اكتر من فيو علشان نعمل كده كودال كرينيال. الحقيقه دي كانت 4O stent 4O by 38 covering the ostium of the left main to touching or overlapping with the mid LED stent. دي كانت 4O stent، وخدنا اكتر من فيو كودال اند كرينيال زي ما حضرتك شايفين. وهنا نفخنا لما اتاكدنا من البوزيشن بتاعنا، واضح هنا في ويست في الستنت اثناء الانفليشن. وده كان شكل ال LED بعد الاوستيوم تريتمنت. وهنا طبعا واضح السي اكس المين، واضح طبعا ان هو بينشد، هو اصلا من الاول ديزيزد وبعد كده بقى مور بينشد. فاحنا قلنا خلاص يعني it should be a two stent way. يعني احنا طبعا خدنا واير ال سي اكس عديناه في كان ده جيلد، عدناه في ال اي دي وسحبناه ودخلنا ثرو ذا ستنت في ال سي اكس تاني، وعملنا بعد كده بوت عشان نوسع الستنت ستراتس قدام ال سي اكس، وبعدين وسعنا الستراتس تاني ببالونه 2.5. وبعد كده هنا بدانا التاب تكنيك بتاعنا. يعني يمكن الناس بيعملوا التاب without parking a balloon in the main vessel. بحب دايما ابقى في الامان. فدي بالونه كانت 3O I think by 18 باركت في الليفت مين قدام الاوستيوم بتاع ال سي اكس عشان البالون الستنت سي اكس ما تنطش في ال دي تقفل الليفت مين او تعمل اي مشكله. we checked the position هنا some contrast وقلنا خلاص we'll go. نفخنا الاول البالونه بتاعه الليفت مين to the LED and then we deployed the stent at the ostium of the LCX, and then we pulled the stent balloon back and we did kissing. Then this was the result after kissing, and then I think we did the final pot. اختفى ما اعرفش راح فين، بس this was the final result after a kissing balloon inflation and a final pot. وبعد كده ده الكرينيال فيو. يمكن ال دي ديستالي ديزيزد، بس يمكن نأمل ان هو بعد كام شهر يمكن يعني يحصل امبروفمنت، ربنا يسهل. والار سي اي كانت ات واز فيري يعني فيري ايزي جوب. التكه الوحيده في التريك الوحيده في الار سي اي تيبس اند تريكس احمد محسن ان احنا استعملنا ان امبلتس رايت جايد مش جاتكنز رايت وايرنج اند بريدارتيشن اند تو ستنتس. استعملنا الحقيقه around 300 milliliters of contrast. And this was the final view. Thank you for your attention and ready for any discussion. هي الحلقه ما فيهاش تيك هوم مسجز خالص، ولكن يمكن فيها شويه ديبيت. مين هيعمل كابج، مين هيعمل بي سي اي، طب هتعمل بي سي اي تاخد انهي تكنيك، الليفت مين هتعمله ازاي، هتفتح ايدي ولا لا. كل ديات كانت يعني
ثانك يو فيري ماتش
debates.
دكتور احمد كامل. حلقه جميله جدا فيها لوت اوف سكيلز تيبس اند تريكس، لكن فعلا نختلف عليها. وي ثينك that you did much more than needed in such a case. Thank you very much دكتور احمد.
طيب احنا طبعا بعد الحلقه الجميله دي اللي قدمها الدكتور احمد والسيشن الهايل ده، خلاص كده نبقى جينا لنهايه اليوم. هناخد صوره جماعيه دلوقتي، وبعد كده هيبقى اللانش هيبقى اوبن بوفيه، وبعد كده هنكمل عشان الجالا دينر في فرقه وحاجات في سيربرايز يعني كلنا هنبقى موجودين. فناخد بقى الصوره دلوقتي، اتفضلوا.